Okay, so just to get the second online conference for approved social workers and their managers started, we're going to welcome Peter Toogood, who's Deputy Permanent Secretary in the Department of Health, to introduce the conference.
That's great, Gavin. Thank you very much. And good morning, everybody. For those of you who don't know me, as Gavin has said, my name's Peter Toogood, and I'm currently the Deputy Secretary for the Social Services Policy Group within the Department of Health. You're very welcome to the second annual online ASW conference. And personally, delighted to see so many of our ASWs, the line managers and the professional supervisors here. I think this certainly qualifies for one of the biggest Zoom meetings that I've attended over the past 2 years. But I'm very pleased to be opening your conference this morning, because at the outset of proceedings today, I do want to put on record my sincere thanks and appreciation for the work that you all do. A lot of my work over the past 18 months has been in the area of mental health policy. That includes the implementation of the Mental Capacity Act. And through that work, that's highlighted to me the valuable role that you all play. It certainly exposed me to something that I wasn't previously familiar with. But having sight of the work that you do has certainly made me very proud of the service that our ASWs provide. Social work often finds itself in complex and challenging places, and I think that is particularly true for our ASWs. ASW practice is located in that tricky place where you have to find a path through the many considerations of risk, rights, the use of power, duties to protect, and respecting autonomy. So it's not an easy task, and I know, and I've had experience of it being lonely work. I know that it's highly stressful and that you often have to face into fraught, charged, and sometimes risky situations. So while your role is not an easy one, it is a particularly important one. ASWs are generally involved at a point of crisis in someone's life, at a time when they are particularly vulnerable and at a time of great distress. And ASWs need to respond with the right knowledge and skills, and with compassion and respect. And there are many strengths of our ASW service here in Northern Ireland. We have an excellent regional training programme for ASWs. And yes, I understand it's a very demanding one, but it is producing ASWs who are knowledgeable, skillful, and committed to rights-based ASW practice. We're also lucky to have some excellent leaders of ASW practice across Northern Ireland, both in informal and also formal leadership roles. However, I'm not saying everything's rosy, because I know it's not. I recognise that our ASW service is under significant pressure, and that you are all under significant pressure in trying to keep things going. I know that there aren't enough of you, and there isn't always enough of the right sort of support that you need. I also understand that as ASWs, you often end up managing the pressures created by systemic and capacity problems elsewhere. When there isn't an acute mental health bed to be found, which is often the case right now with occupancy levels frequently in excess of 100%, it's you who has to provide the support for the person and their family in the long hours of waiting to try and find a bed. It's you who has to support the person who needs to travel a long distance in the middle of the night to receive the treatment they need. And it's you who has to negotiate with GPs, the ambulance service, and the PSNI, all of whom are facing their own pressures. And it's you that needs to find a way to bring all those services together. So we are facing unprecedented challenges across mental health and all of our social work services at present. And we are struggling with significant staff recruitment and retention issues. COVID has also had a profound impact on our society, and the pressures of that are clearly seen in the need for mental health and ASW services. So I do acknowledge all of this. It is a tricky and challenging environment within which we're working, and I know that we need to improve that situation. So that's why there are significant programs of work underway which will collectively help to improve our ASW service. The 10-year mental health strategy, the mental health workforce review, which I have in-depth knowledge of and experience of over the past 18 months, the reform of adult social care, safe staffing legislation and policy, and the developing learning disability service model are all relevant in this area. Work is progressing in that regard, and they will support the implementation of the revised ASW quality standards that were launched last year. So the department's intention in these standards that were launched last year is to provide a pathway to a much more stable, sustainable ASW service. It's about providing ASWs with increased support, and it's about strengthening ASW practice. And through the standards and through the ongoing body of work that I have outlined, we in the department will continue to support all of that in what is a challenging fiscal environment that we're facing into, in an environment where we have to fight strongly for resources. But our commitment in the department is to keep that focus on ASW, on mental health, and on the requirements of those services, and to work in taking those bodies of work forward in collaboration with you all. So one of the strengths of today is the opportunity for you all as ASWs to come together to learn and reflect on the complexities of ASW practice. And one of the most powerful ways of doing this is by looking both across and outside Northern Ireland to learn from others. So today I'm pleased to see that includes carers who have such an important voice to listen to when placing service users at the centre of our work. But I also see there are contributions from our Scottish, Irish and Australian counterparts, as well as colleagues from across the HSC and the universities here. So it's shaping up to be a really good day. It's a truly rich blend of knowledge, experience and learning all ahead of you today. So in closing, I'm not going to keep you much longer. I'm sure you're itching to get stuck into the meat of today's session. I'd just like to thank you again for the opportunity to open your conference today. It really was important for me to be here, to be able to do this. And before I go, I would like to thank you all again for the work that you do, genuinely, and for your dedication and for your commitment to the ASW role. It is greatly appreciated. And I really hope that you enjoy today. I hope it's a rewarding one, and that you all have an excellent time together. So thank you all very much, and I'll hand back to Gavin. Thank you.
Brilliant. Thanks very much, Peter, and congratulations on your new role. And just to take the opportunity to thank you for all of your leadership, especially on the development and implementation or initial implementation of the mental health strategy. I think that's a really extremely positive development. So yeah, so hopefully you'll, yes, I know you're still involved, but maybe not quite so directly, but thanks again. Okay, brilliant. That's a sort of great start to today. So our first presentation is from Professor Lisa Brophy, who's Professor of Social Work at La Trobe University in Melbourne. So some of you might remember that Lisa presented at our first conference, so it's great to see her back. And she's focusing on the sort of the law, policy, and practice framework in Victoria. But I would also encourage you to, when you get the chance, to also look at Lisa's other work broadly on sort of mental health social work, especially in terms of the effectiveness of services. It's extremely helpful. So thanks again for joining us, Lisa, and over to you. Let's see, we can see your presentation, Lisa, but we can't hear you yet.
Okay, can you hear me now?
Perfect. Perfect. Yeah.
Oh gosh, it's always the way. You're on mute. You were very kind not to say you're on mute, Lisa. Now, can you see my my big main slides, not my notes?
We can see your notes as well. Yeah.
Oh, you can see my notes as well. So I'm going to change that. Sorry about that.
No, not at all.
And how's that? Better?
That's it. Perfect. Perfect.
Okay. So thank you so much. And it's absolutely lovely to be here today, presenting to all of you. It's very lovely to be back with my Northern Ireland colleagues, and I feel privileged again to be sharing an international perspective with you all. And I hope to continue to engage in mutual exchange and learning. And thank you for the lovely introduction, Gavin. So it's important for me to say that I wish to acknowledge that during this event, I'm on the lands of the Wurundjeri people of the Kulin Nations, and who are the traditional custodians of their land, and pay my respects to Indigenous elders past, present and emerging, and extend this respect to any Indigenous participants who might have been joining us today. You never know who might be there with you. And I have to acknowledge that our land has never been ceded. So what can I do today is, what I want to do is introduce you to some important changes that we're making to mental health law and the service system in Victoria, and to discuss some of the drivers for innovation and change, and to consider the implications of the changes for system transformation, social workers and the people we work with. So just to place all of this in context for me, I'm part of the expert panel that was involved with the overhaul of the Mental Health and Wellbeing Act, which has now been passed by Parliament and will be fully implemented in September 2022. Actually, that should be September 2023. And this, the new Act will lay the foundations for a redesigned mental health system, and will have implications across a broad range of social work practice areas. So together this morning, I hope to introduce you to the proposed new Mental Health and Wellbeing Act, which was a key recommendation from a Royal Commission that we had in Victoria into our mental health system. And I should explain, as Gavin said, I've had a long-standing interest in practice and research at the interface of law and mental health. And I've got a particular interest in community treatment orders, the situation where people are required to comply with compulsory treatment in the community or otherwise be forcibly readmitted to hospital. And I think this is something you've avoided in Northern Ireland, but it's certainly now a feature of the mental health landscape in Victoria, and I understand in the rest of the UK. So I commenced my PhD in 2000. I had my first paper on this topic in 2003, and I've had another out this year. So it's been more than 20 years of investigating CTOs in Victoria, where we continue to have approximately 5,000 people on these orders. And the Royal Commission found that rate and duration, and also the duration of our community treatment orders in Victoria is just too high. And despite the aspirations that we had for our 2014 Mental Health Act, and the introduction of a new mental health tribunal to reduce compulsory treatment, we didn't necessarily see a great deal of change. So I think, you know, what I bring to this issue is my social work background, and also my perspective on this from a human rights and social justice point of view. And I know all of you are bringing that to your role as approved mental health social workers. But I also have to be very authentic about this, because I'm a member of the Mental Health Tribunal. I was a long-standing member of the Mental Health Review Board before that. But when we moved to having a tribunal in 2014, the tribunal had extended powers, and as a tribunal, we actually make orders. So we make compulsory orders, either inpatient treatment orders or community treatment orders. So I have to be actually quite authentic about the idea that while I've got a critical lens, I'm also actually really embedded in this issue. And so like a lot of social workers, I need to sit with the tension of acknowledging the power that I hold, while also holding my strong commitment to social justice and human rights. And I found that it's been very important to sustain a value-based, critical and evidence-informed perspective to help me navigate that journey in relation to the social control aspects of things that I do. So I'm finally going to talk to you about what some of the drivers of the reforms have been in Victoria, and we'll consider why and how some important developments are influencing the potential to reduce the use of coercive practices in Victoria and develop a system more strongly aligned with social justice and human rights. So you're probably all familiar with the UN Convention on the Rights of Persons with Disabilities, the international human rights instrument governing the rights of people with disabilities, especially in relation to how this is leading to considerable expectation that mental health law, policy and practice needs to be reconsidered with increased emphasis on human rights. And the influence of the CRPD is occurring in parallel with attempts to shift to a more recovery-orientated and trauma-informed and strengths-based practice. But we're finding that those two things are really kind of coming together, I think, and more the personal recovery paradigm is aligning itself with those human rights imperatives as well. The other issues there are legal capacity and supported decision-making, addressing power imbalances and shifting away from the dominance of the biomedical model and reducing the use of restrictive practices and coercive interventions. So the Royal Commission into Victoria's Mental Health Service has identified, though, that we really need to have considerable individual and systemic advocacy to actually work towards change. The Royal Commission really identified that there were a lot of competing discourses regarding how to intervene to improve mental health outcomes and increasing frustration with the reliance on the biomedical model. There's really increased interest now in psychosocial interventions and new practice models, but people were really interested in the evidence around those. And we found that despite a lot of good evidence, it's actually very hard to get those new models implemented. But we're pretty determined in Victoria to do more to align what we provide with what people want and need. So I think for me, two guiding forces have helped shape my thinking and work on these issues. And one is my commitment to my profession. The other is my profound belief that the use of compulsion and forced treatment is not benign. There are iatrogenic harms associated with coercion for people using mental health services and negative and unintended consequences for staff and the services they work in. And I'm really grateful to Kath Roper. She's a highly respected consumer academic here at the University of Melbourne, who really clearly articulated the impact of the use of coercion. So she says, if the state overrides my autonomy and bodily integrity, these are ethical wrongs, potentially with serious, multiple and ongoing consequences, and they are a matter for regret, regardless of justification or otherwise for compulsory treatment. So as Gavin said, my research has not only been in relation to CTOs, but I've also done related activities. So I've been looking at issues around locked wards, around reducing seclusion and restraint, exploring the impact of recovery-orientated practice training on reducing compulsory treatment. I've also been doing systematic reviews to look more at psychosocial interventions and how we can get more innovative models of care embedded into our service system. And I suppose what drives all of that is that I see a lot of our potential to have services that might reduce the use of coercion or our reliance on coercion still sitting on the margins of service delivery and not really central to what we're providing. So I think it's been really important to try and work at multiple sort of levels to think about how we're going to reduce the use of coercive practices and the reliance on compulsory treatment. But right now I feel more optimistic than I have for many years about the potential for reform in Victoria. There's just been so many important developments internationally and locally, and there seems to be so much more commitment to the idea that we're going to reduce these coercive practices. And these are some pretty strongly worded reports by the United Nations Special Rapporteur. I don't know whether you've all seen them before, but we've had, quite strong responses to these comments as well. But I think they've generated a kind of valuable interest in the competing discourses regarding how to intervene to improve mental health outcomes. And I think it's another driver for where do we find the evidence to support psychosocial interventions and new practice models, and get that further support for the demand to shift away from coercive and restrictive practices. And I think the other thing that's happening here is it's very important that we respect the voice of people with lived experience and ensure that people with lived experience are heard and respected and have opportunities to lead reform. So like I said, the UN Convention on the Rights of Persons with Disabilities, we don't have a lot of institutional care in Victoria. Our average length of stay in our acute inpatient units is as low as 7 days. A 10-day admission would be seen to be quite long. It's extraordinary, really, that we have these incredibly acute hospitals these days. But on the other hand, we have a lot of people in other kinds of congregate care. So we have a lot of people who are living in private residential facilities or people in secure extended care. So we still have a lot of concerns about those congregate care environments where people actually may have, even if they're voluntary, they may actually have minimal choices about whether they actually remain in those environments. And in relation, of course, to Article 12, ensuring people can express their values and preferences and have them respected and heard and exercise choice and control is a really important driver of our mental health legislation and practice as well in Victoria. So compulsion, who does it affect? I mean, it's really interesting for us. We've looked at the situation in Norway, where they've also had community treatment orders for an extended period of time. And it's similar to Australia. 75% of the patients have got schizophrenia spectrum disorders, and medication is the main form of treatment for over 93% of patients. And like I said, in Victoria, most compulsory treatment is via community treatment orders, and it's estimated that over 25% of consumers of community mental health services at any one time are on CTOs. So in other words, our case managers and social workers working in our mental health services need to be very familiar with working with people on compulsory orders for extended periods of time. Like I said, we've got one of the highest rates in the world of those compulsory orders, which we started using back in when they were introduced into our Mental Health Act in 1986. So we had a big spike in the use of community treatment orders in the mid-90s when we had a very significant deinstitutionalisation process. It's interesting because we've got high rates in other states that have been slower to take up community treatment orders, but all states in Australia now use community treatment orders. And what we see is high rates in some states, but that it does actually vary across the states. And it's interesting that in Norway, they also found that they've got high rates, but that actually varies in different parts of Norway. And that's been an area of interest of mine in relation to why do we see this variation. And I'll come to tell you a little bit more about that in the next slide. So publicly available data from Victoria reports that we see these differences in the percentage of people who are on community treatment orders depending on which service people are accessing. So the Alfred Health is one of our inner city services they've got this very high rate of people on community treatment orders. And then you go out to our eastern suburbs, a lower percentage, and then a very similar service not very far away, has even less people on community treatment orders. And what the driving factors that are underpinning this variance is really unclear, but we see the same variation in services in relation to their use of seclusion and restraint as well. So we've investigated that, and we have some services that use seclusion and restraint at very high levels, and then we have other services that don't use seclusion and restraint anywhere near as much. I'm going to check in now and just make sure that everybody can hear me and see the slides.
All good, Lisa, great, yep.
Great. So legislative change, like I said, we had this legislative change in 2014 and we were very excited about it. It's quite extraordinary that the government gave me a chance to go on the advisory group for our new Mental Health Act, because I was on the advisory group for the 2014 Act. And I had great aspirations for what we might achieve with that Act. And we didn't necessarily see the changes that we were hoping. So we've had to, in a way, go back to the drawing board to see what we can do with a new Act that might actually address some of these issues. Now, one of the interesting things that we're doing at the moment to actually support the new Act is doing some research. And one of my colleagues, Chris Maley, and I have inherited the job of looking at, well, if we want to try and reduce the use of community treatment orders, where is the evidence anywhere in the world where people have managed to do this? And what have they done? What have been the factors or that they've tried to implement to actually reduce the use of orders? And we've actually had a lot of difficulty in actually finding any jurisdictions that have actually set out to reduce their use of community treatment orders and actually tell people through peer-reviewed or grey literature how they did that. So that sets a very interesting challenge for us to actually try to do that here. So one way of thinking about this is that maybe we need to start thinking more about the social determinants. And if we address the social determinants of mental health, then maybe we can also address the social determinants that are sitting behind the use of compulsory treatment and coercive interventions. And I'm really grateful to ASW Arnie for this fantastic image and summary of the social determinants of mental health. I tend to use it a lot because I actually find it really, really useful. So if we understand the social determinants of mental health and its impacts on well-being, we begin to see the impact of stigma and discrimination, intersectional disadvantage and marginalisation, and some of the barriers to participation, access, inclusion and recovery. And I think we've seen worldwide an increased recognition of social determinants of mental health and how that might actually impact on the use of coercion and compulsory treatment. And I think addressing stigma and discrimination is going to be a really important aspect of dealing with these variations and trying to do what we can to reduce the use of compulsory treatment. And social determinants are intersectional, and inequities can be compounded or experienced disproportionately for different groups in the community. And I think that's also a factor here. So here's some of the interesting statistics that sit around, I think, the issues of social determinants. So in Victoria, well, in Australia more broadly, I should say, people from culturally and linguistically diverse backgrounds are at much greater risk of being overrepresented on compulsory orders. And that's Steve Kisley, one of our really good colleagues, psychiatrist and epidemiologist in Queensland, who's been doing these studies. And it was a student of his who then looked at more of this data and actually identified that patients requiring an interpreter were nearly 3 times more likely to be treated involuntarily. And that was in Queensland, which is a state north of us. But I think, you know, this could also be happening in our state in Victoria. The other thing is that there was a disproportionately impact on Aboriginal and Torres Strait Islander peoples in Queensland. So we saw more people from Aboriginal and Torres Strait Islander communities being on compulsory treatment. But we didn't see this in Western Australia or in Victoria. And then there were other jurisdictions in Australia that weren't even really collecting this data. So this is an interesting phenomenon, and we don't really know why it's a feature of some states of Australia and not a feature of others. But we also see high levels of post-traumatic stress disorder and other mental disorders among refugees and asylum seekers in Australia, and they too are disproportionately represented among the people who are subject to coercion and compulsory treatment. So poverty and inequality is likely to be an issue here as well. So Australia is a high income country, but unfortunately we've got increasing income inequality like a lot of other high income countries. And among the poorest 1/5 of Australians, we see that psychological distress at very high levels is overrepresented. And so if you're wealthy in Australia, you are much less likely to experience high levels of psychological distress. And this, I think, is one of the issues that could be intersecting with the use of compulsory treatment and coercion, because this relates to, actually, this was an investigation that was actually undertaken in the UK, but I think the rest of the world can actually benefit from this piece of work that looked at economic deprivation and found that economic deprivation on an individual level and at a population level, so if you're individually poor or you live in a poor neighbourhood, was associated with increasing the risk of involuntary hospitalisation. So poverty has a role here. Now, the other problem that we have in Victoria that may not be a feature of Northern Ireland, but certainly a feature that we have seen happening over time and an unintended consequence of the use of community treatment orders, is that the use of compulsion and forced treatment, even though we know that it's not benign and there are harms associated with coercion and unintended consequences for services and staff, as Kath so beautifully described before, we have situations where people seem to be put on community treatment orders to guarantee service delivery in the context of them being discharged from hospital. So you see this quote from some research that I did where the consultant had a very strong view that it was best to just put everybody on a community treatment order, and then there was an obligation on the community services that they had to take them and provide that continuity of care. So that's a very problematic way of dealing with problems associated with access to services and shortage of services, to actually set up a contract through a community treatment order. This person will be seen by the service. It's sort of like an insurance policy to make sure that someone gets followed up. But as you know, we've looked at, this isn't actually a benign thing to do, and actually being on a community treatment order could be adding trauma to that person's life. So some carers found that CTOs, so I should introduce this slide a little bit better. So what we often find is that people will say that it's important for carers that CTOs can often provide a buffer for carers and actually offer some support for the use of community treatment orders, and we certainly hear that on the tribunal. But what we found was that although some carers found CTOs provided much needed support and reduced the worry and uncertainty and helped avert the damaging effects of illness, it was at times a double-edged sword. So people were sometimes seeing it as the lesser of two evils. They were worried that they might be abandoned by services if the person wasn't on a community treatment order. But on the other hand, they sometimes didn't see good practice, or they too were very aware of the trauma that was associated with the person being on a community treatment order, and were very concerned about whether something better could be offered, or with more quality in terms of the kind of service delivery, a coercive intervention could actually be avoided. And for most of them, they felt that improved communication was one of the most important mechanisms for reform. And I won't read out that quote, I probably don't have time, but Tatiana was just talking about how difficult it can be if services aren't listening to people about their loved one. And that was sometimes why she would prefer that the person was on a community treatment order rather than feeling abandoned when the person was actually discharged from a community treatment order. So what we see in Victoria is the rhetoric of recovery-focused, strengths-based and trauma-informed practice, but the reality is an overstretched and time for illness and symptom and risk-focused service system. And this is a really nice piece from our the president of our mental health tribunal that really talks about the idea that we need to start rethinking issues of risk, and we need to envisage a partnership or relationship that involves negotiation and the sharing of risk, and that in fact we don't necessarily always need to be using a coercive intervention to actually be ensuring that someone has treatment, that we can actually be using our negotiation skills and perhaps at times being assertive or offering more intensive treatment while people are actually still voluntary. So the Royal Commission made 64 recommendations following 12,500 submissions. And as I said, found a depleted and under-resourced and fragmented and broken system, and had serious concerns about this overuse of compulsory treatment. Also identified this idea of moral injury for staff and the need for a more compassionate system-wide transformation, and really building services that are accessible and responsive to people's needs based on their rights and preferences, and moving from a crisis-driven to community-based care. And as I said, recommended a new Mental Health and Wellbeing Act. It's interesting that we extended to wellbeing. And I think we've all been thinking about what does wellbeing mean in this context. And the way I think about it is that what we're talking about is the idea that we're not just focused on people's mental health, we're not just focused on symptom reduction and mental health treatment. We're also talking about care and support that extends to them having a life within which they can flourish and are actually supported to have that good quality of life. And this is the purpose of the new Act. It will put the views and preferences of people living with mental illness or psychological distress at the forefront, promote good mental health and wellbeing, set a strong base for the system, provide more clarity about roles and responsibilities, and reflect a contemporary human rights practice, and ensure that services are more responsive to the needs of individuals, including our Aboriginal and Torres Strait Islander peoples, and those who have experienced trauma or violence, and those with intersecting or co-occurring needs. And reducing police intervention is something that's been seen to be really important. And I can only emphasise that in previous research that I've done, sometimes the degree to which people have actually experienced extreme distress by having police involvement has often not been recognised, and the Royal Commission has been determined to try and reduce the use of police intervention and move more to using emergency services, and also equipping staff to do more of that emergency intervention. And these are the new objectives and principles of the Mental Health and Wellbeing Act. So respecting and promoting people's rights, dignity and autonomy, providing access to a diverse mix of treatment, care and support. And you see this all the way through our new Mental Health Act, that it's talking about treatment, care and support. So that's sort of broadening out, which I think, as I say, is in line with this emphasis on wellbeing. The idea of ensuring that people have more role in decision-making, valuing lived experience, and some of those other issues that I've already raised. And recognising that people have specific gender-related safety needs and experiences, so moving to having more gender-specific wards is something that we're going to be working on. Responding to culturally safe and responsive care, offering that, and thinking about promoting the best interests of young people has actually been really important in our new Act as well. So with our new Act, compulsory treatment is seen to be a last resort and placing the least possible restriction on people's rights. And importantly, the Act is actually talking about how important it is to take any distress or harm that's actually associated with compulsory treatment into account, and making sure that all the other non-treatment options are being considered and excluded, and reducing the maximum duration of community treatment orders to 6 months. We're also going to introduce a new opt-out non-legal advocacy system, so everyone will have access to a non-legal advocate once they become a compulsory patient or have a temporary treatment order. And the new Act will ensure that people can connect with an advocate. We're going to try and improve the uptake of all our supported decision-making mechanisms like advanced statements, nominated persons, second opinions. We're going to try really hard to ensure that people's preferences are heard through all of those mechanisms. We're going to increase the opportunities for information sharing. And of course, that's always going to depend on the consumer giving consent or service user, depending on your preference in terms of that language. But that's going to be very important to enable families, carers and supporters, the ambulance system and those intersecting services like housing to gain access to information that they might need to provide good care and treatment. We've got a very ambitious plan to reduce seclusion and restraint over the next 10 years with the goal of elimination within 10 years. And we're also going to regulate chemical restraint. We've got a whole lot of new governance and oversight. So a whole lot of new management roles, including the Collaborative Centre for Mental Health and Wellbeing. And I'm delighted to have been appointed to the board of that new centre. I'm going to tell you a bit more about that in a moment. So we did do a consultation with the community about a lot of these changes. And it was interesting that we had a lot of positive responses about non-legal advocacy and supported decision-making, information sharing and governance and oversight, but still people are very concerned about whether we can actually eliminate seclusion and restraint. And generally across the community, there was a feeling that it's going to take a bit of time to get this right. And the opposing views really were about the possibility that we may not be able to achieve the elimination of seclusion and restraint without really carefully thinking about issues around staff safety and around improving the amount of resources that we have on wards. We also have problems about the design of our wards as well. So it really needs a significant level of reform to achieve that elimination of seclusion and restraint. So there was some important thinking, though, that came through about the importance of being trauma-informed, culturally safe and compassionate when it came to reducing seclusion and restraint. There's also the importance of embedding lived experience in the governance of all the new entities. And we saw that there's going to be a number of opportunities for people with lived experience to actually be involved in all these new structures. So we've got a new Act, but just almost. We've got an independent review that's actually going to look at our criteria. We decided after the consultation that it wasn't going to be possible to change our criteria and tighten our criteria for compulsory treatment. And at the moment, that sits with the idea that people have to have a mental illness, that mental illness requires treatment, that the person, there's the potential for serious deterioration in the person's health, or that there's the potential for harm to themselves or others, and there's no least restrictive option available. So they will remain our compulsory treatment criteria, but there's going to be a substantial review of that criteria over the next few years. So the Collaborative Centre, as I said, I've been appointed to the board of the Collaborative Centre, and that'll be a purpose-built facility that will bring together people with lived experience, together with researchers and experts, and we'll be conducting research, disseminating knowledge, and with the idea of really exploring those best possible outcomes for people living with mental illness. And people with lived experience will be central to everything we do. So what happens next? The Collaborative Centre will appoint industry and academic partners. We'll have a new Mental Health and Wellbeing Commission will be established. So that's going to be really important, and they will have extended powers. We'll implement the new Act across the rest of this year and into next year, with it commencing in September 2023. And we'll be looking for the outcome of that review. And then we've already suggested that we'll need to review our new Act within 5 to 7 years. And I think we really need to think about what's underpinning that variation in the use of community treatment orders. And we need to understand the nature and purpose of coercive treatment to reduce the use of CTOs. And we need to investigate and contextualise compulsion use across Australia. We need a fine-grained analysis of variation rates, not only across our different states, but within the states. And we need to know how to innovate and transform policy and practice in this area. And for social workers, how do we really take that step towards understanding and coping with the idea that not every risk can be predicted, controlled and managed? And I think social workers in Victoria, like a lot of other mental health practitioners, have got used to the idea that CTOs are part of our landscape, and that compulsory treatment is also necessary. And a lot of that is driven by people's concerns about risk. So how do we start changing some of that thinking? But I'm really aware that, even without orders, and it's been Jim Campbell and Gavin's work on this, some of which we've done together, that it's really important to also see that we don't want to transfer from using orders to using more subtle forms of coercion. We need to be able to think about actually moving away from coercion altogether and actually moving to a situation where, instead of focusing on best interests, we move to supported decision making. So I, as an academic and leading a social work school, I think about how we can prepare our students and graduates, and we really need them to be compassionate service providers who work in compassionate workplaces. Therefore, they need to go and expect those workplaces to be compassionate. They need to engage in co-design and co-production and work alongside people with lived experience. They need to think about how to be accountable to improve outcomes and experiences for the people who use services. They need to understand human rights and how to respect them. They need to think about how to deliver core functions of community mental health and wellbeing services in a way that does respect all of these principles that we've just talked about. And we also need to be thinking about suicide prevention, supporting people experiencing psychological distress that doesn't rely on coercion. And this is all where we might get more information and all these references that I've given you in case you'd like my slides. And I'm going to end the show, my slideshow there and stop sharing.
Great, Lisa. Thank you. That's very, very helpful to think about sort of the complexity of the issues involved, with your emphasis on the social determinants, and for us, sort of thinking ahead to the full implementation of the Mental Capacity Act, which will widen the scope of compulsory intervention, hopefully, obviously, sort of to promote people's rights and provide additional safeguards, but there are potential complexities in there, and some of the information we might need to be looking out for to understand those possible patterns ahead. So, Lisa, I'm aware it's sort of late where you are, so we won't have you for the whole day, but I suppose if you don't mind, we still have a few minutes if people would like to take the opportunity to ask you some questions.
Yes, well, I was zipping through because I think it's, you don't want to sit and listen to me for too long, but I'd be happy to go back to any of those slides if you had any questions or any further clarification that you need. I understand that I was talking about quite a different system, but I'm wondering whether some of the issues might also resonate.
Oh.
Thanks, Gavin. Lisa, can I just ask a wee bit about the journey that you're on between that best interest approach to assisted decision making what are the key things that we can do to support staff, to prepare them both culturally and mentally to make that transition so that we can get the best outcomes for service users?
It's interesting, isn't it? Because I think we're requiring people to step back from their strong beliefs that they do know what will be best for someone. And there's a lot of humility in that, isn't there? There's a lot of being able to actually really listen to what people are saying are their values and their preferences. And I think it can often be really hard in the moment where people are really hoping that they'll see a different outcome or that they can intervene. And it's very difficult for them to not jump into that best interests approach. And I think that's one of the reasons why we're sort of talking about these mechanisms for supported decision making. So where you have people who have been able to do, say, an advanced statement or an advanced directive, where they've been really clear about what their views and preferences are and how they want to be treated if they were in a crisis, for example, or what their preferences were in terms of how a service would respond or who should be involved, those kind of things. That's also where the non-legal advocates can also come in, to actually be someone who can provide that voice that actually enables the person's views and preferences to be heard. And again, for the staff member involved to be able to think, okay, how do I step back? How do I really listen to what this person wants? And how do I formulate a response that actually takes those views and preferences into account? I hope I'm answering your question.
Yes, that's really useful, Lisa. Thank you for that.
Yeah, but those mechanisms I think are really important. Nominated person, they're the kinds of things. I saw in the chat that there was a question about whether we have current non-legal advocacy. And I should have said that we actually have had non-legal advocacy since our 2014 Act, and we've actually been doing a lot of evaluation of that service and found that it's been highly effective and with high levels of satisfaction from consumers. But we haven't had the reach across all of the people who are admitted or subject to compulsory treatment. So that's why the Act has actually extended that, and the Victorian government is now committed to making sure that everyone has access to a non-legal advocate unless they opt out. So we've got another question there, I think.
Yeah. And Lisa, just before I ask Anya, there's also just a clarification in the chat to ask you to confirm that 7 days is the average length of stay, and 10 days would be viewed as a lengthy inpatient stay in Victoria. Well,
it may not be viewed as lengthy at 10 days, but I think some services have got averages of 10 days, some services have got averages of 7. We do, of course, have people who have much longer admissions than that, but I think I can't exactly tell you what our current average admission is, but it's usually hovering around those kinds of numbers, which is really short by comparison to other parts of the world.
Yeah, well, thank you.
So sometimes we talk about our inpatient services being like an intensive care version of mental health inpatient care, so with a heavy reliance on community treatment orders. Yep.
Anya?
Thanks, Gavin. Lisa, thanks a million for that presentation. It was fascinating, really interesting to sort of see the differences and the similarities, and very thought-provoking. Just picking up on one point you made in terms of, a tendency perhaps to use, a compulsory element, get access to services, and that, that really struck me. Because, I think in Northern Ireland, we have ever increasing thresholds, I think, in terms of access to services. So, it can be a sort of tricky route to go down. It also reminds me of what I think is largely previous practice now, but of the use of guardianship under our mental health order to facilitate discharge, I think, particularly from long-stay learning disability hospitals. Now, as I say, I think we've largely moved away from that, but I think it was the same sort of mindset, and also a bit of a, oh, just to be sure, you know, we should use guardianship, and I think it's really important for us to remember that, you know, what the sort of very strong message that you give is that the use of compulsory powers are not neutral, that they're harmful in themselves. So that was really important, and certainly for me to be reminded of that. Can I just check, you know, in terms of that particular psychiatrist, not him in particular, but or her in particular, but have you had any successes in moving away from that use of compulsion for either a bit more assurance or to access services?
Yeah, it's really so one of the things that I've noticed on the tribunal is that sometimes we see that this might be what's happening, and the service might be requesting this is just one example of a strategy around this, but I'm hoping that we can do better into the future. But the service might be asking for a 6-month or a 26-week order. And they're saying that that's going to be really important to make sure that the person goes, you know, safely is discharged from hospital and then is supported in the community and so forth. Now, that person, you know, we may be convinced that that person at this point in time can't be treated less restrictively, but we can predict sometimes on the tribunal that if those services are set in place in the community, then it may be that this person actually isn't going to need to be on an order for an extended period of time. So we frequently see now that the tribunal makes much shorter orders than what the service is actually requesting. And we may do that deliberately because we think it's actually important for this person to actually have the opportunity to be supported in the community and establish that a compulsory order actually isn't required. One of the worries about that I have is that if we just go with the length of the order that's possible in the circumstances, so if the person's in hospital, we could only make an order for 26 weeks. And under our old act, we could, if they were in the community, we could make it for 52 weeks. If we don't think carefully about that length of the order, then we can have a situation where people can be languishing on these orders for really long periods of time. And I know services don't like to hear that, but the statistics do tell us that a lot of the time, people are actually discharged from their orders just before they're due to come up to a tribunal hearing, or there's some attention that now needs to be given to whether this person needs to be on the order anymore or not. It's because there's going to be some kind of external review. So that's really problematic. And I think that's why we need to make sure that we tighten the length of these orders so that and that's all in the context of saying that this is not a benign situation, that this person could be being harmed by being on an order for an extended period of time. And it's also having an impact on the people around that person as well, the staff and even family and carers who may start thinking about this person in a very different way because they're subject to a compulsory order. There's all sorts of dynamics that are going on while someone's on a compulsory order. So yeah, keeping them shorter is actually one of the strategies that we've used. But I think what we would like to see is some of the post-discharge programs that we've started to introduce and see more of that. So one of those has been to have peer support workers actually support people make the transition home. And that's actually been found to be really successful when it's been evaluated. So when I talk about peer support workers, I hope everybody understands what I mean. They're people who share people's lived experience. They're employed in our services to provide services that are particularly focused on engaging with people and providing them with that kind of more practical support. And that's actually been seen to be a great way to transition people out of hospital home. And it could actually be one of the strategies we use to reduce coercion or reduce the use of orders.
It's really helpful, Lisa, I think. And, you know, there's lots of stuff in there that is very relevant to our own practice in Northern Ireland. So thank you.
We should really break in a moment. But Julie, do you want to ask Lisa while you have the opportunity?
Yeah, thanks, Gavin. I'm being very opportunistic. Thank you very much, Lisa. And that was really helpful to hear all of that. And I'm struck by some of the similarities, but also a bit around some of the differences as well. I mean, you talk very clearly about the inpatient system being almost a very small percentage, that kind of intensive care aspect of it. At the moment, we are dealing with huge unprecedented demand in terms of access to acute inpatient services, which is, as everyone in this call knows, is causing a huge amount of challenge for our ASW resource. I just would really like to pick your brains around how you were able to move that upstream to a more preventative kind of approach and a development of more community services. Do you have any hints and tips in terms of strategic drivers, opportunities? How did you do it?
Well, I don't think we've done it as well as we would have liked, because remember, you know, our commission just sort of talked about us having a broken system. So I think early in our deinstitutionalisation process, we were doing very well. And one of the really important things was probably about having assertive community treatment teams. And we have recently recommended that we rebuild our assertive community treatment teams and also look at the model that they're using in the Netherlands, which is the FAC teams, so the flexible assertive community treatment, and actually having fidelity to those models, really doing that work in the way that it was designed so that it actually has that effectiveness that has been established when it has that fidelity to the model. I think also some of the other opportunities we've had is to build really good subacute services. So we have something called PARCS, with Prevention and Recovery Care Services. We have them now in all of our area mental health services. And this is where we can actually extend people's stay that for 28 days. They're 10-bed units. They're actually offered in partnership with non-government agencies. So the non-government agency runs the show and the clinical services are just visitors. Now, somehow, the same people who tell us that inpatient services are dreadful will go to a park and tell us that they love it. You know, it's really interesting. They can maintain a much more home-like environment, much less focused on risk reduction, lots more coming and going, and they actually they share a lot of the same people. And what we find is that often by going to a park, people's trajectory actually changes and they're more likely to use subacute services in the future and they don't go down that acute path. So they're just some of the examples of some of the things that are actually helping to reduce that reliance on their inpatient units. Can I just say that thank you for raising the issue of the cost of living that's Amanda's put a thing in the chat. If you're on Twitter, I'm on Twitter, right? And I've seen some but Lewis Appleby on Twitter is a great person to follow. And he is so onto the issues in the UK and the degree to which the instability at the moment that you're facing. We're getting a bit of it in Australia, but probably not as extraordinary as what it is in the UK. The impact that is having on people's mental health and a high risk of suicide attached to that economic uncertainty is such an important issue and really an important one for social workers, I think, to be really aware of, because, you know, it's bounced off the long-standing austerity measures as well. And I think it's a really important issue.
Brilliant. Thanks again, Lisa, for joining us and especially for working so late. I appreciate it, and I'll put some links to some of the specific research and services you mentioned into the chat. Thanks again.
And what I'll do is I'll look up that where you can find that average length of stay, and I'll pop it in the chat for you.
Perfect, perfect. Okay, so we'll have the opportunity to take a break now, but if we could start again at 11, that would be great. Thanks, Lisa.
Thank you.
Thank you, Lisa.
Lovely to see you all.
Okay, well, maybe restart if that would be okay. So I'd just like to welcome and introduce Anya Flynn, who's the Director of the Decision Support Service in the Republic of Ireland. So it's brilliant that Anya's been able to join us, and I think there's a lot we can learn from the focus on support under the Decision Making Act in the South. So Anya, thanks again, and looking forward to your presentation.
Thank you very much, Gavin. So let me check if this works. Okay, in the hope that everybody is seeing that, thank you very much. Yes, pleasure to be with you. I have had some engagement with colleagues in Northern Ireland about our various mutual interests. So I have met with people in the courts, in health and in the Department of Justice, as well as Gavin. So I'm the Director of the Decision Support Service, which is a new service here that is established under the Assisted Decision Making Capacity Act. We don't have fusion legislation, so I don't have a direct involvement in mental health services, although the Decision Support Service is located within the Mental Health Commission. That's the home that was found for it. So in this presentation, I thought I just might give you an introduction, some of you may be already aware of it, of the key reforms which our Act introduces and particular issues that have arisen with implementation, because that has been quite a long journey. In case the accent confuses, I am from County Down, but I have always worked down here in Dublin. So our Act is the Assisted Decision Making Capacity Act, and it was finally signed into law after a really long journey at the end of 2015. But the journey continues because it hasn't yet been fully commenced. I think you have a similar process, so that when a big piece of amending legislation is enacted, it isn't necessarily brought fully to life and operationalised right away. And that has been true here. The Act did require a lot of infrastructural reform. And yet the journey continues because we are now in the process of enacting amending legislation. You might wonder why we're doing that before we've even got fully up and running. But the Assisted Decision Making Capacity Amendment Bill has the objective of introducing certain technical and procedural changes, which we hope will lead to better functioning of the Act and indeed of the Decision Support Service. So overall, it is an act to provide for the reform of the law relating to persons who require or may require assistance in exercising their decision-making capacity, whether immediately or in the future. And that in the future part refers to the fact that the Act incorporates also important tools for advanced planning, pardon me, by way of enduring power of attorney and advanced healthcare directive. So these are where we are currently, and from the point of view of supporting decision making, well, all that we have is antique legislation, the Lunacy Regulation Ireland Act of 1871, unbelievably from the time of Queen Victoria. And under that, the wards of court system continues to be administered until the new Act is fully ushered in. And under that Act, a person may be declared by the High Court to be of unsound mind and incapable of managing their person or their property, incapable of managing themselves or their affairs. So it is a form of plenary adult guardianship in effect. We have approximately 2,200 adult wards of court at present. The biggest single category would be older adults with one form of dementia or another, and people continue to be admitted to wardship at present. Often the applicant will be a family member. Sometimes it's our health service executive. In fact, I think they're the applicant or petitioner in an increasing number of applications for wardship, principally where there's some kind of safeguarding aspect to the application. So the other and the only other statutory mechanism that we have to deal with adults who lack the capacity to exercise the right to make decisions is the enduring power of attorney. We have had enduring powers of attorney since the Powers of Attorney Act of 1996. And under that piece of legislation, a donor may appoint an attorney to take their decisions for them in relation to financial affairs or personal care if they become incapable of doing so, mentally incapable, as that Act says, at a future point in their life. Relatively low take-up compared to, for example, England and Wales and Scotland. I think it has been increasing, and perhaps COVID prompted some increased uptake. Something like 1,350, 1,338, I understand, EPAs were registered in 2020. But throughout the whole lifetime of the Act, I think only 11,000 have been, which is quite a bit lower than you would see in neighbouring jurisdictions. But apart from wardship, apart from the enduring power of attorney, we don't really have anything else to support decision making. I know that the UN Convention on the Rights of Persons with Disabilities has been mentioned already by Lisa. So Ireland was an early signatory to the UN Convention back in 2007, but it took us until March of 2018 to ratify, and we haven't ratified the optional protocol yet. Article 12 of that convention, as I'm sure you know, is considered very much to be at the heart of the convention and states that persons with disabilities enjoy legal capacity on an equal basis with others in all aspects of life. And as you will know, disability is defined very broadly in that convention to include enduring mental health difficulties, for example. Legal capacity has been further defined in a document called General Comment 1, published by the UN Committee in 2014. Legal capacity means the entitlement to hold and to exercise rights. When Ireland ratified back in March of 18, it included a declaration and reservation in relation to substitute decision making. So the government stated that to the extent that Article 12 may be interpreted as requiring the elimination of any substitute decision-making arrangements, Ireland reserves the right to permit such arrangements in appropriate circumstances and subject to appropriate and effective safeguards, because in the new model introduced under this, the 2015 Act, there is still a top-tier court-authorised mechanism for support, which effectively, although it's not named as such in the Act, does amount to substitute decision-making. Incidentally, Ireland also entered a declaration and reservation in respect of involuntary mental health treatment, involuntary detention for mental health treatment, to say that if they were prohibited, if such arrangements were prohibited under the convention, then Ireland was nonetheless retaining those under its mental health legislation. Ireland has a dualist system, so that international agreements have the force of law to the extent determined by Parliament. In other words, not direct effect, but international instruments have to be incorporated into and consistent with domestic legislation. So Ireland published an initial state report around this time last year, committing to progressive realisation of compliance with the UN Convention, and the full implementation of the Assisted Decision-Making Capacity Act is considered to be key to that. There are various other pieces of legislation that certainly also need to be addressed. So in summary then, the key reforms which the Assisted Decision-Making Capacity Act has introduced are these. The Act abolishes that system of adult wardship under the 1871 Act, so there will be no new applications for anybody to be made a ward of court. There is amending legislation, as I've said, making its way through, and one of the amendments provides that if an application to bring somebody into wardship has been commenced, then it may proceed to conclusion post-commencement of the 2015 Act, but otherwise no new applications for anybody to be made a ward of court. The Act repeals an even older Act, unbelievably, the Marriage of Lunatics Act of 1811, which said that you couldn't get married if you were a ward of court, and that has been brought to life by way of aside. That came about partly by way of response to a constitutional challenge brought by a man who has an intellectual disability residing in residential services. And he was due to get married in the summer of 2019, and his wedding was injuncted the day before. And the service, supported by the man's family, commenced a petition to make him a ward of court, and he has been resisting that. and has in fact brought a constitutional challenge against the whole wardship framework, which is on hold at the moment to see how the state gets on with commencing the 2015 Act, but partly by way of response that commenced the repeal of this ancient 1811 Act, so that it's no longer true that a ward of court can't get married just by being a ward of court. And all those current wards of court, those 2,200 people that I mentioned, will be eligible immediately to bring an application to come out of wardship. And one way or another, all of that number has to be reached within 3 years of commencement and discharged from wardship. That's all being managed by the Office of Wards of Court. They may be found to be entitled to have their full autonomy and their property restored to them, or they may move over to one of the new supports offered under the Assisted Decision-Making Capacity Act. Otherwise, what the Act does is to put on a statutory basis a functional assessment of capacity. There are new guiding principles, largely informed by the language of the UN Convention, a new 3-tier framework for support, tools for advanced planning, and the Act establishes us, the decision support service, with our functions. So if we look first of all at how the Act treats the functional approach to capacity, and it says that capacity shall be assessed on the basis of ability to understand at the time that a decision is to be made, the nature and consequences of the decision in the context of available choices. So very much a time-specific and issue-specific test. What do you need to decide at the time that you need to decide it? And you can see here a contrast with that blunt instrument approach in wardship, which defines a person as being a person of unsound mind. So a very definite move away from that. What I think is notable about this conceptualization of capacity as well is the absence of any diagnostic criteria or threshold. So it was very deliberately devised as a non-medical test. And if you compare this to the Mental Capacity Act, England and Wales, for example, there's no reference to what might be the organic cause of a person's incapacity. So it isn't being linked to a defect or impairment in functioning of the mind or brain. Diagnosis actually doesn't matter. What matters is whether it is or anything is impacting on the person's ability to do the following: to understand the information relevant to the particular decision, to retain that information for long enough to make a voluntary choice, to weigh up and use the information, and to communicate a decision with appropriate assistance if necessary. So those tools for communication could include, for example, assistive technology, sign language, the interventions of a speech and language therapist, or perhaps just the support of the person who knows you best in your mode of communication. Those supports should be facilitated, and the fact that they are required is not an indication of a lack of capacity. Now, as I say, this is putting what is already the standard on a statutory footing, because this approach to capacity has been with us since 2008, when it was articulated by our High Court in a decision called Fitzpatrick. That was about a woman's ability to refuse a blood transfusion. She had suffered a postpartum hemorrhage, bloods had been administered, and then this was all ventilated in the High Court afterwards because she said she had validly objected to that on religious grounds. The memorable detail from the Fitzpatrick case is that in her notes, she had said, I don't need bloods because if I am given Coca-Cola and tomatoes, it will have the same beneficial effects. And that was interpreted by the court as evidence that she didn't understand information relevant to the decision, and evidence, therefore, that she didn't have the capacity validly to refuse a blood transfusion. Actually, I was involved back when I was in private practice as a solicitor in a case in which this test was applied, called McDonough. That one. That concerned a man who had undertaken a hunger strike in prison. And he was found actually to have capacity to have embarked on the hunger strike, even though it seemed like an unreasonable response to the conditions in the prison. He nonetheless understood all of the information relevant to the decision and understood the likely consequences of pursuing a hunger strike to its conclusion. And this test has already been adopted in the HSE Health Service Executive National Consent Policy and in Irish Medical Council guidelines. So the guiding principles under the Act include the following. We have the presumption of capacity put on a statutory basis, and that is already the standard at common law. so that any adult is presumed to have capacity unless and until the contrary is shown. And that means shown in that functional way. So that's with us already, but now put on a statutory basis. I should say that the Act applies to adults defined here to mean over 18. I know that accommodations are made for 16 and 17-year-olds in some other jurisdictions, and that's something that might happen in time, but relevant person for the purposes of our Act means over 18. A person must be supported to make their own decisions as far as possible. And I do think our Act is quite strong on that. If you think even about the quite wordy title of the Act, it's the Assisted Decision Making (Capacity) Act. And we often reference those brackets around capacity because it isn't fundamentally an act about assessing capacity or accessing consent. Primarily, this is supposed to be an act about supporting people as far as possible to make their own decisions autonomously. And an unwise decision doesn't mean that the person lacks capacity. It's not quite the same thing as a right to be unwise, but rather that wanting to do an unwise thing or having decided to do something that seems unwise doesn't mean that the person lacks capacity to decide to do it. The Act talks about the importance of minimal restriction of rights and freedom of action. And the importance of respect for dignity, bodily integrity, privacy, autonomy, and a person's right to control over their own financial affairs and property. There's an emphasis on permitting, encouraging, and facilitating participation in any intervention. And I've put this one in bold because it is considered kind of the golden thread through the Act. The importance of giving effect as far as practicable to a person's past and present will and preferences. At the same time, acting in good faith and for the benefit of the person. But what you don't see anywhere in our legislation is any reference to best interests. And I know that comes up all the time in other pieces of legislation and objectively would be considered quite a benign standard. But as you'll be aware, it has been very definitely rejected by the UN Committee for the Convention. So that the starting point is not objectively what do I think is good for a person, but what do they want? And that's you proceed from there. So these are the categories of decisions capable of being supported under our 2015 Act. So when you see the word decision in our legislation, it means the following. And they're broadly divided into property and affairs decisions and personal welfare decisions, all capable of being supported under the Act. On the property and affairs side, then there's anything really to do with owning, buying, selling property, applying for benefits, involvement in court proceedings, supporting other people financially if that's what the person has been accustomed to do. And then on the personal welfare side, which might be of more relevance to this audience, there are decisions around accommodation, education and training, access to social services, healthcare, including medical decision making, and then the very broad other matters relating to the relevant person's well-being. The Act does spell out certain exceptions so that decisions around placing a child for adoption, consent to sexual relationships, and a number of others spelled out in section 138 of the Act are specifically not decisions for the purposes of the new framework of supports. But as you can see, a lot is included, and people might well have decisions across both categories. For example, the sale of the family home in order to fund long-term care. So we have been very keen in all of our work promoting awareness of this Act to say this is an Act which applies across a huge range of settings, which is why we find ourselves speaking to really diverse stakeholders, legal and financial professionals, for example, to An Garda Síochána. We speak to social care providers, providers of disability services, healthcare professionals. In the last few weeks, we have spoken to major teaching hospitals, a residential service for older persons. I've spoken to the Banking and Payments Federation. This really is kind of the nature of the impacts of this Act. And this is the new support framework. So this is where we've been quite ambitious. The Act went through a really long evolution. Originally, it was going to be the Mental Capacity and Guardianship Act, but along the way, and with really good inputs from stakeholders, speaking from the perspective of disability rights in many cases, what was arrived at was a 3-tier framework for supports, so that supports are available, matched to a person's need, and always with the priority of the least interventionist approach. And I'll go through the tiers in turn. The decision-making assistant, in the middle you have the co-decision maker, and then at the top tier there is still, as I say, that route to court, a decision-making representative. There are eligibility criteria across all of these tiers of support, so that a person with certain previous convictions or a history of family court orders can't step into one of these roles. And if the person is in residential services, then the owner or registered provider or an employee of those services can't step into one of these roles. I think the legislators had the perception that there would be, the risk of a conflict of interest, and all have to apply those important guiding principles with that priority on giving effect to will and preferences. So briefly then, and at the lowest tier is the decision-making assistant. This appointment comes about instigated by the person who considers that his or her capacity is or may shortly be in question. So they are choosing somebody in a pre-existing relationship of trust who's going to assist them in their decision-making. It doesn't go as far as advising. In fact, that's one of the things to be changed in our amending legislation. It should be confined merely to assisting the person to obtain relevant information, explaining that information, ascertaining and helping the appointer to communicate their will and preferences, to make and express their decisions, and then helping to ensure that decisions are implemented. So thinking again about what the decision could be, it could be a decision about accessing healthcare services, including mental health services potentially. Importantly, no capacity assessment is required to enter into this kind of light touch support arrangement, and the appointer is still making their own decision. So they're just entitled to be part of the information sharing, to be in the room effectively, and to participate in those conversations where information is being conveyed. These arrangements then are notified to us, the decision support service, so that we can confirm that somebody genuinely is a decision-making assistant, but we don't hold them on a formal register in the same way that we do some of the other decision support arrangements. So there's quite a bit more then involved at the middle tier, and this is co-decision making. Again, though, the appointment comes about in the same way, so that the person who considers that his or her capacity is or may be in question, again, is choosing somebody in their life, somebody in that relationship of trust, and opting to make specified decisions jointly with them. Quite a bit more involved around procedural requirements when it comes to us for registration, so that formal capacity statements are required from medical or other healthcare professional prescribed by regulation. Healthcare professional, I'm not sure if it's true in the North, can include social work professionals. So they would be supplying a capacity statement to confirm that this is a person who has the capacity to enter into the co-decision making agreement, who needs assistance in respect of these named decisions, and together with their co-decision maker will have the capacity to make these specified decisions. So it's quite a nuanced assessment of capacity. And when all of those procedural requirements are satisfied and this co-decision making agreement is registered, we hold it then on a register which is searchable. It could be very important for a health or social care professional, again, to satisfy themselves that somebody presenting as a co-decision maker really is and the scope of their particular co-decision making agreement. Because the effect of registration then is that relevant decisions made otherwise than jointly are null and void. And just staying briefly with co-decision making agreements, the co-decision maker has what's called a duty of acquiescence under the Act. So we're often asked, well, what if the co-decision maker and their person disagree? Well, the co-decision maker has a duty to give way to what the person wants, unless the co-decision maker apprehends that serious harm is going to result. But that doesn't give them a right of override. Instead, they're effectively at a stalemate. The decision can't be made, and I would suggest it's back to us in the DSS to see what next steps might be, and we can provide guidance around that. We conduct periodic reviews in relation to how a co-decision making agreement is working. We have to consider whether that nature of the person's capacity remains a true evaluation of their capacity, and the co-decision maker keeps accounts and submits reports to us. We are very keen to say, and particularly to family carers who see themselves potentially stepping into one of these roles, that we would see ourselves as supporting the supporter. This is all quite new. Objectively, it's quite challenging to people. So we want to be able to support the supporter to do the best job that they can. But we do have a regulatory oversight function, and sometimes arrangements will go badly wrong. And in the worst kind of cases, there could be a risk of, abuse or people overstepping the mark. So we have to be there to carry out that supervision and can escalate to court in the event of non-compliance. And then moving there into the top tier, because Ireland has retained this model for substitute decision making, although I don't think the word substitute decision making appear in the Act. I think inescapably that is what it is, but those guiding principles never go away, and I'll say a little more about that. So this is our decision making representative who may be appointed following an application to the court, and that's now our circuit court. Wardship, as I've said, is largely administered, almost exclusively administered by our High Court, but these will be applications to our Circuit Court. And the idea of the Circuit Court is it's more regional, accessible and cost effective. Any person with a bona fide interest in the welfare of the relevant person may apply. So foreseeably, that's often going to be a family member or a service provider who moves the application, or the appointment of a decision-making representative could be as an outcome of that review process of our existing 2,200 wards of court. Effectively, the application is one to court under Part 5 to make a declaration about the person's capacity in specific matters. So thinking again about what a decision can mean, it could be a decision about healthcare interventions, about property, it could be about a large award of compensation, for example. The court is being asked to declare whether the person has capacity in that functional way to make the decisions that are set out in the application. And the court has to apply the guiding principles as well. The least interventionist approach. Would a lower tier support be sufficient? If the court makes that declaration that the person lacks capacity, that itself is subject to ongoing periodic review by the court. The court can make the decision for the person, and it might just do that where it's a once-off isolated type decision, for example, about surgery, or it may appoint a decision-making representative where a more enduring relationship of support is going to be required. But arriving at that decision, the court has to have regard to matters including the person's will and preferences, the desirability of preserving existing family relationships, and this audience will certainly know that family relationships can be a complex thing. There might be a conflict of interest. Family members may disagree about who's best placed to step into this formal role. The financial affairs that the decision concerns could be particularly complex. People may have very significant estates that need to be managed. So the court will consider the suitability of any proposed family member to step into that role and whether they're going to have access to separate expertise in acquitting that role. And if there is no suitable or willing DMR, the court can turn to us in the Decision Support Service. We have a panel of decision-making representatives that we have stood up during the past year. So they're drawn from a range of professional backgrounds. They're all members of regulated professions. So we have social workers among them. They account for, I think, 25% of the panel, the rest being legal professionals, healthcare professionals, and some drawn from financial services backgrounds. So they will be available to be nominated to the court, and the court can choose somebody from that panel to step into one of these roles. Again, what distinguishes this approach from the approach in wardship is that the order is specifically limited in time and scope. So it isn't go forth and make all of this person's decisions, but rather this is what you're authorised to do and authorised to do for this time. It may be that it's appropriate to appoint different decision-making representatives or more than one in relation to different decisions. And all of it has to be kept lively and under review, has to be kept agile so that you can go back to court at any time to seek a variation and discharge of the order. And that court order comes to us, like the middle tier one, comes to us and is held in a searchable register. So again, a professional being presented by somebody saying, I'm the decision-making representative here, authorised to make decisions, you can confirm that with us. So their authority is specifically taken from the court order. And even though they're an agent making decisions on behalf of the relevant person, they still have to have regard to those guiding principles and the importance of will and preferences. And we supervise how they perform. There are certain decisions that they can't take, and that's spelled out in the Act. So they can't make decisions about life-sustaining treatment. They can't prohibit contacts by the relevant person with another person. I was interested to see that in the Act. I was over in the Court of Protection in London early on, and a lot of its work seemed to be taken up with deputies, court-appointed deputies, who are a bit like decision-making representatives, prohibiting family members from contact with the person. And presumably, based on the debates that led up to our legislation, the decision was taken that that wasn't going to be in scope for a DMR to do. Also, our amendment bill that's making its way through removes any of the provisions relating to a DMR exercising restraint. There were parts in the Act that said that if they were going to exercise restraint, they had to report on that to the DSS. And we actually said that's no place to be putting in restraint provisions, and that we didn't want the Act to be read as being permissive of restraint. So they've actually been taken out of the Act. Planning ahead briefly, enduring powers of attorney, as I've said, already exist, and EPAs that people have already made under that 26-year-old Act are still valid. So as you may well know, when a person makes an enduring power of attorney, their capacity is fully intact, and they're appointing a trusted person who's going to take decisions for them in the future if necessary. And again, they will be supported by a formal capacity statement from a medical healthcare, which can include social care professional. What is different with this 2015 Act as compared to our older Act is that we will then supervise the performance of the enduring power of attorney. One of the changes that our amending Act brings about is that an enduring power of attorney won't include treatment decisions. That has been taken out, and treatment decisions will be exclusively within the remit of an advanced healthcare directive. We already have advanced healthcare directives, but the Act is putting these on a statutory basis. Treatment, as you'll know, is predicated fundamentally on consent, subject to exceptions, including under the mental health legislation in a very limited way. But what an advanced healthcare directive allows then is for a person to plan ahead and say, I'm going to be refusing certain treatments, and if I lack the capacity to say that for myself at a future point, then here is a legal document in which I am making my wishes clear, thereby enabling the person to be treated according to their will and preferences, and providing healthcare professionals and family members indeed with information about treatment choices. Here, a person may also appoint a designated healthcare representative as their agent under an advanced healthcare directive, really to ensure that the right people know that a person has an advanced healthcare directive and that it is being respected, so that a refusal of treatment is as effective as if it's being made contemporaneously in the present tense. And that can extend to life-sustaining treatment, provided the AHD document is sufficiently explicit. A person can't refuse basic care though, so you can't say in an advanced healthcare directive, if I'm not able to say this for myself in future, I don't want, for example, ordinary oral hydration or nutrition. An AHD document doesn't need to be registered to be a valid document, and where there's any doubt about whether it is a valid and applicable document, there is, if necessary, but not in every case, a route to court to decide. There are various protections from civil and criminal liability for a healthcare professional who doesn't know about your advanced healthcare directive, or on the other hand, treats an advanced healthcare directive as being valid when it turns out that, you know, it's the product of fraud or coercion, for example. There are exceptions contained in the Act, and these are the subject of some controversy, where the directive maker is detained under the Mental Health Act. So as you read our Act today, it says that if a person comes to be detained under our mental health legislation, then an AHD in which they are refusing mental health treatments is not valid for those purposes. So it's not to be read as a valid refusal of treatment. A refusal of physical health measures can be validly refused within an advanced healthcare directive, even if you're detained under the Mental Health Act. Now, this has been argued against as offending parity, and that would be the position of the DSS and the Mental Health Commission, that needs to be rectified. And there has been some retreat in the amending legislation, so that now if you're detained we have two grounds on which a person can be detained under the Mental Health Act: A, risk to yourself or others, or B, that you need treatment, that you're not going to get treatment unless you're detained, and being detained and receiving treatment is to your benefit. So if you're detained on those B grounds, no risk, then your AHD is still valid insofar as you're refusing mental health treatments. Now, we have said just allow people's advanced healthcare directives to be regarded as valid, notwithstanding that they are detained under the mental health legislation. Our own mental health legislation is undergoing a review, and there's a general scheme of heads of bill which has been before our Oireachtas since last year, and it's hoped that there will be various reforms introduced under the Mental Health Act, which mean that better access to this Assisted Decision-Making Capacity Act should be established even when a person is within the mental health service. We can discuss that further if you like. It's definitely complex and quite challenging as a theme. So was this next of kin, and what does it really mean? I don't know if it's true in Northern Ireland as well, but there is this really established but misplaced belief that the next of kin already gets to decide, that the spouse, the partner, the adult child of a parent who doesn't have decision-making capacity, or the parent of an adult child, already is a legally authorised decision maker, and that isn't true and never has been true. So it isn't as if this act that I'm speaking about takes anything away in that regard. But that can be quite challenging when you say it to family members who will sometimes say, I have always decided, and I am treated as if that is my role. I'm thinking about a case that I was consulted on when I was in practice, which concerned a man who was in residential services, living quite an independent life with lots of support, and his parents had always, in quotes, decided about everything. They had both died, and he needed root canal treatment, and the dentist, in absolute good faith, was trying to track down all of his siblings, and he had a very big family. She was also trying to find the one that nobody had heard of for 10 years to see if they were all signing off on his root canal treatment, which is fundamentally missing the point, in that they weren't authorised to consent anyway to his dental treatment. And also, she wasn't asking him. She wasn't applying a presumption of capacity. She wasn't supporting him in his autonomous decision making. And when fortunately that was carried out instead, he was well capable of consenting himself to the treatment, and happily that's what happened. But I've mentioned here the results of a survey which show how widespread this belief is, particularly on health grounds, that the close family member already gets to decide. They don't. They're relevant, but they're relevant from the point of view of being consulted in order to gain an understanding of what the person wanted, not because the family member is the authorised decision maker, absent any formal legal arrangement. So the Decision Support Service, that is us. It was going to be called the Office of Public Guardian. As I mentioned, this act went through a really long evolutionary process. And again, with the inputs into the debates of people coming from a rights background and an independent living background, it was argued that guardianship as a concept sounds particularly paternalistic and protectionist, and that a better name was the Decision Support Service. It's a bit challenging because nobody knows at first glance what it means, so we're constantly reintroducing ourselves. And we're established, as I say, within the Mental Health Commission. Our Mental Health Commission has, it takes its functions from the Mental Health Act, and they're quite distinct from what we do in the Decision Support Service. So our Mental Health Commission is responsible for the regulation and oversight of acute mental health services. Our approved centres where people can be detained are registered with the Mental Health Commission, and we're also responsible for the management of the mental health tribunals. And it's been a good home for the DSS because the Mental Health Commission has the experience of taking reforming legislation and building a service, but our functions are quite distinct under the 2015 Act. And those functions are, in summary, to promote awareness and confidence around the Act and information to the relevant person, the person whose capacity is or may be in question, and their decision supporters. We also have a function to provide information and guidance to public bodies, to various bodies on their interactions with relevant persons and their supporters, and to recommend organisational change to promote the exercise of capacity. And I've mentioned already how diverse our stakeholders are and how broad our engagement with them. We will have registers of those decision support arrangements. We have a function to investigate complaints about decision support arrangements. We will have that panel of decision-making representatives and also panels of general visitors and special visitors who will help us with our supervisory and investigative functions. Some of those panel members drawn from a social work background. We will be publishing codes of practice shortly. We have a particular international function as central authority for the purposes of the Hague Convention on the International Protection of Adults. And we have an ongoing function to report back to our ministers and make recommendations to ensure that the Act remains fit for purpose. So on the safeguarding side and in the context of investigations of complaints, we can investigate complaints against a decision supporter and a decision support arrangement. It could be that a service provider, it could be somebody working in a safeguarding capacity becomes aware that here is a decision supporter who has exercised fraud, coercion or undue influence to persuade their person to appoint them as their co-decision maker. Or it may be that something is going wrong in the performance of that, for example, co-decision making agreement. So broadly, it would involve a person acting outside the scope of the Act or acting outside the scope of the particular arrangement. And that can be escalated to us in the Decision Support Service, where we can commission those special or general visitors, summons witnesses, take up evidence, escalate to court where necessary. With the amendments to our Act, we'll be able to go in on an interim basis to suspend the person from acting on a temporary basis if real harm is going to result otherwise. And we can, where necessary, escalate for criminal investigation. The Act creates a number of criminal offences, which I hope prove to be a rarity. But again, as this audience knows, sometimes these support arrangements can turn out to be anything but supportive, and it may be necessary to involve the ordinary prosecuting authorities. We can conduct our own initiative investigations, and we have, importantly, the ability to resolve complaints informally, and I hope that we're able to do that more often than not. We are publishing codes of practice. There are 14 of them in total, including a general guidance code on supporting decision-making and assessing capacity. There are specific codes for healthcare professionals, which include social care, and guidance particularly in relation to working with somebody in the context of an advanced healthcare directive. So these codes came to us in draft form. Our National Disability Authority and a ministerial working group appointed within the Health Service Executive led out on the drafting of those codes with really important external expert groups. A code has this status: a person concerned shall have regard to a code of practice when performing any function under the Act in respect of which the code provides guidance. So breaching a code, if you are, for example, a social work professional, doesn't amount to anything giving rise to liability, but it's something that could be taken into consideration, for example, in regulatory proceedings by your registering body. So we conducted a public consultation on these codes of practice over 3 months, from November last year to February of this year, and got really good feedback from people who are going to have to work within the codes. So we've been able to incorporate that into revised drafts, and we hope to publish those when we know that the Act is a finished piece of work. We'll be able to go out with these codes, and we hope to do it before year end. I sometimes find it important to explain what the Decision Support Service doesn't do. So sometimes in other jurisdictions, offices a bit like ours are called the public guardian, as I've said, or public trustee, or both. Sometimes they have functions as the decision maker of last resort where there is nobody else, but we don't have that role. So we don't make decisions for people. We can't directly appoint your decision supporter for you. So we can't find you a decision-making assistant or a co-decision maker, for example. We won't, I'm glad to say, and this comes with one of the amendments, have a function to manage people's money and property. We aren't a provider of legal advice. And we don't act as a regulator of other professionals and services. I did find it important to say that sometimes to healthcare professionals. You have your own regulators and you're highly regulated, and the DSS doesn't have any function to take complaints about professionals or service providers. I think if somebody were to come to us and say, my GP, my disability service provider, is refusing to acknowledge that I have a co-decision maker, we'd get involved to ensure a good understanding of what a co-decision maker is and what this one in particular is authorised to do. to ensure that that conversation is happening in the way that it should. But we can't take a complaint, as I say, about that external body. So some of the challenges that we encounter, and I said we speak to a whole range of people who will be impacted by this Act, including, really importantly, potential users of the Act, also family carers who sometimes are apprehensive about what it might mean for them, and service providers, healthcare professionals, legal and financial professionals. And what they do say a lot is that it's complex legislation, and it really is. It's quite long. And I've been reading it for about 5 years more now, and it is not the most readable piece of legislation. So there's an inherent challenge with that. So we have a constant duty to try and simplify without losing meaning. And that comes with our duty to raise awareness and confidence across a range of sectors. I've mentioned already the importance of addressing that misunderstanding about the status of the next of kin. And the Act doesn't revise and reform all other pieces of legislation that are of relevance. So there is definitely a bundle of other pieces of legislation and policy that do need to be reworked to align with this Act. There's that important interface with safeguarding. Sometimes safeguarding and professionals will say, well, if we are to respect people's decisions all the time, if the unwise decision isn't evidence of a lack of capacity, what actually do we do to keep people safe? And that, I think, is kind of developing as a theme, and I see pockets of really good work happening around that, but it does sometimes seem intuitively challenging, I would agree. We have a problem in that protection of liberty safeguards have not been properly developed. They were going to be dropped into this Act as a separate, as a new section of it. Now the idea is that they're going to be developed as standalone legislation to be developed by our Department of Health, and good initial work had been done, and then COVID, and they are now returning to that theme, and I hope to see further work on protection of liberty safeguards imminently. There was quite an important Supreme Court case here a few years ago which said, look, there really is a void in our legal system where somebody is held in a living situation where they're under continuous supervision and control and not free to leave, but lacks the capacity to consent to it. We need a process there. The doctrine of necessity is short-term and will only take you so far, and some legal process is required. And what our Act has done is to acknowledge that our High Court can rely on inherent jurisdiction to fill the gap. Really not satisfactory, and we do need a separate framework around protection of liberty safeguards. I'm really interested to see what is happening where you are. There are resourcing implications across multiple sectors, the importance of training and equipping people to engage with this Act. And separately, it's a resourcing matter to ensure that costs aren't a barrier to the ordinary person seeking to avail of the Act. And there are the complexities that arise with the interface with mental health legislation. So quite a bit to contend with, but really good work happening, I'm certainly satisfied to say. And I won't go through all of these, but these are quotations taken from people who contributed to a book that we also participated in, published last year, Professional and Personal Perspectives on the Assisted Decision-Making Capacity Act. So to keep kind of our eyes on the prize, I like to refer to Mary and Damien O'Donovan's take on the Act. Damien has Down syndrome, lives with his mother, lives a really independent life, and he's really motivated by what the Act potentially might mean for him, and refers to it as his act of emancipation. So no pressure. I really hope we deliver for Damien and people like Damien. That, I think, is enough for me. There is plenty of information available on our website if it's of interest to this audience. And as I say, really interested to hear about developments north of the border. And I think, Gavin, that allows time for any questions that might have arisen. So I will stop sharing, and thank you very much.
Brilliant, Anya. Thanks very much. Yeah, no, we've got about 10 minutes, which is great. I think really important points in there. I think we share your concerns about the accessibility of the Act here. Assisted Support Service seems to be a much more progressive way to frame the sort of role and function of the public guardian, and it will hopefully really help us to sort of further consider how the support principle can be operationalised. And the design of your presentation is really impressive. But anyway, okay, so let's see. There may be already some questions, or anybody like to ask any questions. Let's check the chat here.
Stunned into silence. It's grand.
There is the recurring question about when, I suppose.
Oh, when? Well, yeah. No, I wish I had a definitive answer. The key dependency at the moment is the amending legislation. Now, that's the responsibility of our Department of Children, Equality, Disability, Integration and Youth. So it's been making its way through. It had been hoped that it would be finalised before the summer, and it had a return to the Seanad in September, and didn't finish out all its steps last month. It has to return to what we call our report stage in the Seanad and then back to the Dáil for sign off, and then we have to go through the formalities of the President's signature and the commencing legislation. And in the meantime, it's not just the DSS that needs to get ready. The courts have been doing their preparatory work as well. Obviously, a big new piece of work is coming their way, so they're mobilising around that. I really hope we see its commencement and that we're fully delivering for people very early in the new year. But I'm watching the space with as much interest as everybody else, and I'm going off to interrogate my department, in fact, this afternoon, to see if they've any update for me.
Oh, brilliant. That'll be great to see. I think Anya and then Phil.
Thanks, Gavin. Thanks very much, Anya, for a really interesting presentation again. Just lots of echoes and lots of things to think about and similar dilemmas, etc., etc. I had two questions, if I'm allowed to get two in one. Sure. So the first one was really about the role of social work in the decision support service, and are there particular things that you see social worker are likely to be particularly good at, or you would want them to particularly kind of step up to take on a particular role? So that sort of exploration. And I think you largely covered this, but the people who using our language would be deprived of their liberty currently. Is really nothing happening, or are some of them making their way to a court for inherent jurisdiction?
Yeah. So, Grant, thanks very much for that, Anya, whatever you're having. Yeah, I think social work will play a key role, and we do see quite a bit of social work professionals and pockets of really good work, which show that this cultural change that we often speak about here is really well underway. I think that social workers will be required to step up in certain areas. If we look at one of the specific ones, it's around where capacity statements are formally required in different sections of the Act to support particular decision support arrangements, because social work professionals are identified as one of the professions that can supply those statements. So a very definite move away from the idea that that was the preserve of medics. And I think that's where they will provide really good and valuable input. That kind of total view of a person's circumstances, I think, is something that social work is really trained for and likely to be very good at. Locating a person where they are, not just a diagnosis, looking at a total family situation, for example, as well. I think that could be very valuable. As I mentioned, some social workers have specifically applied for the role of panel member decision-making representative, and it was really encouraging, actually. We went through a long selection process, and I did find from speaking to candidates from a social work background, they really got it, actually. They had all of the language and all of the right instincts for what this Act's potential is, and that was really encouraging. I think as the Act is rolled out as well, that social workers may well be the person who connects the person with our service and with the Act, who's able to say, look, here's a situation where the supports of the Act could be required. So building that bridge and ensuring that somebody who perhaps isn't aware of what our Act offers is put in touch with us, so they're aware, look, you're somebody who might benefit from a decision-making assistant, a co-decision-making agreement, or whatever it might be. It may be that the social worker is the person who, or their particular service, sees a need for an application to court for that top tier of support if nothing else has sufficed. And then it could well be also the social worker who's involved with a particular person and or their family or service, who realises that perhaps an arrangement that has been put in place isn't actually going well, and needs to be rethought, whether by way of bringing the matter back before the court because a person's capacity isn't where it was, or because a complaint needs to be escalated to us. And your other question, Anya, on the deprivation of liberty, yeah, that gap persists, and I suppose it is sometimes filled currently by an application for wardship while we still have wardship. There hasn't been, because we have wardship, the inherent jurisdiction isn't typically relied on yet, because you shouldn't rely on inherent jurisdiction if there's an alternative statutory arrangement, and I suppose wardship offers that at the moment. I hope, as I say, that the deprivation of liberty, which we hope are called protection of liberty safeguards, are progressed quickly, because I think otherwise it'll end up being litigated again, I would see. So I do hope to see progress there with colleagues in the Department of Health, because it is a gap, I think, that persists at the moment. So I hope that answers your questions there. Thanks very much.
Thank you.
Gavin, is it Phil who
yeah.
has this question there?
Anya, thank you. And I want to pick up on Anya's second question, and that kind of like interface within the Mental Capacity Act that we have, and particularly around the deprivation of liberties. Because one of the tasks that the social workers and the approved social workers are challenged with is about the amount of weight that's put onto the person's special regard. So it's decisions that they would have made previously. And it's never black and white, because sometimes the care and treatment decisions roll into the situation where the person either needs to have specific treatment or care within the care home or their own home setting. So it'll be interesting to watch how your interface works out, because that's certainly something that we can see immediately. There are going to be challenges for us as we work our way forward. A special regard needs to be taken into consideration, even if it's not directly related to the deprivation of liberty. The care and treatment that they may receive in their place of residence because of the deprivation of liberty can have big implications for them. So it's more kind of like picking up on that more area for us to do. And it'll be interesting just to keep a wee eye on what you're doing down south to learn from it as we work our way forward. So,
I think so, yeah. It is interesting how different jurisdictions have tried to capture that importance of centering the person and their wishes in the decision-making process. And all what we come up with, as you know, is respect for past and present will and preferences. So you always try and work with the person in the present tense as well, supporting their decision-making as far as possible where they are. But yeah, lots to keep an eye on there. And actually what we do hope, I know we talk about keeping an eye on things and seeing how things evolve. I think it's really important that this is all kind of data driven. It's often we speak at the level of kind of policy or even philosophy in these things. Really important to capture lived experience in terms of numbers and statistics and people's voices. We hope to, and I hope we achieve this, to go back to people and say, okay, particularly if they were a ward previously, what is qualitatively different for you under this act? Have we been transformative? Has it been more of the same? Really to capture that, because my impression at an international level as well is that it is quite hard to get data actually about what these new initiatives achieve for people. And I'd like that to inform all that we do.
Yep, and raises the opportunity to align some of that data collection to facilitate comparison north and south, which would be great. Just a query from Anya about transfer between jurisdictions.
Oh yeah, that is interesting now. Some of that obviously happens already, being close neighbours, and I understand at the moment where it arises, specifically about transferring between facilities. Yeah, does that happen at the moment? I suspect it does, and I think where it does, it's managed under the wardship process, or kind of mutual recognition of court orders, possibly. I think what would be transformative there is potentially transformative there is the Hague Convention and the International Protection of Adults. Now, we will be automatically ratifying that. Well, there's a bit of a lead time. So once we commence our act within 3 months, we are fully signed up to the Hague Convention, but Northern Ireland isn't. Scotland is, England and Wales said they were going to, but haven't yet. So I'm not sure if there are any plans afoot there. It may be that if somebody transferred then across the border to us, that a whole new legislative arrangement here could be required. Yeah. But I think that the Hague Convention might have some potential there, but it might be case by case that arrangements need to be arrived at. So yeah, again, protection of liberty safeguards here being really important in that space. I sympathise with Amanda Burgess's observation about having to register with Carew following Brexit. I've heard of that actually from somebody in a border area who was applying to one of our panels. Yeah, and Carew has been going through a really long process to register social care workers actually as well. So yeah, my sympathies.
Thanks. Yeah, just to come back on the deprivation of liberty, it's kind of it's an issue that I think we're probably all grappling a little bit with, in terms of, right, what are the legalities of this? Can we do it legally in terms of, you know, a transfer? And yeah, I think, yeah, there's a lot of uncertainty for us around what you might actually have to do, and it sounds a bit like that probably is probably mirrored on the other side of the border as well. So it's just interesting to hear.
I think it will be case by case, and maybe things will be streamlined in future. I have been asked about quite specific cases that would fall into that category, in fact, and I think it will be case by case until there's some sort of properly defined process here and kind of mutuality of the two.
Thank you.
Brilliant, Anya. We should leave it there, and thanks again for
Not at all, real pleasure.
Oh, it's great, and all the very best with it. I mean, it really is an exciting development, I think, the Decision Support Service. So yeah.
Thanks so much. Thanks for having me, and I look forward to engaging again.
Brilliant.
Thank you all. Bye bye.
So the next presentation is focusing specifically on the role of the ASW in implementing the Mental Capacity Act. And presenters are, most of you, if not all of you, will know Phil already, but Phil Hughes, who's a professional advisor on the Mental Capacity Act for the Department of Health, and Janine Gordon, who's working on sort of Mental Capacity Act training and skills development in the Northern Trust. So Phil, it's over to you. Just to acknowledge, Phil has been working on the development of the Capacity Act since the beginning of the Bamford Review, so I think probably knows this process better than anyone. So it's great you're doing this, Phil. Thank you.
Okay, no problem, Gavin. And it's certainly been an uphill and downhill journey from we started work on the Bamford Review to try and develop better ways of working with service users who lack capacity. And we're now in the situation where we've got partial implementation of the Mental Capacity Act, and the focus is really in relation to the deprivation of liberty issues. Can I have the next slide, please? So Janine and I have no control over our slides at this stage, so they've been worked for us. So let's hope this works okay. Okay, so what we're going to look at just between now and lunchtime, and I know that people are probably getting a wee bit hungry and keen to get away off and get a sandwich, but maybe if you just took a minute to refocus yourself, stand up and sit down again. Isn't that what we kind of like talk about in the Leadership Centre, or turn around? Good, Claire, that's good to see you moving. So just shake yourselves for a couple of seconds and then we'll refocus and get into this. Louise, love that stretch. Okay, so we're going to look at the ASW rules specifically in relation to the Mental Capacity Act. The current challenges as we as social workers and approved social workers are faced with, and the impact that has on the service users and their nominated person. We'll spend some time looking at why approved social workers are key in the implementation of the Mental Capacity Act, and that will give us an opportunity to reflect on some of the work that Lisa mentioned earlier on, and the importance of the knowledge base and the skills that social workers and approved social workers bring to the table. And then we'll talk about next steps. Next slide, please. Okay, so the ASW specific rules, the first one's around the participation on the panel, and a number of you already work within your trust areas helping to man those panels. And the panels are made up of 3 different disciplines: a medical person, an approved social worker, and another healthcare professional. And all of those panel members have to be trained up to level 5 in the mandatory training that has been organised by the department. And there are no surprises that the chair of the panels are all right across the region approved social workers. And when we look at the knowledge and the skills that the approved social workers bring to the table, that gives us a very clear indication of they're the best person placed to manage that process, to help to address any challenges or issues that there are, but also to show very strong leadership in terms of driving forward the implementation of the legislation and ensuring that the panels are working towards standardisation of the application of the legislation right across the region. The second area is around extensions, and it's really good to see across the region that for a number of approved social workers, particularly who had the benefit of retiring early at 55, have come back into the system again to support that work. So we've got a significant amount of retired, really experienced approved social workers working across the region in all 5 trust areas to help specifically in relation to the extensions work. And the extension work really builds on the capacity assessment. So you have someone who's completed out the capacity assessment. It has to be a different person who will undertake the extension. So it gives an opportunity for another person to review the need for the deprivation of liberty in relation to that specific patient. And equally, we have 2 options. The first one is that an approved social worker who's involved in the care or treatment of the patient can be involved. And the second one is around someone who's designated by the managing authority in the hospital or the care home. There's about 97% of all of the extensions have been completed by approved social workers. Some other disciplines have contributed at times where we haven't been able to resource sufficient numbers of approved social worker, but the bulk of the work, and you'll see the numbers in a few minutes, the bulk of the work is carried out by approved social workers, working very closely alongside medical staff who will also make the medical assessment for those extensions. The third ASW specific role is around the short-term detention authorisations. So they must be an approved social worker, and that's the line that we start with, that you have to be an approved social worker. And we had an interim arrangement which was facilitated by Anya and the department to enable a number of staff, social work staff, who had a lot of experience in working within acute, but maybe didn't have sufficient experience within the mental capacity or the mental health order, to be trained up specifically to carry out that role as an interim arrangement until they were able to continue on their developmental journey and complete the approved social work course. The next area is around second opinions, and very similar to the mental health order. If the nominated person has got a challenge, or sorry, this dog's been really good all day, now he's going to start barking. So the second opinion is where the nominated person has got a reasonable objection as to what is happening to their relative. They don't want the person to be detained against their wishes. And in that situation, a second approved social worker will come and do a second assessment, an independent assessment. They'll work with the nominated person, they'll work with the patient, and they'll also collaborate and work with the other disciplines that are involved to make a decision as to whether or not they feel that that deprivation is needed. And then the fifth area, which I know was causing a lot of stress and strain right across the region at this stage, is in relation to warrants. We know that there have been across all 5 trust areas individual cases where ASWs have been trying to support patients to be conveyed into either hospital or into a care home when there's been a significant level of risk, and they've had to go through warrant situations without the formally approved warrants under the Mental Capacity Act. Debbie, who's on the call today, is working relentlessly hard in the background to try and get those forms finalised so that we can have them to work with. But the bigger challenge is actually the buy-in from the PSNI. So we need to continue to work in that joined up way with the other agencies that are involved in the conveyance processes. So when we get a warrant, that the constable on the ground with us knows exactly what their powers are under the Mental Capacity Act and help with that transfer into hospital. Next slide, please. So let's have a wee look at the activity in terms of what has been happening across the region. So from the 2nd of December 2019, we've had 8,826 applications, and just under 8,000 of those were authorised. So there's a gap between the number of applications that were made and the number that have been approved or authorised by the trust panels. A number of reasons for that. Initially, we were on a journey where we weren't always getting the right information onto the forms, and we were testing out the system in terms of trying to ensure that we had the right information on the applications so that the panel would be able to make a decision on those forms. And we didn't always get it right initially, so there was quite a few gaps in those kind of like first 6 months. And then the systems kind of balanced itself out, where there were very few applications that were made to panels that were refused. And that was because staff were being trained up, there was good supervision, good leadership across all of the 5 trust areas to help people through buddy systems and through coaching and mentoring, so they would build their own confidence and competence in the application process. Once we started then into the second phase of the implementation of the applications, we were sending applications to another trust panel, and that caused a wee bit of tension across the system, but also showed us that each of the trusts weren't using there was no standardized practice. They were reading the forms differently, and they were using slightly different thresholds. So again, we've got a number of forms that have been refused through applications that would have been approved within our own trust areas. And we're continuing to work on that to ensure that all 5 trusts fully understand the threshold that's used. After an application's been made, there's a safety network established that for those people who aren't able to make decisions as to whether or not a meeting or a review tribunal can take place, a referral is made into the Attorney General's office. And across the region, it's roughly sitting at about 72%. And we haven't really frayed off too much against that average. But what we do see across the regions is that some trusts are currently sitting up at the very high 80s or low 90s, and other trusts continue to be down overall around about 56 or 57%. We're trying to understand what the variances are across the trusts, and each of the trusts' Mental Capacity Act leads are working with their staff to try and bring that variance in the gap closer. And we're testing out the number of Form 7s that have been made, auditing them to try and see whether or not there's a variance in the application. The third stage is the Attorney General will make a decision as to whether or not they can make a decision that this person needs to have the DOL in place and there's no need for a further review tribunal opinion. But on 40% of the applications, the referral is made through to the review tribunal, and what that results in is either a paper hearing or an oral hearing. And thankfully, we've got very few oral hearings overall, but each of those requires a Rule 6 report. And I know across the region that the majority of those Rule 6 reports that are coming through are being carried out, the big percentage again, by approved social workers and social work staff. So it's additional pressure on what's already pressurised services across each of the trust areas. The next area to focus on is extensions. And if you remember from the first slide, the majority of those extensions, again, are being carried out by approved social workers. And we've got 6,500 across the region, with 68%, a much higher percent going through to the Attorney General's office. But the good thing is that at that stage, the Attorney General's office is able to make a decision on the majority of those cases that they don't need to go through for either a paper or an oral hearing at the review tribunal. And that is down to the high quality information that the social workers and approved social workers are putting into the Form 7. They're giving the Attorney General the right information to make the decisions, which reduces the need then for Rule 6s or for further information at a later stage. Next slide, please. Third area then is around the short-term detention authorisations, and the majority of the short-term detention authorisations occur within the acute setting. We've had about 7 cases across the region that commenced within the communities. The first one being led by the consultant psychiatrist up in the Macrofelt mental health team, who kind of broke the ground for other people because people were reluctantly thinking about what will we do. She very ably brought her team together, was able to look at the capacity assessment of the person, look at the risks that they were being placed at, and worked with her team to ensure that the service user remained central to the decision-making, whilst ensuring that the risks were adhered to and that the conveyance and all of those other challenges worked through. So it was, for Northern Ireland, our first case, which was really well led by that consultant and her team. You will see a big gap between the work started and the number that are authorised, just over 1,500 authorisations out of that 4,500. And there's lots of reasons for this. Some are good reasons, and some of it is because the person could have a delirium when they come into hospital and they're assessed by the medical team, and the decisions made with that team that they need a short-term detention authorisation. But at the same time, we've got antibiotics that are being applied in different treatment plans. So the person begins to regain their capacity. They're kept under review throughout that process. So some of them actually can stop, and they no longer need to have that short-term detention authorisation in place. And it's really good to see that the social workers and the approved social workers in that process are stopping it and saying, this person has got capacity at this stage and is discharged. The numbers through to the Attorney General and the Review Tribunal are relatively low, and we have only had a handful, in fact about 4 cases that have made their way through to the Review Tribunal. No surprises in that as well, because the majority of issues will have been addressed within the acute sector. A lot of those people will actually have been discharged home before the paperwork actually goes through into the Review Tribunal and is logged. There haven't been any issues or concerns about the cases that have been sent through, because it's for people who generally will have a brain injury, who will need to have a further application or extension to ensure that they're protected and their safeguards are in place. The number of live cases across the region at the end of September, and this means the live cases are for people who currently have a deprivation in liberty or a short-term detention authorisation in place, is for the DOLs, it's just over the 3,000, and for the short-term detention authorisations, it's 48. We're having an increase, a slow increase in the number of DOLs currently over the last couple of months, but it has tended to stay below the 3,500. It's still much higher than what we had anticipated we would be working with when we started out on this journey on the 2nd of December 2019. The other areas, which I'm sure you're all aware of, that are causing tensions and pressures across the system are around the Section 50s and the Section 48s. And what we were discussing yesterday even in the multi-agency meeting was, for the number of Section 48s that are being made, quite a few of those are ending up in oral hearings. And that's because they haven't been screened previously by the Attorney General's office. So that additional work is going to come back into the trusts again to the approved social workers and the social work staff to complete those Rule 6 reports, supported by their other multidisciplinary colleagues where that's in place. So lots of activity around what's happening across the region, and particularly in relation to the fact that the approved social workers are carrying the brunt in many cases of the activity and the high levels of numbers that are going through. But the approved social workers are also leading the way in terms of identifying what the issues are within the system and working to find solutions to each of those challenges as well. So we'll just move on to the challenges now, please. Next slide. Thank you. So some of the challenges that we have within the system at the moment are around how do we manage that flow of work that comes down the Mental Capacity Act line alongside the work that comes down the Mental Health Order line. You've got the same group of approved social workers on the trust registers, and how do you manage your daytime notice whilst ensuring that there's still capacity to do all of that work under the Mental Capacity Act? We know that in some trusts there have been particular issues around the recruitment and the retention of the approved social workers, and it's about how is that re-energised. And we can see that energy really been built back into the system again over the last couple of years. And that drive and emphasis that has been brought through Darren and Anya in terms of getting the additional funding to recruit more applicants on and support and fund more applicants on to the approved social work course. Something that we need to continue to work at, and something that we need to check as approved social workers either decide that they no longer want to be an approved social worker and specifically change jobs within the trust so they no longer have to undertake that role. We need to think about what was it that drove them out of that very skilled area? What was it that we did as a trust to help them to retain that work-life balance? The next challenge is around preparing for the future rollout of the MCA. And I can hear at times social workers and approved social workers really eager to push on with the Mental Capacity Act. And some of that's about the interface issues with the Mental Health Order, where at times you're being challenged and asked to make decisions around, is this a mental health order that we're working under, or is it the Mental Capacity Act? And sometimes there's a very close interface between both of those pieces of legislation. So you're already thinking through how do we roll out for the the next phase of the Mental Capacity Act, when we will be using the MCA for all of those patients and service users that we currently support through the detention process under the mental health order. The level of activity isn't going to reduce in the near future. We can see that some of the trusts are sitting in the incoming months with way over 100 cases that need extensions completed on. We're coming into the winter time where there's also challenges within your other work that you're trying to balance as well. And we also have challenges within the system that the review tribunal will ask for more and more information on areas that we don't always understand or fully appreciate they should be asking us for, but we still have to provide that information if we're going to have a hearing for that patient. Rule 6 reports are something that we're continuing to work on and continuing to work with the review tribunal to try and get an agreed process in terms of what needs to be in that Rule 6 report, and trying to continue to reduce the duplication in the process as well. I've mentioned the warrants, and then the final challenge is continuing to work with that variance across the region. We have made great progress over the last almost 3 years now on the way that we have delivered the Mental Capacity Act right across the trusts, the care home sectors, right across the entire region. There's still variance, and some of that variance is actually good, because if we were all doing things exactly the same way, we could become complacent and miss the opportunity to review and reflect on our practice. The variance brings good opportunities to actually discuss how it might be done in the Northern Trust as compared to Belfast, and look at the impact that that has on both the service user and on their family, so that we can move forward, reduce the variance, but reduce it in a way that brings us to a much better place and improves outcomes for the service users. Next slide, please. The opportunities to make things better is always something that ASWs hold on to. And I hear continually when I dip in and out of the refresher training, the ASW training programs, and also the supportive forums. We all want to make things better. That's why we come into social work. We want to be able to work with someone and move away, to leave them fully independent and be able to make decisions and manage their own risks and their own choices in life. We need to get better at understanding why we can't recruit and retain. We also need to understand what the anxiety about the new roles are and help people to understand that those support mechanisms will be in place. There's still a lack of clarity about what people are going to be asked to do under the Mental Capacity Act. And we know that that will take time to bring clarity to the situations. We can also see some of the challenges at the moment that are still within the mental health order, it having been implemented in 1986. So we never ever really reach a situation where all of the system is saying this is exactly what you do under each piece of legislation. There'll always be challenges that will help us to improve our practice. What support and supervision arrangements have we in place for approved social workers right across the region? Some trusts have got it really nailed in terms of they've got group supervision, professional supervision, individual supervision. Other trusts have gone through a transition period where they maybe had good arrangements in place, but have dismantled them to try and rebuild even stronger ones. Some of the other things that we need to think about is workload easement. Right across the region, I see people who are working alongside different disciplines, who are leading, maybe they're a locality manager, or they're a team leader, or there's a specific role, and they are taking on additional approved social work duties on top of their day-to-day practice as either a team leader or a locality manager. So what are we doing in terms of that workload easement? Because we haven't really cracked that system yet in terms of having the really concise way of recording what someone does on a day-by-day basis. We may have some systems that will track over a week, but have we actually given the right rating to each of those pieces of work? And when we look specifically within the acute sector, those social workers who are helping with the Mental Capacity Act and the short-term detention authorisations may also still be doing quite a bit of social work practice within those general wards as well. And there's nothing really in terms of how do we actually weigh up what it is that they need to do so they've got enough time to do what they need to do, and also that they aren't pressurised to the extent where they say, I can't do this any longer. Another area that we've talked about quite a few times in the ASW forums and workshops is around the idea of, will the approved social workers who are doing the short-term detention authorisations also be on the daytime rota to implement the mental health order? That's not what the department's view is in terms of moving forward. It's too difficult to bring those two pieces of work together without placing service users at an unacceptable level of risk. So it may be that there has to be two different rota type systems or staff specifically identified for the short-term detention authorisations. You might have the same groups of staff that are doing it, but they're doing it at different times. So on no one day are they expected to do the short-term detention authorisation whilst manning that very demanding and very busy mental health order rota at the same time. And then finally, are rotas working as well as they can? What about the impact of sick leave and annual leave? How are those rotas being manned right across the region? There's quite a lot of variance, and there's still opportunities to do things better. And we will continue to work on that to help standardise the practices across the region. So let's move on now to why is it important for approved social workers to be involved in the Mental Capacity Act, and why are you the people who are driving it forward? So next slide, please. So the first area is around the knowledge base. And Lisa spoke out throughout her presentation about a number of things that will be reflected in the next few slides. So it's about the importance of the social determinants. Why is it that we need to think about the cost of living at this point in time? Why do we need to know exactly what's happening in terms of all of the other pieces of legislation and policies and processes that are at play? And it's because with the conflicting sometimes pieces of legislation and practices, that's when the gaps start to come in and crack. And that's when people get lost in the system. So the approved social worker are the champions within the legislation. And I have heard that for the last 4 decades in practice and mental health services. You are the people who are looked at whenever there needs to be clarity and guidance. And that will be before someone will go to their legal services. They'll ask the approved social worker, what do you think about that part? Can we use the mental health order? Now I hear from the GP practices, I'll discuss with the approved social worker whether or not this could be the Mental Capacity Act or should be going for a mental health order. So the approved social worker is very much the person who needs and is expected to have this information. And you do have it because you're working with it day and daily. It's bread and butter as part of your training, but in your practice, when you become a fully fledged social worker, you, throughout your supervision and your continued professional development, are looking at the legislation that you're using each day and daily in your practice. You're also building in terms of the human rights and what aspects of that sit within your work within the Mental Capacity Act. The Health and Personal Social Services Order and the Chronically Sick and Disabled Order open up an opportunity for resources, and social workers and approved social workers are the key disciplines who tap in. So you've got your Article 15 money. You also know that people will need daycare, they need attendance at adult centres. You know that for those people with learning disabilities, they've been trying to develop better ways of providing safe accommodation, and at the same time, activities throughout the day, they make them feel worthwhile, that they're contributing to the society. Social workers also, and approved social workers, particularly in mental health and older people and learning disability, take the lead in care management processes. So you're looking at the whole complexity of the patient's needs and ensuring that your systems approach has been pulled into line in terms of checking out how that person sits, not just individually as a part of a family, but part of the organisations and the communities that they live within. And then safeguarding, which sits very closely alongside both the Mental Health Order and the Mental Capacity Act, is driven forward again by social workers and approved social workers to ensure that we're not being over-involved with people, that we're ensuring that the safeguards are in place, and we're making sure that the interfaces between safeguard and the Mental Capacity Act particularly are looked at with very focused lenses, and ensuring that the service user is maintained at the centre of those discussions. Next slide, please. The other knowledge base that you bring with you in terms of not just the legislation is also around the social sciences bit. You have a wee quick look around this circle of what it is that you have at your fingertips. You can see that all of this information that you have at your fingertips and that you build on reflects a lot of the work that Lisa talked about in terms of their challenges and how they're trying to change their systems and improve things better. We all know that the medical model was very much strong and driving practice in the 1970s, 1980s. And then we could see in terms of that approach that social workers and approved social workers bring to their practice of that biopsychosocial approach. You lead the way in terms of recognising the medical model is really important. There is a place for medication. There is a place for ECT. There is a place for all of those interventions, but not in isolation of what the other things bring. So the psychosocial approaches, the CBT therapies, the talking therapies, the strength that you bring as a social worker, helping to place that person in a strength position. You look at what they can do rather than what they can't do. You build on what they're able to do in terms of managing their own needs and their own risks. You bring along that social policy in terms of what's happening around housing and in terms of finances and benefits. So a lot of that is about how you actually build that network of supports around the person with lived experience and the service users. Lisa also talked about addressing discrimination, and no social worker can sit down at a table and talk about anti-oppressive practice without thinking around Thompson's 3 PCs around that oppressive practice and anti-oppressive practice and how it layers. So you can see how poverty, which has been mentioned in a few presentations already this morning, poverty is here with us. It's live. People are frightened of how they're going to pay their electricity bills, how they're going to put oil into their houses. They're already living on very close margins of what they can and can't afford. We can see that there's greater use of food banks. We can see that people are asking for handouts and helpouts much more frequently now than they had previously. And it's not just about people who you would have expected it to be. That group of people is widening because of the lack of ability to secure the financial income that they need to maintain safe homes for themselves, safe homes for their families, and safe homes for their children. So as approved social workers, we will always be working with oppression. We will be addressing it and ensuring that we bring balance to the table, and we address the need to ensure that that person is given the right information, the right approaches with them to help them to make decisions as far as possible about themselves. Community development is another area that approved social workers and social workers have led on. And we used to be trained on it in our social work courses way back in the late 70s and 80s, and then it fell out of fashion. But over the last 10 years, we have regained the knowledge that we need in terms of maximising the assets within the person's community so that we can help them to link into the supports that are there to keep them as well as possible, but also to help them on their recovery journey. The third area, knowledge base, is around the organisational issues that you bring to the table. Can we just have the next slide, please? Thank you. So some of the things are around record keeping, and nothing challenges you any more than the implementation of the Mental Capacity Act to see whether or not you're able to record the details that are needed at the time and the place that they're needed, and also in the format that helps other people in the process to make good decisions. So as approved social workers, particularly in the work that has been done around the Form 7s, you have helped to reduce the number of applications that make their way through to the review tribunal. You now have been very skilled and focused on what needs to be put into the forms, doing it in a very concise and bullet pointed way, or using titles, subtitles as part of the presentation as well. That all helps, makes good decision making. It also helps when a different person, a different approved social worker comes at the extension stage to review your decision-making process, because it's very clear in your records what you've based the information on and why you've made your decision, so they can then review that much more safely. Data protection is a big thing for all of us, but again, that's part and parcel of what you do in your day-to-day basis. And what I can see, particularly over the last 6 months, people have been more tuned into removing information out of the MCA forms, information that is not needed because it's about another aspect of that person's life. It's maybe talking about safeguarding issues or about difficulties that they may have had in their childhood, things that are not related to the deprivation of liberty, whereas before it was almost like a social history, giving all of that information. It was actually a breach of confidence of that person's personal details. Resources and funding and duty of realism is needed more than ever down the decision-making process. And as approved social workers, you have championed the duty of realism model. So in your decision making, you know what's available, not just for that one person that you're trying to deal with at that point in time, but you also know in terms of the waiting lists that are around at the moment for healthcare issues, but also that social care and community resources. So you're making informed decisions and balancing that very difficult task of ensuring that that individual's needs are met, whilst ensuring that there's sufficient consideration given to the needs of the other people on your caseload and on other caseloads within your team. The duty of realism is something that we all need to hold on to. And if anything that you take away from today, go and have a wee read at that Chris Beckett chapter on duty of realism again, just to refresh yourselves in terms of how it will help to prepare you, particularly over the next 6 months, as you're trying to make really difficult decisions about who gets access to daycare, to adult centres and to care homes at a time when the demand is outstripping the availability. The other things around welfare rights particularly are about making sure that you know where to send people to. No one's asking you to fill in the benefit forms yourselves, make the applications, but know how to use the systems and to trigger them so that you're able to get the best outcomes for those service users. So again, as approved social workers, you lead the way in terms of showing good practice for other staff and other disciplines, how to maximise the resources that are there and use yourself as a resource in terms of information collation and recording. And the next slide, please. We've talked about the knowledge that the approved social workers bring to the table to support people who lack capacity and who have mental health issues, learning disability issues and dementia. But one of the key things that you bring into your work and at home every single day is the skills that you've developed over not just your period of time of being an approved social worker, but you've built on the skills that you had as a social worker, a social work student. So for me, this is the reflection of the last 4 decades of working alongside very confident, competent, approved social workers within the mental health and learning disability fields. And for me, approved social workers bring this. You'll not find this in the book because it's kind of like my ideas in terms of the analysis of what approved social workers bring to the table. You're effective partnership workers. You know how to work with other disciplines, other agencies, service users and families. You know exactly what the ingredients are to bring to the table. You're skilled negotiators. So when there's conflict, you're able to help people to reframe. And I've described it as being a crafted reframer at the bottom. You're able to take the tension and the negativity out of situations. You help people to think about the situation differently. Think about it from the nominated person's perspective or from the medic's perspective or the care home manager's perspective. So very gently in your conversations, you're helping people to move their seat into other people's situations. And you find a solution that reduces that negativity and you can harness the positive energy that's in the room. You're inspirational builders of networks. So you tap out to all of the key networks that are needed around that specific individual family and that individual patient at that point in time when they're in crisis. But you also build on those networks to help that person through their recovery journey. So you don't look just at what's the presentation at that point in time on the day that you meet the person in a crisis, but you also think around their educational and employment needs, their social needs, their emotional needs, their financial needs. You use that systems approach and you make the connections that are needed throughout that community and the statutory organisations to get the very best outcomes possible for those service users. You're experienced communicators, and that's, I can see that right across all of the different service user groups, that you're able to communicate in a way that addresses your need and your desire to help people who have challenges with their communication skills to as fully as possible engage in the decisions that will impact on their lives. It's really important throughout the capacity assessment processes and also the best interests. And I've had the opportunity to observe a high number of staff carrying out capacity assessments with both people with acute mental health issues, but also people with a whole range of cognitive impairments, right into being significantly impaired to the extent that they no longer have connection with who they are, time, place, or person. Also for people who are working with people with a learning disability and a whole range of people with sensory impairments in addition to their mental health or learning disability needs. And I can see how social workers sit so comfortably in that role, being able to take all of the key cues from the verbal and the non-verbal aspects. You bring information from other parties into that discussion. You treat the person with utmost respect and dignity, and you position yourself in a way that you're able to work on the right power level with them, getting right down, bended knees, looking as closely as possible to the person, using your body to help them to feel safe and to be able to be engaged with throughout that process. That doesn't come easily to everyone. And I think that the approved social workers that I have observed have been exemplars of practice. And hopefully we'll be able to use some of you in some of the role modelling and video clips that we'll do for that work to help the training as we move forward. Specialist confronters, and that's, you call it out, if things are not right, you will challenge yourselves, you'll challenge your other approved social work colleagues, you'll challenge management and leaderships or people in leadership positions in your trusts, other disciplines and other agencies to say, this doesn't feel right. So you do it in a way that's not aggressive. You do it in a way that actually helps the person to think, to stop and think, gosh, I haven't thought about that before. Let's talk about that a bit more. So in challenging and confronting what's happening, you're able to turn it around and help people to think through the situation differently. You're flexible adapters, and you can see that with the workloads that are coming through. And when I look at some of the work that Keith Johnson juggles on a week-to-week basis in terms of the demand of the work coming through and how that needs to be worked through. And Steph Kerr is one of the most flexible adapters that I have seen. When she's signed up to do a specific piece of work on a day and the whole agenda changes, and she very quickly is able to adapt and say, I can do that, and this is what I'll do for you. You're keen to adapt, you're able to work with change, and you really thrive on change and the challenges that the day comes to you. I spoke to someone very early this morning who was hoping to get onto the conference today, and she was saying, I don't know if I'm going to make it because I've got a number of people off sick. I'm going to try and make it, but these are things that I have to do to enable me to do that, so I can make sure that the workplace is safe, the services are safe, and then I'll come back in again. So it's that ability on a day-to-day to say, what needs to be done? What can I do to serve all of the things that I wanted to do, and then prioritize. And then finally in that slide, we've got the reflective practitioners. You're always keen to learn. There's no one as hungry for knowledge and information as approved social workers. I can see that open and challenging debate in the social work forums and the support forums, where people will challenge themselves in their decision, but they're equally allowing themselves to be openly criticised constructively by their colleagues and saying, this is what I did. And colleagues can give them comments about, well, that was either good, but equally, did you think about, what about if this happened again? Maybe we should think about something else. So that willingness to always reflect on your practice and to grow is key in terms of how we work with service users, and you as approved social workers are the key people in doing that. And then the final slide then, please. Just to sum up, each of you individually and as a group of really strong collaborative workers are making a difference. You're making a difference to every single patient and service user that you make contact with on a day and their families. But equally, you make a difference across the system. You take a lot of the pressure out of the system by working innovatively, being able to manage risks much more differently and in a much more managed way than some of the other disciplines have had experience of doing. So you lead the way in doing that. You're passionate. And I have not heard an approved social worker for a very, very long time tell me that they're burnt out. Anyone that I'm engaged with, that passion is still shining through. They might say, gosh, work is really busy and we don't have time to do it all. But you know what? We're going to make things different. We're going to look at ways that we can do things differently. They energize themselves and they energize the other people that are around them. And that passion is something that you need to hold on to. It's what sets you apart from a lot of other disciplines and organizational staff as well. That passion to work with people. You realize that you're not the only discipline who needs to be involved. So your ability to be the glue that pulls that multidisciplinary team together is really what's needed. You value the work that the medics and the nurses and the occupational therapists and other AHPs bring to the table, and you're able to energize that group around your patient and your service user. and hold on to that, make sure that if that goes, then you're probably at a stage where you're thinking, okay, I need to go and do another course. Speak to Gavin about what's coming up and get yourself re-energized again. You can see from the knowledge, skills and values that we've talked about that the approved social workers are perfectly suited to implement and drive forward the Mental Capacity Act. So finally, just thank you all so much for not just attending today. It's always good to see such high numbers coming out, but equal the amount of work that you have done over the decades that you've been employed, but specifically over the last almost 3 years now in the Mental Capacity Act. It has made a difference. You have stood above the parapet in terms of when things are difficult, and you've helped everyone to find solutions whilst dealing with very vulnerable service users and ensuring that those safeguards are in place. So thank you for all of your hard work. Thank you for your passion and your commitment to the organisations and to the people that you work with. And I really look forward to the rest of the day, but continuing my work with you as approved social workers. Okay, so we'll stop sharing and bring up Janine's presentation.
I think I'm going to try and bring it up here myself, which might be a dangerous thing, but let me see.
It's on now, yeah.
Oh, there we go. So hopefully that is myself. Oh, hold on a wee second. I wanted to do it. See, this is where I should have said no. Work away. Yep. Okay. Hopefully. Is that coming up? Okay, I don't know why it's not coming up with my notes on it, folks, but anyway, I'll just work my way through it here. So as I say, my name is Janine Gordon, and don't worry, you'll still, I had advised Phil I wouldn't need the full length of time today, so you'll still hopefully be on time for lunch, so don't be panicking. I'm the mental capacity lead in the Northern Trust, and would take a lot to do with the training alongside our training team also. And today it was really just coming along to show some of the resources that we would use. And really it is to promote the really value base alongside Mental Capacity Act, alongside the levels of training as well. We know we all have that mandatory training every 3 years to complete in relation to mental capacity. But this is also really to emphasise in between those times, and also to promote that training, just really the value base and what we need, and to remind ourselves at times why mental capacity is here. It's not just about the report writing and the forms. It is just about that value base for the service users. So we currently have 4 page tigers. And hopefully I'll show a wee clip of the page tiger for maybe some of you that wouldn't be familiar with them. But they really came from a need that was identified with managers and staff who at times had been saying that, but with the ongoing implementation of MCA, and at times things were changing, so maybe we were doing different tweaks regionally, and that information maybe wasn't getting down to staff, and at times they felt they were missing that vital information. So we really wanted to have that shared resource throughout the trust, that we were able to enhance and develop staff knowledge, really to empower managers and staff as well, that they could access information themselves instead of having maybe to come through to one of the team, the core MCA team. So it was about getting that information out there. At times we maybe even would have found we were answering the same questions. Not to say that doesn't happen now at times, but we were answering maybe in the same queries and questions, whereas now we're able to use this as a central resource to put on for the MCA, everything MCA related. We also have, as I say, we have our main staff resource. We'll go through them, and just then our training resource. There's also then one for our independent sector, and then we've just recently started our resource toolkit. And it really is just about driving that value base. I know back in 2019, I'm not sure what would have cleared the room quicker if someone had said COVID positive or Mental Capacity Act needing completed. But as Phyllis said there, we've come such a long way in the pathway. We've developed so much further, and staff are starting to actually embrace MCA and what it stands for. So as I said, we have the main staff resource. That's what we started out with, and if I stop sharing, hopefully I'll not wreck this, but just really to even show you that the main one that we have. Hopefully this comes up okay. Yep, hopefully that should be on. So this is sort of our main staff resource that we have, and we do have links to the code of practice there. I think that's the wealth of knowledge and even training that staff can gain for themselves, as I said, outside of the formal training resources. Where we do have links to, say, even the department's website, and there's that wealth of knowledge there. Moreover, on what we have even on our page taggers, just in relation to that frequently asked questions section, and also the wealth of maybe like different flowcharts and various things that they would have. So as I say, it's great that we can direct and signpost also staff for further information. One of the areas I did want to use this video just now, and I just was going to show it. This is something that we would use within the our training sessions, but again also for staff to really hear the person and see the person behind the paperwork, explain what mental capacity is. So I'll just, hopefully this plays okay and you can hear it.
Mental Capacity Act.
My name is Karen. My name's Carol. Laura.
My name's Chris. And my name is Pauline. I'm helping make the video about the Mental Capacity Act.
The Mental Capacity Act is a law that says people must assume you can make a decision.
What is capacity? How do you know you've got capacity? Can you understand the information about the decision? Can you remember the information for long enough to make the decision? Can you weigh up the information to make the decision? This is about thinking about our choices. Can you communicate your choice in whatever way is right for you? There are many ways you can communicate. You can use Makaton signing, communication board, or a device where you can talk through a computer or use bodily gestures and talking.
How it works.
When supporting you to make a decision, your staff should
start by thinking you can make your own choices.
They must help you by giving you information and support.
You should be supported to have the best chance of making your own decisions.
Listen to your views and what you want. You can make a choice that they don't agree with.
If you do not have capacity, then must make a decision that is best for you.
If somebody has to make a decision for you, they must make it in your best interest.
The decision must give you as much freedom and control as possible and reflect your wishes.
And hopefully you could hear that okay. So that is part of what we would have. I would use at training sessions as well. Just bring us back up again. And it really is quite a challenging, actually, I would find. Sorry, this is why I should maybe not click these myself. It's quite a challenging and emotive video, and it's really, to be honest with you, I've used it at the beginning of some of the training sessions, really to set, I think, the scene and set the day. And also it's no coincidence, it is near the front of that page tagger also. And to me, it really does bring that value base on why mental capacity is there. At times I would ask staff, prior to seeing the video, I would ask staff, what does mental capacity mean? What do you know, whenever you think of mental capacity, what do you think of? And you would find quite a lot of the answers will be about the impact on them as staff members, that it's maybe time consuming, report writing, stressful, confusing. There can be a lot of words used like that. And whenever we do challenge staff to think about, well, why is mental capacity here? And really going back to that fact, as I keep saying about that value base, because it is so important. And staff then will see actually nearly that person behind the paperwork. And whenever they do hear, and to be honest, I think it's actually what they do say within that video speaks more strongly and has more impact than potentially us standing up for a full day given training in relation to mental capacity. And they will start to actually take themselves out of nearly the impact, and they will see it as the human rights and promoting the person's rights and safeguarding the person, and really taking the report writing out of it and seeing the person for who they are and why they are needed to support that person. So say it is really an effective way of trying to ensure that we are not just seeing those menial tasks of having the report writing there, and that the reasons why mental capacity is required. And it's really just to say keeping that person at the centre of our work. We also have then our champions and leads, and we would use them. We have our champions forums, and we would use the champions to continue with learning and skills development within the teams also. They play a really vital role in disseminating information as well as what our page tiger will as well. We have then, as we know, we have the two other page tigers that I mentioned, and they would really focus on trying and strengthen that key principle 3 in relation to all our work. And it's something that I'd be very passionate about, and I know our core service would be. We all know at this point it is just about that support principle and ensuring that we have all our practical help and support and enabling the person throughout the process. Yes, we have our mandatory training, which is obviously essential within the work, but within the trust, we want to upskill staff, and staff, as Phil had said there just at the end of her presentation, staff are passionate, and it is actually fabulous to see that they, even with all the competing demands within a daily work, they are still very keen to progress. They want to develop their skills, particularly in relation to their mental capacity assessments, but obviously that goes further throughout all their other work. So it is really refreshing that you can see that passion and drive to enhance their knowledge and skills. And we would regularly run talk and maths courses alongside our speech and language therapist colleagues, and as well some of ourselves are being trained also, social workers, to be able to take the training and take that forward with our staff. And that's as alongside we're delivering or having someone come in to deliver the Macathon training. And I find for that key principle 3, to ensure that yes, we have within our forums, we are looking at time of day, and obviously if there's any hearing impairments, which are obviously very vital importance in relation to the support principle, but again looking at that other meaningful support that we can provide. And some staff don't have that knowledge and skills in relation to that, and that's what we want to ensure, that we are upskilling our staff, that we can meaningfully provide any help and assistance. And as what we would say to staff at times, some people may not be able to communicate in the way that they have or were able to. They may now, talk and maths may be a new avenue for them to do it. So just because it's never been used, it's certainly something that we should be trying within all of our assessments where appropriate. And it's great to see the uptake we have, as I say, in relation to our Macathon. We have obviously the mandatory training, talks about consent and capacity, but we do run additional courses in relation to that as well. And we have our SALT colleagues coming in relation to additional communication support, because we really do feel so strongly that this support principle, I mean, it really is that foundation in relation to supporting the person through that assessment and providing that person-centred care throughout all our mental capacity work. We'd also have external opportunities at times we bring into our staff from Alzheimer's Society. So these are all sort of different courses in relation to sort of enhancing the knowledge and skills outside of our training that would be provided by our trust training team also. Just really having everything that bit more specific and tailored to the mental capacity assessments. One of the newest parts that we have is our resource toolbox, page tiger. And it's really in its early infancy at the minute. And again, it's about enhancing and sharing knowledge trust-wide. During some maybe of training session, we'd have found that potentially some teams or even divisions at times may have been holding quite a wealth of resource. where other teams may not have had that same level of resources. And it was just about ensuring that we had that equity of resource and knowledge, and again, upskilling our staff in relation to what is out there, having that shared learning. You know, we used these pictures, or, you know, we found this very useful. And it was about bringing all those resources together as a trust and having that unified approach that no matter what trust, or no matter, sorry, what area within the trust, as a person, if you were having an assessment, a capacity assessment, complete it, you were going to be offered that same support, and that the staff member was going to be as knowledgeable and upskilled as someone in a different area. So it's about, as I say, coming together and having that unified approach within all the teams, within all the divisions. So this is, again, I could even quickly stop sharing this here and even just bring that one up just so as you could see it, which will be slightly more interesting. Or sorry, I might even have closed it down here. So, but again, it is just similar to that that we would have had of the page tagger, that knowledge and skills one, that page tagger, similar to that. We see this. You can tell today my PowerPoint presentation skills are not very up to speed. I'm usually a bit better than this on them, but anyway, it's really going through having, again, that support principle, really highlighting the support principle for everyone within the trust, to ensure that we are sharing those resources, we're upskilling ourselves, and that we're sharing, say, from one team to another. There's different tabs within it that they can upload through to yourselves, and that we're ensuring that we have that unified approach and that real strong resource library for our staff. The final one that we do have is the independent care home type page taker resource. And it was really important for us that yes, we needed to upskill our knowledge staff within the trust, but we also needed to upskill and support those from the independent sector. So we developed this page tagger, and I would also run quarterly support meetings, or sooner if required, for those within the independent sector. And really what feedback from themselves was, whenever MCA was coming into play back in 2019, really at that time COVID had obviously hit, we all know, had hit the care homes very hard. And at that time, their focus really was on caring for the people within the care homes. And in some ways, some care homes and saying they felt a bit lost whenever it came to Mental Capacity Act, and they maybe weren't up to speed as some others. So it has been wonderful that we have built those relationships. We have been able to run skills and training for specific care homes. We've run individual sessions. We've run wider sessions for all care homes to come along to. So it has been great to be able to reach out to that sector as well and move forward together. And we're not just keeping that niche with of knowledge and skills within our own trust. And it's we remind ourselves that it is good, but we are building those relationships and support. We are seeing an increase of referrals coming through, and as I say, we have to remind ourselves that that is a good thing and a good sign. But we are having that further engagement with that independent sector also, which again really can only benefit the care home staff, but more importantly, it's benefiting those residents and those service users. So it is. So folks, that was because I'm conscious of time there. So that was kind of where I will leave it.
Thank you, Janine.
Brilliant. Yes. No, thank you both. So really great, sort of positive and clear assertion of the importance and complexity of the ASW role and the importance of the Mental Capacity Act itself. And Janine, those resources are really impressive. It's great to see that process. Annie, I think you wanted to come in just for a moment before lunch. Is that right?
Thanks, Gavin. Yeah, and again, thanks to Phil and Janine there. I couldn't agree more about the many and varied skills that ASWs bring to the job, and it's great to see the resources to support people. I just wanted to pick up, Phil, you had been talking just about, the time to do the job and how that fits in. So I just thought it would be useful to give a quick update about work we have underway in the Office of Social Services and the Department of Health on safe staffing. So some of you will be aware that safe staffing legislation is in the offing, although our current political situation isn't helping us progress that. It was originally designed to be largely about nursing safe staffing, but so OSS and other professionals have successfully lobbied for it to be wider and to include all professions. So that's a very positive development, but it also means that we have to be ready with our work on, well, what do we consider to be safe staffing? So you'll be aware that probably our first attempt at that was with the ASW quality standards, you know, where we did say how many ASWs we believed were needed, and also set a standard of 10% of an ASW's time on ASW rota duties. We've also done some work on what mental health safe staffing and social work should look like. And that was a piece of work that well, Gavin and Darren were very closely involved in. What we're moving on to now is I'm setting up safe staffing projects for social workers. We're going to develop the mental health work we've already done a little further to look at normative caseloads. And we're starting a process with older people's and children's services as well on trying to determine what we think safe staffing is. I will say it's fiendishly difficult to do with just many and varied and multiple complications and to be considered within it. But I do think it's a very important thing for us to do. And I suppose I just wanted to say that work is underway. You know, it's not going to give us something in 6 months' time. I mean, I think the time scale for us perhaps getting to guidance for some programs of care is, you know, we're talking 2 years or so, you know, to really develop it. But we're starting the review of the evidence base, starting listening to, you know, to practitioners about what they're telling us about safe staffing, etc., etc. And we will gradually roll that out to include all programs of care. But I suppose I just wanted to give the reassurance that time for ASW work will, across all programs of care, will very much be a feature of the calculations that we make. Yeah.
Great. Phil, do you want any last comment before we break at all?
You know, if there's any other comments, that's fine, Gavin. Yeah, I'm happy to take any comments or questions.
Okay. Any quick comment or question?
We're competing now with people's tummies, Gavin.
Exactly. Yes, my mind's on soup. Okay, we'll take a break then. So see you back here at 1:30. Is that okay? Thanks again, Phil and Janine.
Okay.
Thank you.
Oh, great.
Yep, it's ready to go here, guys, as soon as everyone is back.
Brilliant, Isa. Thank you.
No problem.
That's great. People returning now. Okay, brilliant. Welcome back, everybody. Souped up, hopefully. So the next presentation is by Maura Harper, Maura is a care advocate for forensic services for cause, which has also been involved as a care advocate in a lot of the sort of legal and policy developments, and also is involved in professional education, including on the ASW program. So, Maura, thanks a lot for your ongoing work on that. It's good to see you.
Thank you.
Let's see. Yeah, great. Thanks, Isa.
Okay, good afternoon, everybody. Some of you might have come across me before when I was doing some of Gavin's ASW training at Queen's. So hopefully it'll not be another take for you. You can listen again. So anyway, just starting off now, as I say, as Gavin said, I am care advocate in forensics in Shannon Clinic. and before that worked with mental health in East and South Belfast, covering those areas, and then went into the forensic end. So I have been with Cause now for 15 years, and as a peer advocate, I left my teaching position to go into this type of work because my own daughter became unwell and I didn't know anything about mental health. So it was a great way of learning. So I joined Cause as a care advocate and sort of been there ever since. So if you'd like just to pass on to the next one. As you can see, we have been going now for 27 years, which and we're based in most of the services except unfortunately for the Northern Trust, which we don't have an advocate in there, but we have in Beechcroft as well as all the other south and east, north and west. You can see all the different areas. Next one, please. Our aims, of course, are to, as you can see there, to raise awareness of carers' needs, to develop staff empathy for carers, to clarify staff expectations, and to improve carers' experience of inclusion. So I'm going to talk a bit more about this as we go on, so you'll see some of the slides will move on quicker. Okay, thank you. Next one. And our Relative Reach programme, as you can see at the top there, we have the helpline. So we have the Cause helpline where people can ring in, and we share it between ourselves as the advocates. We have 2 late evenings until 8 o'clock. And very often we get people ringing in just completely ad hoc who maybe are concerned about their loved one, you know, with the start of mental health. So we have that. Again, care representative individual groups. Again, we do a one-to-one, usually when we would meet up with the carer for the first time. Always like to do a one-to-one with them first, because I think the fact that, you know, we're coming from a peer-led organisation, they feel more at ease with you and you can talk to them and they can sort of feel free to talk with you, which makes a big difference. Also, we do have support groups, which I don't actually, unfortunately, in Shannon, because obviously it's regional and we're all over Northern Ireland, but we managed to get together at our respite events, which is good. Again, we have educational programs for our carers and professionals, and again, it's also about learning about what Cause does, and also to help our carers understand all the aspects of mental health. Forgive me if I'm a bit croaky here, because I was trying to get rid of this awful cold. So on to the next one. We have our listening ear again, which is similar we're talking about the helpline, and we can once the person rings up, we can then help them. Maybe sometimes you're maybe on the phone 30 minutes, 40 minutes, sometimes an hour. It can be unbelievable. Also, we have carers who would ring, you know, just ring you on it all the time, you know, just for, you know, wanting to speak about the situation. And so that listening ear is quite important. Next one, please. So again, the role of the care advocate, passing on the needs of carers, because very often when people ring us up, it might be, they're very young people, and there's the aspect of Beechcroft and or children's services, or also to explain to them that they have to go back to their GP for their first time, so that he can then make the decisions as to what their needs are. So you find that people ringing up for the first time, you know, find it very, very difficult. They're very confused and they don't know how to get into services. That's one of the things that we find. We get an awful lot of phone calls on that. Also, our own carers who would be looking for information about, you know, who they would contact, etc. We would obviously, you know, keep telling them that as well. So again, very often too, we might have a carer who would be in crisis, who maybe they, you know, their loved one had been okay for maybe a few years and they have been with us in cause, and then they have come back into a psychosis and they would ring maybe in desperation. What are we going to do now? How are we going to get, you know, going to get the help? Because very often they would be with the system and then they're off the system. The good thing, I suppose, about the forensic services is that when people come out of Shannon, they have the community mental health, you know, forensic community mental health, which in a way looks after the patients there very, very well. Obviously, in the mental health general, you know, if people are well or appear to be well, as they always talk about recovery, even though it's not total recovery, they may have been well for 2 or 3 years and maybe have lost contact with the services. And that's when it's very difficult. So very often we get help, we get requests to help them to get back into that situation. Okay, thank you. Next one, please. I think, sorry, just that's a similar one, so we'll go on to the next one. Again, informing carers of their rights. Carers are unaware of sometimes of carers' assessments. Now they are getting a lot better, but I think the problem with that is that the carers feel that sometimes they don't want a carers assessment, not for the reason they have the wrong idea that maybe if they're going to be asked to, you know, what money they're earning, and they have all these ideas in their head that people are going to ask them all these questions. But anyway, it's a lot better now. They have made it easier. It used to be very, very long. And I remember one of the carers saying that, goodness, I was ready for a glass of wine after that. It was such a long haul going through all the questions. So again, the carers of service users do require support, information and guidance on how they can best assist the clinical team and the service users in their care. So again, that's something that when they're just maybe new into the system, they need that extra support to help them, you know, who are they going to ask? Or maybe they would ring me up and say, you know, I need to speak to the psychiatrist, or I need to speak to the social worker or whatever. And again, helping them along with that. And then maybe speaking to the clinical team about their problems or things that have cropped up and help to solve it that way. It's sort of becoming that sort of in-between person that can hopefully soothe things out a wee bit. Okay, so if we go on now to the next one. And again, the emotional support one, I think this to me is actually one of the most important ones in our role as care advocates. I think firstly because we have the time on that one-to-one basis to talk to carers, to give them plenty of time and to listen to their story. And I think they'll tell you their story in detail because they know that you have had experience of someone that has gone through mental health. So they feel safe in that aspect. So I do feel that at this particular thing, the peer aspect is very, very important. Because sometimes there's some things that they mightn't even tell the psychiatrist for all sorts of reasons. And obviously that's their confidentiality with me as well, which you don't, not unless it was something obviously, you know, which to do with children or something like that, but I'm just talking in general. So that I feel is one of the big things for our type of work. And there isn't really, I mean, I do have carers, and I know some of Fiona's there on the meeting. We do have carers that have been there maybe for 8 years. So I have been with them for those 8 years from their journey. So it's not as if, you know, you get to that stage where they look on you as there's someone that they can sort of trust or speak to or talk with. And I think that's really important. Okay, thank you. Next one, please. Again, our education and training. We do a prep course of 10 weeks for carers where we can teach them or give them information, really, I suppose, more than anything else. Obviously, during COVID, that stopped, you know, and we weren't able to do it. So we did some online. But again, that's important for carers to learn how to deal with the situation. So also, we used to have a lot of, I'm sure some of you people would remember the thorn training that used to be at Queen's. And again, that was really important because we had thorn trained nurses that were able to, you know, especially trained to work with families. And that stopped, but I was hopeful to hear, maybe Gavin knows this, that they're starting again with the thorn training. It was always very, very helpful because we could have brought in one of those nurses or somebody also like Stephen Guy, who used to do the pharmacy, you know, to explain about medications and how it affects them and different things like that. And also we would have brought in sometimes junior psychiatrists as well to help with the training and give their views on it. So again, that's something that's hopefully we're getting back on again. We also do some training for personality disorder, which is a specialised training on its own. And the advocate that does that has the experience of having personality disorder in her own family. So next one, please. Thank you. I think I've gone through that one, so I'll pass on again. Sorry, to the next one. So, sorry, could we just move to the next one? Role of care advocate. That's it, thank you. Okay, as cause advocates, we are privileged in attending various meetings with the health trusts, which is really good, where we can address the needs and various circumstances in assisting with support. Now, I think that does help quite a bit. Also, from the professional's point of view, from my point of view as a care advocate, and also to bring the concerns of the carer to the professionals. And that does make a difference. We're also involved with, as yourselves know, training of the ASWs. We also do training with junior doctors, Queen's first year social work students. We're starting up again with our New for You forensic training. And also I would do a lot of SAIs, level 3. And it has now been recognised that a care and user involvement with that is now key. So that is mostly the type of training with professionals. But again, helping to give the carers a voice, you know, in that sense that if I speak on their behalf about their concerns, and then it's knowledge, because very often some of the things can't be brought forward. I know our social workers do a great job there, and they do as well. But sometimes there's other little things that might crop up that can be added to it. I did sit on the Forensic Executive Council in the Royal College of London for 3 years, which was a really great experience, and I learned a lot on that. And again, that helped me to build up from professionals and people that I met there that I can still be in contact with, was the forensic aspect. And it was very, very useful, and I did enjoy that. And that was just before we all stopped. You know, I was traveling. In fact, the last conference that I went over to in Liverpool was just the start of COVID. So that ended it after that. So again, the next one, please. So again, the biopsychological social model, again, the I just keep coming back to this, but I do feel that the peer model is very important on this point, because again, you know, families are the individual experts in their own experience. They're the ones who have lived with a person. They're the ones that see it. And I think to help them to deal with the situation, especially if the person has been unwell for the first time and then becomes unwell again, they need to have the knowledge of how to deal with it and realize again that it is an illness, and not the way maybe at the start of when someone becomes very unwell, that as often the carers have said to me, oh goodness, I had to put them out of the house where they were so cheeky, they were so, you know, just, you know, for them to understand that this is the way it affects them and how it affects them. So thank you. If you move to the next one, thank you. So we have the triangle of care. I'm sure a lot of you have all heard of it. And again, it's the three together, working together as a service user, professional and carer. Family interventions with relatives and carers of people with SMI aims to decrease the stress within the family. It also reduces frequency of relapse and hospitalisation and encourages compliance with medication and helps people stay in employment. An important consideration in offering family interventions, in keeping with Standard 6 of the National Services Framework, where the needs of carers are identified. So we would often mention that triangle of care because sometimes, you know, carers can be just sort of pushed over, really, I suppose that's the way to put it. And really, in some ways, they could be so much help to the recovery of that person, you know, so I think it's one for us to remember. Okay, next one, please. Thank you. So again, where I'm working at the moment, again, is forensic services. You can see there, Shannon, I still have some contact with Clare Ward, although we're still hoping that at some stage we would get a low secure. It's not officially a low secure unit. And for those of you who don't know, Shannon is a medium secure 34 bedded unit. I think Clare has 16 beds, but again, we have people coming there from AMIC and we have people coming, stepping down from Shannon, but really what the forensic services greatly need is a proper low secure unit, which is something that has been in the talk for quite a number of years, and hopefully it'll come up soon. Our community forensic then, of course, when our people leave Shannon, very often they just go out into the community and they're looked after by the community forensics. And that again is quite challenging because I have one carer who the person that she was looking after was in Shannon and came out. And the trouble is, when you don't have a low secure unit for them to move into, he went out into the community and of course refused to have any contact with the community forensic. And unfortunately, this very day, he's on the streets. And those are the things, funny, I was talking yesterday at a meeting with Siobhan O'Neill, you know, the girl, the mental health girl and champion, mental health champion. And I was just saying, you know, putting these points forward that these are the sort of sad ends. Again, the other problem for a lot of our people going out into the community is getting them homes to live in or getting a place to live. And also because of their forensic background, sometimes again, you know, because a lot of these places they're not sort of within the trust, but they're actually other agencies own them. They don't want to take on maybe somebody who's has maybe been caused arson, etc., etc. So you can understand how difficult it is to get a placement for people that have been there. And I do think, again, it's another thing, if we could just have some wonderful place that we could actually go to and be there, it would make a difference as well. So again, just talking about that, and Shannon, following assessment by our senior clinicians, all decisions are made by the bed management meeting held weekly. So again, when people are maybe in prison, or the clinicians have to go and assess them, maybe with the social worker or other member of the staff, and see whether they would actually have to come up to the Dundrum set of references for admission, which is used by the psychiatrist. So they have to be assessed on that as to whether they're medium secure and can be brought into Shannon Clinic. And because a lot of them really like Shannon Clinic so well, you know, the thing is, sometimes they actually don't want to go out. So they become sort of, you know, so there's that aspect of, you know, giving them the support there, but also training them for going out into the world and all the things they have to deal with. So we have an OT there who's very good at doing all that type of thing. As you can see then, the Carstairs, you can see it's our high secure, and the conditions of high security would only be indicated where there is perceived grave and immediate danger to public safety should the person escape. Well, at the moment, I have one carer who has a son in Carstairs at the moment, and he's been there 5 years. The unfortunate thing for the carer is that they have to travel over to Scotland, that's where Carstairs is, to visit. And, you know, it's quite an ordeal having to go backwards and forwards over there. Now, they do get help with that, but it's just the aspect of, I'm just thinking of this particular mother. I mean, would be in her 70s maybe. And, you know, it's quite an ordeal having to go over and be there. And again, we don't have high secure in Northern Ireland either. So we don't have high secure and we don't have low secure. So we only have the medium secure. Just regarding referrals are from special hospitals, acute admission wards, courts and prisons, psychiatric intensive care units, and the community forensic mental health teams. So they would come from all of those. So there we are. So would you like to go on to the next one? Yes, and this again is the carer's perspective. And when talking about this, I thought maybe rather than talk about my own situation, I thought that just mentioning a case of a carer without obviously any names or anything like that, but the type of thing that maybe carers have to deal with, or for instance, maybe I'm just thinking of, there's so many different cases, but anyway, one particular person who unfortunately had only one child, and he took the life of her husband and then attacked her quite viciously and also killed the dog. So the sad scenario about that is the mother ended up in hospital for quite a long time, but obviously because it was her son and because she knew that it was his illness and his condition, she obviously wanted to keep seeing him and visiting him and everything else when he was in prison firstly, and then when he was out of prison and in Shannon. But because of that, then the rest of the family just didn't want to know. So they cut her off completely. So in other words, all the side of the family belonged to the husband and thought that she shouldn't be going to visit the son because that wasn't right. So you can see how difficult it is for families on that forensic aspect where they have that double stigma, you know, trying to deal with not only the effect of what has happened to them themselves and their families, but also the whole outside family are so affected by it. And then, of course, the horrific thing is, we always talk about, as you know, confidentiality. It's always a big word. And yet here we are, after those cases, the next thing, when they've come up through the courts, everybody can go onto the internet and look them up, find out all about it, see all what happened. And again, that's stigma, 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 again, for that person in the family to try to deal with all that, when other people are saying, goodness, did you see that? Did you notice what happened and how that happened to him? So they have this journey, you know, which is so difficult for them to deal with. And again, I think that's one of the reasons that when I get them together on their respite ventures, that they can sort of confide in each other, because they've all been on that forensic journey. And it has, they don't have that worry of speaking to each other about, oh goodness, you know, my son was in prison. You know, they know, and it makes it a lot easier for them. So again, it's just one of the many, many cases. I mean, there's so many different variations of situations like that. And also cases of, I'm just thinking of one other case again, where the family were distraught with what happened. I can't actually go into this one, but he ended up in prison and Maghaberry. And because of the situation, he was locked up for, you know, something like 22 hours, hardly ever got out. And he was suffering he had mental health, serious mental health problems. But again, I feel as a carer advocate, and I'm always shouting about this, that there is not enough support in the prisons for people who are, you know, suffering from severe mental health illness. So the family fought and fought because they thought that he shouldn't be in prison, which actually he shouldn't have been. So it did take quite a long time. He was in prison for 1.5 years, and eventually he did get back into Shannon. And again, the family then were much happier, because at least they knew then he was going to be getting treatment and going to get assessments and being looked at, and that helps the situation, you know. So as you can see, it's very, very, very difficult for families having to deal with. It's difficult enough for families dealing with people who become unwell and mental health generally. But I think for the forensic aspect of people, you know, suffering with mental health and having been in prison and having to come out and then trying to get them back into the community, I think it's just so, so difficult. Okay, thank you. If you'd like to go on to the next one. Am I talking too much, Gavin?
No, that's the idea. That's the idea.
Okay. So again, you can see the impact on the family, just as I was just talking about there. It's all down there. Those feeling dazed, confused, angry, ashamed, guilty, afraid, health, shame and stigma, all that we talked about, relationships in the family, relationships beyond the immediate family, work and finance. Again, that's another thing, you know, trying to help them if they're going to go back into work. If they have offended, you know, you've all those extra difficulties to deal with, you know, so thank you. Next one, please. So again, the stages in their carer's experience of their illness. Again, that's the disbelief and denial, inability to accept the new reality that is severe mental illness. Searching for the explanations, blaming others, and feelings of anger, emotional turmoil and conflict as family members seek help from each other and from professionals and find that cannot offer the help that we need. You often find that the carers will be saying things to you like, I wonder, did something happen whenever he was a baby or she was a baby? Or did, you know, they're always looking for reasons why they became unwell. And, you know, I think it's just, I suppose it's a natural thing. Disorganization, bargaining, confusion about about what the new situation means and repeated attempts to defend against the problems it brings. Stage 4, realization, taking it on, depression, facing up to the new situation and the loss it brings, anticipating the consequences of the loss. And I find a lot of the carers that I have dealt with over the years have become unwell themselves and have suffered quite a lot of their own depression and illness. So you can understand that, how that would affect over a long term of, you know, trying to deal with all aspects of their loved ones' mental health plus the whole family. And the stage 5, acceptance, reorganization, understanding, accepting the new situation, taking new challenges and preparing to make the best of it and trying to make new plans for the future. Okay, thank you. Next one, thank you. Again, research and common sense tell us that these are all stages we all go through when coping with a major loss. It's like the death of someone we love. It's almost like that for a lot of people in the forensic aspect. Each person works through these stages in different ways. Some people get stuck at one stage and find it difficult to move on without help. When someone dies, we work with the grief of that single event and hopefully come to terms with it in time. Severe mental illness such as schizophrenia and bipolar are relapsing conditions. The family carers have to face traumatic loss each time their relative recovery is halted and a relapse occurs. And that's what's very hard for people when they find that they think, you know, things are improving and things are getting better, and then they have the relapse, and that is very hard to deal with. Okay, next one, thank you. I'm aware of our time, so again, this is research on carers' experience of mental health services. You notice that there's a general feeling that carers continue to feel excluded and marginalised. Criticisms are levelled at the lack of specific information, where there's a crucial need for practical knowledge, poor participation in care or discharge planning, poor lines of communication with a multidisciplinary team, widespread confusion over the limitations of confidentiality. And that always comes up, as you know, the confidentiality one, because you'll see, and I think it's maybe the next slide, if you'd like to move on. Next one, please. Yeah, this is the consensus statement, and you can see, again, with that consensus statement, I'll not read it all out to you, you can possibly read it. The Department of Health, the Royal College of Practitioners, the Royal College of Nursing, the Royal College of Social Work, they have also, that consensus statement came up, and with regard to that, what they're sort of saying there is, okay, we know about patient confidentiality. If the patient says they don't want the person to find out or to know about it, there are other ways and means of helping by just saying what you think can be needed, or the professionals can, and social workers can speak with them, and, you know, without breaching that confidentiality. And I think that is something that has, you know, years ago they used to talk about it was an excuse, this confidentiality, just not to be bothered talking to the carers. And okay, there might have been a wee bit of that in it, but I do think now that things have improved greatly, and there is that open aspect now of asking the carers and trying to see if that will help. So it's good that things are improved that way. Okay, next one. What carers can offer professionals? Again, assist in assessments and diagnosis by providing medical histories and family information, just on that point we're talking about. Contribute to decisions about the suitability of treatment. Based on past experience, the carer can give past experience, especially when it comes to things like personality disorder and things like that are more difficult to get your hand around. Advocate on the ill person's behalf, advocate on the ill person's behalf during periods of incapacity. Provide a supportive network of relationships. Provide practical, financial, emotional support as the ill person recovers, and triangle of care. Thank you. Next one, thank you. And again, I think I have this one up because I do think it's so important, the ever important role and increasing dilemmas faced by you approved social workers. I mean, I know a social worker can be so valuable and important for families. And I know in Shannon Clinic, they do certainly are very happy with the social workers and the work that they do and go out and speak with them and help them. But I'm also aware of how difficult it is for social workers, especially when you're having to go out and help with detentions and things like that. I know I can honestly say that way back, it was actually a social worker friend who told me, why don't you get in touch with Cause all those years ago, and maybe they'll be able to help you. So I do find that the social workers have a big part to play in the recovery and the support and help of all the people that they're working with. So I think it's something that you have to be so keyed into and clued into, but if you are, you can be an absolutely brilliant social worker. So thanks for that. So I think we're nearly finished. You'll be glad to hear. That's us. So that's us finished now, and thank you very much for listening. I even know my voice is croaking here, and if there's anything you need to ask or anything you want, any help or support or anything, you can contact me at any stage if I can be of any help to you.
Thank you. So we just have a few minutes if anybody would like to take the opportunity now to ask or any questions or any comments. Thanks from Phil as well. Phil, sorry, yeah.
Maura, thank you for that really enlightening discussion. It's good to see that things have moved on and that you feel in Cause that carers are much more involved now in discussions around their relatives' admission and the diagnosis, and that really important information that you bring as well. I think it's been useful to help us to refocus on the impact on carers, on families, both on the illness that the person has themselves and their condition, but also in how we interact with the patient. You made a really good point around confidentiality, and I do agree that I think that we all did use confidentiality as a reason why we didn't consult as much with carers. So it's good to see that that has moved as well. I'm just wondering, one of the case scenarios that you talked about, and it's something that I hadn't really thought about in my practice before, about how the mother wanting to continue to give support to her son who had unfortunately carried out an act the dad had died as a result of, how she was really isolated from the family. I don't think that we've really considered that either as part of the SAI processes or within our own practices. And it's maybe something for me to take away from today more. So I would like to thank you for just raising that point and helping us to refocus on that again.
Yeah, thanks, Phil. And I do know myself, just as you're saying, with sitting on the SAIs and the level 3s, it does split families big time, and it's a lot of, it can add a lot of extra stress and strain to the situation.
Thank you.
Okay, thank you.
There's further thanks on the chat there, Julie. Yeah.
Thank you so much, Moira. That was really, really helpful. And I suppose I just want to pick your brains a wee bit in terms of the kind of overall regional perspective and what you're hearing from the people that you work alongside, particularly in relation to substance use, whether you're seeing this more and more, and what your view is of some of the responses from services around the comorbidity and substance use and mental health.
Yes, Julie, it has become a big, big thing, much more, and especially for even our patients that go maybe out into the community. And I'm just talking about different ones that maybe do end up on the streets, because there is that far more to do with drugs, now, and the temptations, and there's seems to be so many more aspects of being able to get it, you know, for the patients. What I do think is that, I mean, there was a lot of talk a few years back. We were supposed to get dual diagnosis nurses, and there was one appointed, and it only lasted about 8 months. Something happened, and then we're going to get some more, but that has never happened. But then I was speaking to someone, and I believe in Derry they have they actually have someone in the doctor's surgery, and I think that's the sort of thing we really do need in the doctor's surgery. We need somebody with mental health training or whatever, so that when they go to the GPs, because very often the GPs do not know, you know, that that person have a mental health problem. I've heard some people saying to me, oh, that they've said, oh, well, you know, you should try going for a walk or try knitting or something like that. So if you had the someone in those surgeries to be able to, and they do have it seemingly in Derry, which is a great start, I think that would help, because the thing is with the drug situation now, it just seems to be, it's just gone overboard. I mean, I was in Belfast myself a few weeks ago, and I was absolutely shocked. I couldn't believe the number of people that were lying indoors, you know, and you know, it didn't used to be. Maybe years ago you'd have seen one outside the Opera House or something, but it is a big worry. And I do think what you need is, you need the people to work together very strongly. It shouldn't be, again, you probably know yourself this anyway, Julie, that, you know, the case used to be if you had a mental health problem and you had a drug problem and the two together, they would turn around and say, well, we can't see you for your mental health until you've cleared yourself of the drugs. Well, that's nonsense, because the two of them go together. So they should actually be collaborating and working together to get that sorted, you know, because one, you can't say to somebody, oh, wait until you do that and then we'll look at your, I mean, you know, it doesn't make sense, because some of them are using the drugs for self-medication, you know.
Darren.
Hi, Maura. It's just really to reiterate what Julie and Paul has said. I just really want to thank you for agreeing to kind of come along today to do this. And, you know, it was really refreshing. I think it's always really good to hear that care perspective through all the work that we do originally. So I just wanted to thank you for that. And also, I think it was really good to hear some of the things that you identify as unmet needs that we've got currently going on, especially within that forensic world. So for me, that was really helpful as well too. And I'm sure that everyone here today really got something from that. So I just felt it was really important to say thank you.
Well, thank you very much, Darren. Thank you. It's a privilege, as always.
Great. We better move on to the next presentation. Thanks again.
Okay, thank you. Thanks, Gavin.
So up next is Dr. Pierce McCusker. So Pierce is a senior lecturer in social work over at the University of Edinburgh, and he has responsibility for the equivalent of the sort of ASW program there, the sort of mental health officer training course, which has the parallel sort of qualification with the University of Edinburgh. And he also has agreed to be the external examiner for the ASW program. So he's just started that role. So we're delighted you're involved, Pierce, and thanks very much for presenting today. His focus today is on the context in Scotland, where there have been some very interesting and sort of potential developments.
Okay, well, thanks a million for the invite, Gavin, and lovely to see everyone here today. You can probably tell from the accent that I originate from Northern Ireland, but I've actually been in Scotland now for nearly 30 years, which is hard to believe. But nonetheless, my links to Northern Ireland continue, not least, as Gavin said, taking on the external role for the programme at Queen's, but also I'm doing some work at the minute. My interest in mental health spans the kind of preventative continuum all the way down to the stuff that we're talking about, you know, the more statutory kind of end of things. But on the preventative side of things, I've done a lot of work on mindfulness with social workers, and a colleague from UCD, Alan Maddock, and I have been doing some mindfulness research with social workers in Northern Ireland. And interestingly, we have a final session with social workers in Northern Ireland tonight. So it's nice to continue those links back to home. So yeah, I'm going to try and share my screen just now and see if I can get my presentation up. So maybe Gavin or someone can let me know if that's sharing.
Perfect. Yep, that's it.
Yeah, okay, brilliant. Okay, so yeah, I'm going to talk about the review of mental health and capacity law in Scotland, and a little bit about the role of the mental health officer, and basically, I'll tell you a bit about the background essentially, because I think it's important to understand that to get the context for the review. I'll talk a little bit about the MHO role as it stands currently. I'll outline the case for change, and then I'll talk through some of the key recommendations from the review. It's interesting to be at this event because there's a fair bit of overlap with some of the information that you've had already. You know, we've just heard Moira's very poignant contributions about carers. Now, I'm not going to focus on that, but this review has had carers' experiences and the importance of unpaid carers front and centre, along with the views of service users. But the material Lisa was talking about this morning, while I wasn't able to stay for Anya's talk about the experience in the Republic, I'm aware of, having heard her speak before, that there's a fair degree of coalescence around some of these ideas. We're a bit further behind, if you like. I don't think that's a bad thing, because as you'll probably see, we've learned from some of the initiatives that have been taken forward by yourselves in Northern Ireland and other jurisdictions. But anyway, hopefully this adds to what you've already heard about the kind of drivers for these changes and what the potential new forms of legislation and practice might look like. So basically, as it stands, we have three kind of key pieces of legislation in Scotland, each of which performs a distinctive role, but there's some overlap between them, and in some situations they can be used at the same time. So the first one is the Mental Health Care and Treatment Scotland Act, which was brought in 2003, and it's the main piece of legislation that refers to people experiencing in the terminology the Act used, which is mental disorder. Which nobody really likes, and is one of the recommendations for change in the review. The second is the Adults with Incapacity Act, for adults whose mental capacity is limited for various reasons. It was amended in 2007, and there was also quite an in-depth consultation in 2018 to revise it, but it became clear that revising any of these statutes in isolation wasn't going to make sense, hence the reason to hold off making any changes until the review reported. And then the final piece, if you like, is the Adult Support Protection Scotland Act, commonly referred to in other jurisdictions as safeguarding. And I appreciate that in Northern Ireland, as in other countries, there's not always safeguarding legislation as such. It may be guidance or policy, which is maybe a kind of debate for another day. But for now, I'm just noting this act at the minute. Mental health officers don't really have a reserved role in the legislation, but they are often directly involved as social workers or working with other social workers or professionals in adult protection cases. But it's certainly a key part of the legal umbrella for mental health and capacity and safeguarding, and it's part of the review, albeit a very small part that the review is considered, has nonetheless paid some attention to it. Adult safeguarding has also got a broader remit than mental health or capacity legislation as they stand currently, because it applies to people who have both or mental disorder and or incapacity, as well as people who don't. So just to talk you through quickly the statutes, the two key statutes. So the Mental Health Act was viewed as really progressive legislation when it was introduced at the time. It was brought in because the previous law was seen to be outdated, and there was a particular concern about European Convention of Human Rights requirement for proportionality, particularly around the lack of community-based options for mental health care and treatment in Scotland. It introduced a set of principles, and it was one of the first pieces of legislation to do that in a very kind of meaningful and in-depth way. I won't read them out, but they won't come as any surprise to you. A lot of it's about acting as signposts, if you like, for practitioners when they're considering how to approach any kind of particular piece of work. They also introduced a corresponding range of provisions, such as Lisa was talking about this morning, community-based compulsory treatment orders. We moved to having a mental health tribunal. Previous to that, long-term and short-term orders sometimes had to go to the Sheriff Court in Scotland, which clearly nobody really would think is appropriate anymore. We also introduced a right to advocacy, and that was, again, one of the first statutes to do that, I think, internationally. There was also a series of specialist provisions introduced, such as perinatal care for mothers and age-appropriate child and adolescent mental health services. Although it's quite interesting because just now in Scotland, we are in the process of developing a national child psychiatry inpatient unit. A forensic adolescent inpatient unit, which is going to be built, and that's almost like 20 years on from the Mental Health Act being introduced. So basically the point there is that it takes a long time from the inception of legislation to change happening on the ground. And lastly, the Act introduced more stringent criteria for the use of compulsory measures or coercive measures. Again, I won't go into detail, but basically these acronyms stand for emergency detention certificates, short-term detention certificates, and compulsory treatment orders in hospital and in the community. There were also more set times, if you like, for review processes to prevent lag and slippage. The AWI Act, there was a similar imperative for introducing it. Again, the previous law was seen as inadequate and was open to significant infringement of an adult's rights, which included exploitation. Adrian Ward is one of the kind of main commentators. He's a lawyer in Scotland, and he's commentated widely and was heavily involved in introducing this legislation. And he spoke about fragmented, outdated, and often harmful provision being in place previously. Likewise, the previous statutes amounted to what he referred to as all or nothing kind of approaches that were simplistic, and there was a loss of legal capacity rather than any kind of subtlety in assessing capacity, for instance, and thinking about it being decision specific. So the new Act brought in a wide range of new provisions that acknowledged the variety of levels of impairment, types of impairment, levels of incapacity, the emphasis on encouraging capacity, limiting restrictions, and introducing time-limited interventions after a carefully, kind of followed systematic process, all of which was underpinned again by a set of principles. And it introduced a range of provisions that kind of varied in their levels of restriction, from powers of attorney, when people decide what they want to do in advance, right the way up to guardianship orders, which are pretty, they can be extremely comprehensive and can have any number of powers attached to them to kind of make decisions about an adult's welfare. So within all of that, the mental health officer, which is the equivalent to the approved social worker in Northern Ireland, has pretty key roles in both of those pieces of legislation. So similarly to Northern Ireland, and unlike England and Wales, the role is still reserved for qualified social workers. And at the time of the Mental Health Act being revised back in 2003, and then again briefly in 2015, the argument was accepted that social workers bring that unique social perspective, and therefore it's important to have that as a counterbalance to any kind of medical kind of opinion that's being brought to bear in relation to decisions about the use of these measures. Like yourselves, the training's at master's level, and it's currently a 1-year postgrad cert, which is different actually to yourselves because yours is a diploma. There are three routes in Scotland, each with a slightly different configuration, but they all address the same national standards. And candidates need to have a minimum of 2 years post-qualifying experience and experience of working in mental health and intellectual disability, and all of them are nominated by their local authority employers. So within the Mental Health Act, first of all, MHOs consent to detentions in hospital under emergency detention and short-term detention certificates. Now, there's a caveat for the emergency detention certificates in that in situations where medics find it impracticable, that's the language used in the Act, to access MHOs, perhaps outside office hours, they can proceed. But that clause isn't available for short-term detention certificates, which can't go ahead if the MHO refuses. So, you know, a fair degree of power in terms of acting, as I say, is that counterbalance. Mental health officers are the lead applicants for longer term orders, whether they be in hospital or in the community, and they need to present those applications to the Mental Health Tribunal. There's a caveat here too, in that the MHO would still need to make the application if they disagreed with it, which is quite an invidious position to be in perhaps sometimes, but in practice it works pretty well, because in reality, you know, a mental health officer and the relevant responsible medical officer wouldn't want to turn up to a tribunal with an application whereby they disagreed about it, because it would just leave a lot of room for debate and confusion, and you know, potentially lead to the order or the application being refused. They also perform what's called a designated MHO role, and this was introduced by the Mental Health Act to provide consistency and continuity of the role, in recognition that service users can often feel that they're dealing with just too many different people, and when there's something as important as these decisions being made, and perhaps, you know, someone's in hospital or subject to some kind of order for months, if not indeed years, then consistency is even more important. They complete various types of reports. They're responsible for upholding particular rights in relation to the statutory processes, such as named persons, and informing service users about rights to access to advocacy. And they do provide a kind of more general guidance role to social workers and other professionals, for example, GPs, in relation to mental health law. Similarly, they perform a pretty key role in relation to the capacity legislation. So they attend case conferences and consider whether or not adults with incapacity measures are required, or if indeed lesser restriction could be achieved through adult support protection intervention, for instance. But where decisions to proceed are made, then MHOs lead on the application process again for intervention and guardianship orders, and you know, they've got a role in determining the kind of powers that are attached to those kind of orders. And as I said earlier, they're pretty far-reaching. So, you know, they can go down to the minutiae of, you know, what someone wears, to, you know, someone being restricted from accessing alcohol, for instance, say if they have alcohol-related brain damage. Okay, so with that kind of context in mind, you know, we'll turn our attention now to the case for change. And again, there's similarity and overlap from what Lisa was talking about this morning. So there were some, as I said, minor amendments made to the statutes, but there was an acceptance that root and branch reform was required, or is required, and that's driven by an increased use of statutory measures across the board, basically. I don't want to bamboozle you with statistics, but, you know, basically, as the bullet points there indicate, there has been a long-term increased use of compulsory measures across both mental health and the ASW Acts, including long-term orders, compulsory treatment orders in the community, and in hospital, and guardianship orders. And again, allied to what Lisa was talking about this morning, there's a disproportionate impact on specific populations. So talking about here people from Black and Asian and other minority ethnic backgrounds. Again, you know, this, I mean, it's pretty stark in terms of the statistical differences here. Likewise, for people who live in the most deprived areas of Scotland, they are most likely to be subject to detention and treatment orders. Alongside this, there's a concern that the safeguards that have been built into the various statutes have been slipping. So, for instance, mental health officer consent for those emergency detention certificates is really very, proportionately low, 40% overall, roughly, and indeed 22% in some areas. And the completion rates for social circumstances reports are also really low, and they're designed to be, informative about someone's social background and bring again the social perspective so that, wider considerations about care and treatment and support can be attended to. Also, there's a concern about principles of the legislation not being attended to. So Colin Mackay and Jill Stavert, both at Napier University, have written about this. And they've spoken about critics suggesting that the acts were characterised as promoting and protecting the rights of people with psychosocial or intellectual impairments, but in practice operate to provide legal protection for professionals to take decisions which the person may not agree with. And so they're really drawing attention to the fact that the principles don't seem to be working. Again, another key reason for change. Alongside this, you've already heard about the UN CRPD and the European Convention on Human Rights, and in relation to the first, the ECHR, I won't go into detail again because I'm sure you're familiar with all of this, but the rulings in relation to Bournemouth, and Cheshire West, which significantly widened the understanding and clarified the understanding of deprivation of liberty, precipitated change, basically. It precipitated a lot of concern and confusion amongst agencies and practitioners in Scotland about practice around, this area. And this was actually exemplified recently in a report by the Mental Welfare Commission, which investigated concerns about moves from hospitals to care homes during the pandemic. And in some, it found cases of unlawful moves taking place. So while some of the concerns related particularly to the pandemic, the report also found more endemic examples of poor practice, a lack of understanding about the law, a lack of understanding about good practice, confusion of the nature of placements, misunderstandings about power of attorney, and in some, meaning that many of the moves were made without valid legal authority. There was also a lack of uniformity from one kind of health and social care board to another, with different approaches taken to, kind of applying legislation. As well as this, the system, to be honest with you, is logjammed in relation to statutory mental health and capacity. So it's kind of creaking under the demands of statutory orders, and there's a huge backlog, for instance, of guardianship applications in most local authority areas. So again, there's been a need for systemic change for some time. In relation to the CRPD, so the key developments, there are lots of them, but I'll just talk briefly about Articles 12 and 14 as interpreted by the United Nations Committee on the Rights of Persons with Disability. So Article 12 in relation to legal capacity, very clearly saying that we need to replace substitute decision-making with supported decision-making to uphold rights, will and preferences of people with disability, including mental health issues. And Article 14, the right to liberty, which they interpreted as meaning that intervention based on mental health was discriminatory, and that forcible treatment and in detention, also based on mental health diagnosis, was illegal. So all in really radical changes. Now we know that since then debate has contested, the incompatibility of retaining some forms of substitute decision making, detention and forcible treatment with the CRPD, based, for instance, on the need to intervene to protect a person's right to dignity and well-being, safety, etc., where they cannot make a meaningful decision. But it's accepted by the powers that be in Scotland that, as it stands, the Mental Health and AWI Acts aren't compatible with the CRPD, so change is required. So where are we? Well, at a very interesting point. I hope you'll agree once I've finished exploring it with you. So all of this coalesced into the setting up of the Scottish Mental Health Law Review in 2019, and it's just published, well, in September of this year, published its final report. It was based on really wide-ranging consultations with people with lived experience, a real emphasis on co-production, and that's reflected in co-production, and the voice of people with lived experience being the first recommendation or set of recommendations that the report makes. Also wide-ranging consultation with practitioners and experts, and indeed Gavin and Anya Flynn contributed to some of the expert panels that the review process organised. And some of this, there was a series of subgroups, and I was lucky enough to be part of the subgroup that looked at the issue of capacity and support for decision making. And again, we listened to a range of experts about these very, to be honest with you, complicated and difficult concepts to get your head around, and particularly how we put them into practice. But in some, the review has concluded that it's not going to adopt an absolutist, or it's not recommending that the Scottish Government rather should adopt an absolutist approach. And what it means by this is that it doesn't want to tear down the house by adopting what they define as the absolute position advocated by the United Nations Committee. And in this, it acknowledges the very real fears expressed by some of the service users and carers that took part in the review about, should all forms of compulsion be removed, and asking the question, well, where would this leave them? For example, at times of, significant mental health crisis. But having said that, the review is committed to developing a radically different legal framework founded upon human rights. And this is consistent with the Scottish Government's wider ambitions for all Scots law in this regard. So at the minute, the Scottish Government is trying to progress a human rights bill through the Scottish Parliament. And you might be aware that there's been some controversy in relation to the relationship between this process and the Westminster parliamentary process. And as you can probably imagine, there's lots of political stuff going on in the background in relation to a small matter of the desire for independence amongst a range of people in Scotland. But nonetheless, this is the stated position of the Scottish Government, and it's so the human rights position has heavily influenced the mental health review process, as hopefully you will see. So I think actually it's a really exciting and profoundly different legal framework and set of recommendations. And personally, as a social worker, I should have said that I was a practicing social worker for 10 years, and for I think 6 of those years I was a mental health officer, and I worked as a manager in a community mental health team for a number of years as well. For me, it's really exciting in that it aligns very closely with social work values in terms of its commitment to human rights and social justice. And this is expressed in really explicit reference to a rejection of framing mental health and disability in medical terms, and instead to adopt a social or human rights model of disability and mental distress. And this is evident all the way throughout the review. I don't know if you'll get round to reading it because it's about 900 pages long, but it's threaded throughout, and it's particularly evident or foregrounded in the opening chapter of the report, which is illustrated in a couple of quotes that I've pulled out for you. So the first one cites Thomas Hammerberg, who was a former Council of Europe Commissioner for Human Rights, who said that it moves from viewing human disability as a personal problem that needs to be cured, in brackets the medical model, we have come to see the source of the problem, the society's attitude towards persons with disabilities. which means that we have to act collectively as a society in order to remove the barriers that hinder persons with disabilities from living among us and contributing to our society, and to fight against their isolation in institutions or in the back rooms of family homes. A shift away from welfare policies and charity as the only tools for dealing with disability to an approach based on human rights and equality. So really important that the review is, putting these conceptualizations of what mental health, what new legislation should look like. And they also talk about a shift in the law from one which is primarily focused on authorising and regulating actions which may limit a person's autonomy to one where a person's rights are respected, protected, enabled and fulfilled. The emphasis on human rights and taking a structural approach, as I said, is evident throughout the report, which is directly referred to in relation to issues of inequality and discrimination, things that the evidence that the review has found in the process of its 3-year consultations. So in this first quote, in relation to people with mental or intellectual disability, and in the second quote, in the recognition of the need for changing how services are configured to meet the needs of different communities, including, as the quote indicates, the importance of community-driven, non-institutional support to address the inequality people from ethnic minorities experience in relation to mental health. And I was really interested in the concept that Lisa was talking about earlier about collective community mental health services. I think this is probably the direction of travel that we would want to head in, albeit there's a lot more working out needed of what that would actually look like. And the review also really nails the inadequacy of what they describe a narrow focus in terms of legal and mental health focus. So the focus on law and mental health system and the medical aspects of care can mean that a person's pushed out of the system once their condition is judged stable, even where underlying issues have not been addressed. This can result in repeated and avoidable use of coercion. And so this last quote, I think is the last one, I think helps capture the philosophical difference between how the law is arguably framed in a deficit way currently to the positive kind of iteration the review is proposing. So, moving away from the current primary focus of mental health and capacity law as being one of authorising actions which encroach on an individual's autonomy to a focus on ensuring that all of the human rights of people to whom the law applies are respected, protected and fulfilled. So with that wider kind of aims and context in mind, what do these actually translate into in terms of recommendations? Well, the first one is that they are recommending fused legislation in a way similar to what you've done in Northern Ireland. So one act that would replace the current Mental Health and AWI Act, but the safeguarding legislation, the Adult Support Protection Act, would remain separate. And there are reasons for that I'm not going to go into now, but I think that's a good decision. So as the quote indicates, the reason for fusion legislation is that they believe this would address the current problem with discrimination based on mental health diagnosis and help to address issues with consistency across statutes and in practice. And this overarching ambition, if you like, and change would be founded on 3 key pillars: a human rights enablement framework comprising supported decision-making and an autonomous decision-making test. Importantly, the extent, if you like, of human rights would encompass economic, social and cultural rights. And I'll come back to that, but I think this is also a really exciting development because I think it's the first time ever that those kind of rights have been embedded in, you know, the equivalent of mental health or capacity legislation. I could be wrong, but certainly the emphasis that's placed on them speaks to the wider social determinants that Lisa talked about earlier in that brilliant slide that showed, you know, the kind of underlying issues that lead people to experience mental distress. So what does human rights enablement look like? Well, basically, they reiterate that, you know, the existing focus on authorising non-consensual interventions needs to go further. It doesn't ensure that a person's wider needs are respected. For instance, you know, a person's right to live independently and to fully participate in society. So if this is to be achieved, the law needs to reflect the rights that entitle a person to have these needs met. So a human rights enablement comprising supported decision making and the autonomous decision making test would seek to address this, and all of the recommendations are aligned with this framework. So they recommend another pretty radical thing from my perspective, which is that a legal requirement would be introduced for the Scottish Government to establish minimum core obligations for people with mental health or intellectual disabilities to secure their human rights, and alongside that a statutory duty on public bodies to secure those aspects of the minimum core obligations, and, you know, a recognition that codes of practice, etc., would need to be introduced. In essence, a human rights enabling approach would ensure that a person's will and preferences are known and given effect to. They would identify the broader rights in need of protection. All relevant human rights would need to be considered. And there's further kind of clarification of how this would be arrived at that I don't really have time to go into. That would weigh advantages to human rights against harm to human rights, and that would provide a plan of action for giving effect to rights and meeting the person's needs. You're clearly familiar with the concept of supported decision making, but this is one of the other key pillars. So I'll just rattle through this quickly because I'm aware time is moving on. So yeah, that's just their definition, or a brief definition of what supported decision making would seek to achieve. They recognise that there are current initiatives, but they've said that they don't go far enough, and also that there's limited research evidence for what supported decision making currently achieves and what it might achieve. They accept that resourcing is going to be absolutely key to this and all of the other recommendations that they've made. Interestingly, they distinguish between what they call a non-discriminatory best interpretation of the person's will and preferences and a best interest decision, saying that they recommend the former in favour of the latter because they say that the latter is potentially paternalistic. Yeah, and we could debate that till the cows come home, but again, it's just to kind of make that point. And obviously, there could be criticisms here of whether this is just a substitute decision making by another name, but they do address the need to scope out what would happen in crisis situations. Basically, they're talking that about in order to make this a reality, the Scottish Government would need to implement a supported decision making scheme across the 3 statutes that exist currently, but also develop one to support the development of the fusion legislation whenever that happens, and various other changes there in the 4th bullet point, as well as considering a national advocacy service to build on the developments around advocacy that have been achieved so far. Just quickly go through the autonomous decision-making test, and essentially they're accepting that there is a need at times to act without consent where it's impossible to get a meaningful decision from the person. But they're saying that we need to replace capacity and significantly impaired decision-making tests, which we have currently, with the ADM test to make them rights-based. They should only be made where non-consensual measures are being considered, not used to determine those measures, and of course every support used in advance of bringing in an ADM test. Yeah, I mean, the kind of criteria that they're suggesting, the first part of it will be very familiar to you. None of that's very new. The second bit may be more familiar, particularly the last point about the impact of any situational or environmental factors. So again, they're broadening the concept of, you know, what might impact someone's decision making way beyond you know, a kind of diagnostic issue, which clearly this would jettison. So, you know, it could be to do with challenging relationships. It could be to do with you know, family circumstances, etc., etc. So taking it way beyond what we do currently. Conscious that time is probably, we're finishing up at 3, I think. So yeah, okay, still a wee bit of time yet. So in terms of in relation to kind of doing away with the diagnostic bit, you know, and I presume Anya Flynn would have talked about this earlier in relation to who carries out these tests. Then, you know, the review have said that it would be the person or professional relevant to the, you know, the most experience relevant to the decision that needs to be made. They accept the comprehensive guidance that's going to be required. They also accept that, you know, more thought is going to be required for how one would carry out such a test in urgent situations. They also address deprivation of liberty and acknowledge that there's a need to introduce standards in Scotland as a matter of urgency, and they talk in some detail about the types of standards and the types of orders that might be introduced, and acknowledge also the right to review that you know, service users and carers need to have to deprivation of liberty standards. Other key areas include recommendations for reducing coercion, making this a national priority with a range of associated duties, developing alternatives. Again, this relates to some of the discussion that Lisa talked about earlier. Revising the criteria for detention and involuntary treatment, strengthening the rights of children and young people. They've got quite a lot of detail on the role and rights of unpaid carers, which is great to see. But they also acknowledge that there are huge challenges in bringing this, you know, very ambitious and, as I say, radical legal reform process into actually being. And they acknowledge that, you know, even in some of the really, you know, kind of positive responses that they've received from agencies, practitioners, carers, service users, professionals, all the rest of it, that they see an implementation gap, you know, between the ideal and reality. So they acknowledge that, and they say that in their view that the issues that affect this, such as staffing problems, resourcing, and all the rest of it, are actually an argument for stronger legal duties, not maintaining the status quo. And they say that, you know, we can't, if we accept that securing the full range of human rights is necessary, that won't be achieved by carrying on with what we're doing at the minute. So within that, they propose a staged approach to this legal reform process with short to medium term actions. So basically, you know, keeping the 3 pieces of legislation that we have currently, working towards a joint set of principles, developing the human rights enablement, supported decision making, and autonomous decision making framework across those 3 acts, and bringing in various review processes and tightening up time limits, etc. Amending the AWI Act in particular because of the logjam and issues to do with guardianship. And then in the medium to longer term, bringing in fused legislation, expanding the jurisdiction of the Mental Health Tribunal of Scotland to deal with all questions of involuntary treatment, including incapacity or capacity cases. And I think as well, there's a real a very kind of live recognition of the culture shift that's going to be required to bring about these changes. And again, some of those points were raised earlier. What about the role in all of this for the MHO? It's very hard to say, but I'd like to think that there's a really important role for whatever MHOs are going to be called, because the name will change. But social work more generally in this act, because as I hope I've tried to illustrate, that it really plays to our strengths in bringing a social model perspective to bear. But certainly in carrying out these human rights enablement assessments, in carrying out tests around autonomous decision making, in developing practice around supported decision making, we're already doing this. And I think it's a really important opportunity for social workers to grasp in supporting these changes, and also in some of the more short-term changes, such as those relating to guardianship and to the kind of range of amendments that I spoke about earlier that are being recommended for the 3 acts. So that's me, folks. I'm sorry it was a bit of a kind of race, if you like, through the legislation, because to be honest with you, we're just getting to grips with it ourselves. Sorry, I'm sharing and not sharing and don't know what I'm doing. And so, yeah, there was a lot for me to kind of condense there. But anyway, hopefully it's been helpful as a kind of overview, and I'm happy in this short time that we have left to pick up on any questions you might have or observations.
Thanks, Pierce. Is it really helpful and clear overview of, as you said, I mean, an awful lot of work and development. So thank you. Any comments or questions for Pearson in the next few minutes? Julie.
Hi, and thank you, Pierce. And I have to admit to a bit of reminiscence therapy, because I was an MHO a long time ago in Scotland, particularly when the AWI came into play. So it's really helpful to see the journey. I suppose that just in a very practical point of view, the designated role, the designated MHO, you've quite clearly articulated some of the logjam issues around statutory work. Do you think in terms of the review that designated role will be reconsidered?
Do you know, your name is familiar, Julie? I don't know if our paths have ever crossed. They may
probably have.
But yeah, nice to see you. Do you know, there hasn't been very much attention given to the MHO role. I mean, it's been acknowledged in the review alongside the roles played by, by social workers. Actually, social work is mentioned a reasonable amount of times, but also, other professionals as well are acknowledged. But it hasn't drilled down into, what particular professional groups might do. And I think they're probably leaving that because they're aware of so much else has got to be worked out in terms of the broader scope, if you like, of the legislation, because while this is what they're recommending, it's certainly, from my point of view, it'd be interesting to hear from everybody else, but from my point of view, it is radical. So now it's going to be a case of, well, what will the Scottish Government do with this? And what will the response from, albeit this is the final report, is the end of the consultation period, but there will be an opportunity for the Scottish Government to to go back out to professional groups. So I don't know the detail, but I would imagine, given the original argument was based on the need for continuity, that I would see an important argument to continue to be made to retaining that designated role. But yeah. So I think it's something that could well be featured, but it's hard to say if it's definitely going to happen.
Thank you.
Great. Here's we better leave it there. We're due to have a break, but maybe opportunities in future versions of our code or codes of practice to consider how those links to especially economic, social, and cultural rights, a fascinating sort of development might be made. But listen, thanks again, and Angela Donnelly was sort of just sort of also on the sort of chat, looking forward to welcoming you to the sort of the ASW program. So see you soon. Plenty of marking ahead.
Brilliant. Thanks very much. Thanks, folks.
Yeah.
Lovely to see you. Bye now.
So is that okay? Everybody will take a break now until 1:15. Right. Yeah, Paul, so hopefully people come back now.
No problem. Do you want me to start, Gavin?
Yeah, I'll maybe just introduce you, so which I'm happy to do. So good to see you. I'd like to introduce Dr. Paul Houghton, who's a GP and a clinical research fellow, and has led the development and evaluation of forum theatre approach to interdisciplinary training, which I think is a brilliant development, and it's been supported by Anya and Darren through the Office of Social Services. So looking forward to this. Thanks a lot, Paula.
Okay, thank you, Gavin, and thank you for having me along today to present. I'm delighted to be here. So I'm going to begin today with general introductions. I'm then going to give you a snapshot overview just of my work in this area to date, just to put things into context. And then I'll move on more specifically to discuss the forum theatre-based simulation work that many of you were involved with. And I will conclude today by handing over to Inspector Joni Beattie, one of our colleagues in the police service, to talk to us about the police perspective in relation to training. So to begin. So as Gavin said there, I am a GP, so I'm a newly qualified GP, so it's my second year out working. And I have a very keen interest in clinical education. So I work one day a week as a GP specialty training programme director with NIMDA in Northern Ireland. And I am in the final year of completing a research doctorate in medical education. And my whole doctorate is focused on trying to improve training for mental health crisis assessments. And the reason I picked this as an area to research was it occurred to me as a GP trainee that there appeared to be a bit of a gap in training in this area. So to introduce the research team I've been fortunate to work alongside. So Professor Davidson there needs no introduction today. I also, Professor Gormley and Dr. Reid are two GP colleagues and my supervisors at Queen's. Miss May McCann and Lisa Morrison are PPI representatives on the project, and Dr. Paul Murphy is a drama lecturer at Queen's. So this is just to give you an overview of my doctorate research. I began the project by really focusing on how best to develop training in this area. And I tried to find this out by doing a scoping literature review and a qualitative study. So my scoping literature review, the question was how best to develop training for professionals involved in the mental health detention process. So I conducted this across 6 electronic databases, and we had 1,130 articles included initially, and this was whittled down to 52 articles which we felt met the inclusion criteria. I then went on to present my findings to professionals involved on the ground. So there were 16 professionals came forward to take part in my study, and I basically did focus group interviews. So in total I had 4 online focus group interviews, and these were interdisciplinary, and I asked the participants how findings in the research or findings in the literature sit with their professional experience and how we can use this information to really develop training moving forward. And some of the pictures I've included there were just some of the data generated from these focus groups by the participants involved. So I went on to analyse this data using a template analysis approach. And the key message really, as I said, this is a snapshot overview, but the key message coming through from the literature and these focus group sessions was that there is a gap in practical training in this area. Many professionals said you end up literally learning on the job. And there was a clear call for interdisciplinary experiential learning. One approved social worker said, experiential learning is really, really important, and I think that's a big gap. So following on from this, I decided to develop and deliver a training approach. And in particular, I decided to look at adapting basically forum theatre as a simulation framework for teaching in this area. So I'll explain to you what forum theatre is just in a second. But I did a developmental phase of this work last October. And then in March this year, we did a feasibility study, which I know many of you were involved in. And then I'm currently doing another more in-depth development phase of research at the moment. So at this point, I'd like to say a special thank you to Anya Morrison and her colleagues in the Office of Social Services from the Department of Health. Without you and your funding, we would not have been able to do this part of my research, so thank you very much. So what is forum theatre? So forum theatre is a type of moral, interactive theatre that was basically developed by a theatre director called Augusto Boal, who lived in Brazil at a time of great political oppression. And he developed this theatre approach basically as a means of using the stage in a way to empower the disempowered, and to basically using plays to, I suppose, speak to the public and to try and empower them to make changes in their lives. So we became very interested in looking at adapting this as a simulation framework for teaching around mental health crisis assessments, as we think it has a number of key advantages over traditional simulation approaches. So I just have to introduce some key terms. If you were there in March, you'll probably already be familiar with some of these. So the people who are involved in the first play are known as actors. So you've got your very own James Todd there as actor in the middle. And then you have got the whole learning experience is basically facilitated by someone known as a joker. So you can see there Professor Gormley as the joker in that image. Everyone in the audience is known as spectators. And if you're brave enough to get up in the second play, you become known as a spectator. So you become a spectator who takes over the role as an actor. So in very simple terms, you can think of forum theatre in this way. The first play is pre-scripted. It's basically designed to have some form of oppression in it or an unresolved ending designed to go wrong in some way. There's then a forum in the middle for discussion and to think about how you might do some things differently. And then the whole play or parts or scenes from the play are then repeated again, but the joker tries to encourage those in the audience to get up and actively get involved. And the interesting thing about using a forum theatre approach, it's different than role play in that the spectators decide what way the learning event goes. So each day you do it, it can go completely different. So the feasibility study that I was talking about was hosted over 2 dates in March. So our objectives were to design and deliver a half-day interdisciplinary forum theatre teaching event. So we started off thinking we would do 1 half day, but to try and get as many people as possible to benefit from it, we decided to actually host 2 half days. We wanted to assess the feasibility of training delivery and to also assess participants' acceptability of the learning approach itself and the evaluation design. Then we as a research team had to reflect on the findings and decide on next steps. So before we could actually host the teaching events, it was so important to prepare the acting troupe. So what I mean by this is we had to first of all agree on a script for the first play. So we put together a script, but we had to all agree that it didn't represent any professionals in a bad light relative to others. And also, believe it or not, it's really hard to do something wrong when you're told to, particularly in front of different professional groups. So it was so important that everybody involved in the first play were comfortable with what they were doing. And we hired 2 professional actors to play the patient role and the carer role. And then we had a volunteer ASW, GP and police representative to step in and to that first play as well. Due to COVID, we had lots of last minute changes, but we got there in the end. So I think the Oscar definitely goes to James Todd for his contribution in this from an ASW point of view. So thank you, James. It was really helpful to have you involved. So in terms of methods of evaluation, we got participants to fill in a pre and post event questionnaire. I emailed these out to participants in advance, but they could also access them on the day by using their phones to scan a QR code. Each day, we had 4 parallel interdisciplinary focus group sessions. So in total, we had 8 interdisciplinary focus group sessions, and participants took part in these immediately after the training event. And then we as a team went and individually reflected on the training approach and how it went afterwards as well. So this is just an overview of participants. We had 68 participants in total, 27 approved social worker trainees, 22 GP trainees, and 19 police representatives. So we were happy with the participation numbers there. So I'll just give you a brief overview of what the questionnaires showed. So we asked participants to how they would rate this forum teaching or forum theatre learning experience. And you'll see a breakdown of the results there. But we were really, I suppose, encouraged by the fact that over half of the participants rated it as the highest rating excellent. We then asked the participants to give it a rating relative to other teaching experiences that they have had to prepare for this crisis assessment. And again, the results were very encouraging. You will see there 74% rated it as being much better, which is really encouraging. And we also asked our participants, was this an acceptable method of learning? And participants strongly agreed that this is an acceptable method of learning. And basically, we found that there was an average acceptability rating of 4.73 out of 5. 98% felt that it was acceptable to complete questionnaires before and afterwards. And everybody in the focus groups was mad to know the answer to this question, so that's why I've included it. Just out of interest, we asked participants if they would feel comfortable being an actor in the first play. So that's a play that we plan in advance. We anticipated that maybe people would be a bit shy about this initially. So we were kind of right in that regard. Before the event, only 3 people said yes. But after the event, it's really interesting to see that this went way up. So 23 people said yes. So we feel that the more people get used to this training approach, the more willing they will be to participate even in that first play. And everyone 100% said that they would recommend this teaching approach to a fellow colleague. So we got really encouraging feedback comments in the free text section. One participant said, excellent setup with very open discussion and learnt a lot. Another participant said, good to see each profession challenge each other and then work with each other to agree how to work things to as best as possible for the safety of the patient. So I went on to analyse the 8 transcripts from the focus group sessions. So those were really interesting. Again, I used an iterative template analysis approach, and there was 2 core themes coming through. The first one being a call for more, an approachable and acceptable method of training. And within this, we identified 7 sub-themes. And the second core theme was evaluation methods, no issues raised. And within this, there was 2 sub-themes identified. So just to give you a flavour of the data, I'm going to go through each of the sub-themes in turn, and I tried to pick out 1 or 2 quotations from each. And I've put the profession in brackets afterwards. So the first sub-theme coming through was, there appears to be a real need for training like this, and there's definitely a call for more of the same. You'll see there, one ASW trainee said, I think it's very valuable. You could do a full week of this of different scenarios. The second sub-theme was this sense that this learning approach really helped them get into the moment. They felt that, they really embodied in the learning experience. A police officer said, I was really, taken into it. A GP trainee said, the actors immersed you in it. In every focus group session, there was this real clear pattern that, there's such benefit from learning together. There's such benefit from interdisciplinary learning. One ASW trainee said, I think it's crazy that we're all doing it separately, but the expectation is in reality to be doing it together. A police officer said, 18 years in the service, And this is the first time I've ever experienced frontline workers all coming together collaboratively to sit and appreciate each other's roles. There was also this sub-theme coming through that this was really a safe space to have those challenging conversations, but also to learn from each other. One ASW trainee said, "I feel like I learned a lot from the spectator actually. I was like, he is brilliant. Just about giving space to answer the question and kind of removing any element of uncertainty for the patient and everything." There was also this clear, I suppose, pattern coming through that this learning approach felt more authentic, it felt more real than traditional role plays. One ASW trainee said, "You wanted to make sure the actor was okay, so it was very realistic." Unsurprisingly, some of probably the more shyer people in the audience were very keen for there to be clear ground rules established at the start, whereby they knew that there was no risk of them having to get up in front of people and take on the spectator role. And they suggest that there's so much learning by just observing. So they wanted that safety, that they wouldn't have to get up if they didn't want to. One police officer said, "You learn just as much by watching and observing. Some people are really comfortable with getting up, and lots of people just aren't. So having that option of feeling safe to make that option, I think." And the final sub-theme in this category was group size. So there was a variety of different comments. Some people felt that people might be more willing to participate if the group was smaller, but on the whole, most people seemed to find the numbers acceptable. So one ASW trainee said, "I think the numbers were good." And there was actually a suggestion that the larger group was better for group discussion. One GP trainee said, "I think that it's actually better in a bigger group because there are more brains." So the second theme was about the evaluation methods. And really the overall message here was there was no concerns. People seemed to find the questionnaire straightforward to complete. One ASW trainee suggests that she's going to steal that idea with the QR code out the front. It was so easy. And there was an overall, I suppose, acceptability of the focus group sessions as well. One ASW trainee said, "I think it was perfect." And another suggested that the focus group is a bit of a debrief. So overall, the feasibility study seems to have got the seal of approval from participants in terms of the learning approach and the evaluation methods used. So we as a team then built in Microsoft Word forms online, and we tried to weigh up the pros and cons. So just reflecting on some of the cons first. So there is no doubt that this learning approach, it takes considerable time and resources, especially when compared to other approaches like PowerPoint teaching. And there is a lot of advanced planning involved, particularly at this stage when we're developing the approach and the framework. Also as well, the interdisciplinary element, whilst it's great, it can be more challenging to organise because you're trying to get an awful lot of people free at the same time. You're trying to get shared learning objectives, and you also have a lot more people to teach and involve in each of the sessions as well. But we feel that the cons outweigh, or the pros outweigh the cons. I'm getting tongue-tied there. The feedback was overwhelmingly positive. So it was in the data, but also I received so many emails and text messages from participants just thanking me for organising the training afterwards, which I was a bit taken aback by. And I think we as a team are really trying this teaching approach further. If we can secure the necessary future funding, we do believe that it has lots of potential to be, incorporated into annual training for respective professionals involved. So where to next? So we as a team have decided that we're really keen to further refine the forum theatre teaching approach. So I'm in the process at the minute of going back through the questionnaires and focus groups, but this time I'm analysing the data with this research question: how to further refine this teaching framework for practical implementation. So I'm basing this on our responses as a research team, or our feedback forms, and also from the questionnaires and transcripts from the participants as well, as we would be keen to develop the approach further. We are going to, so I'm submitting my doctorate thesis in March with a viva in May, hopefully, but we're hoping to do another Forum Theatre teaching event at the end of May so that the current ASW trainees get the opportunity to do it as well. And all going well, I'm hoping to have a number of publications linked to this. So I've already submitted the first 2 parts of my research for publication, but I'm hoping to do an article on the feasibility study and a separate article on, this developmental, simulation-based developmental work. And I'm also working on a paper with Lisa and May looking at PPI involvement in mental health research and education. So on that note, one of the highlights for me as a researcher has been having May McCann and Lisa Morrison involved, and just having that carer and patient with experience, perspective on things. It's been so crucial, I feel, to the research and also to the education delivery. May reminds us here to consider it could be you, it could be your child, that this crisis assessment is something that can happen to anyone. And I think one of the most encouraging comments I have received in my career to date was from Lisa Morrison, who said to me that this project models the openness, curiosity and respect needed for authentic co-production. And that's really what we were striving for in this project. So it was so nice to hear her say that. So I'm happy to answer questions afterwards, but I'm a GP. You guys are all ASWs, and I thought it was only right to invite somebody from the police along today to give the police perspective on this training. So I'm going to stop sharing my slides and I'm going to hand you over to Inspector Joni Beattie.
Hi Paula, can you hear me okay?
Yeah, I can indeed, Joni.
Okay, everyone, thanks very much, Paula, for the invite to come along. I'll just take a few minutes. Paula's just asked me to come along, I suppose, and give a brief overview of how I found the event whenever I attended it. So I suppose from a personal point of view, it was very enjoyable. I am someone who's a very visual learner. You can show me things 10 times on paper, but unless you show it to me visually, or even better, if I can get it, experience it and do it in practical terms, then I'll remember it forever. So it's definitely, from a personal point of view, it was the best type of learning for myself. But then I suppose from an organisational point of view, from the PSNI point of view, I mean, we all know we're trained, we know what our organisational objectives are and what my bosses, what the expectations are of me, and what my statutory requirements are and what my legal requirements are when I'm dealing with somebody in a mental health crisis. But we don't get taught the part that other statutory bodies play in the whole overall picture. So the fact that we got to work alongside GPs and approved social workers was so invaluable, to see just where our small bit of the jigsaw puzzle. I think that's really important. It also gave me an opportunity to to ask the approved social workers or GPs, what would you like from us as an organisation? How could we maybe present things differently to you? What would you like me to take away and tell the officers under my command? Are the issues and the concerns that you have, and how I could feed that back so we could communicate better. Communication is key in all of this. So that was one of the huge advantages for me in the training. So I've just made a few notes here. So I'm just trying to make sure that I've said everything that I wanted to. And I think the most poignant thing, and Paula rightly says that it was totally different from role play, because role play training would usually be done just within your own organisation, but this was with all the other statutory bodies as well. And having the actress there and the actor, it was really poignant. You really, I don't know, I got sucked real into the emotion of the whole thing and really genuinely wanted to help this person, and that, having that all those thoughts going through my head of how I could help this person, what I would say. It was just really fantastic learning for me, and also there was representative there. Was it a patient representative, Paul? I'm not sure if I'm maybe describing her right or not.
Yes, Lisa was there as the patient representative and May as the carer representative, Joni.
Yeah, and so to have them, and it wasn't until the end, I think, that Lisa, came on and made the comment that still sticks with me, about being careful of the jargon that we're using, and when we're talking to each other as professionals, whenever the patient can hear what we're saying, the language that we use, talking, frequent flyers, repeat people, problem child, all those sorts of things, and how that makes them feel, and that we should always respect them, and that in the middle of the whole thing, as we are as individuals within our own organizations, and is somebody who's broken in the middle of the whole thing and is just crying out for help. And I suppose that really was the big thing that I took away from it. So definitely a lot more impactful than just doing a role play. So yeah, overall I find it really beneficial, and I would absolutely love to see it upscaled and see it rolled out.
Okay, thank you so much, Joni. Thank you for doing that. And I just thought it would be helpful to have that police perspective as well. I'm happy to answer any questions. I know that my doctorate supervisor, Professor Gormley, is here as well. So we're happy to take any questions if anybody has any questions.
Brilliant. Thanks very much, Paula and Joni. And indeed, it's a great overview, and sounds like it's really sort of going very well. So congratulations. I mean, as you said, you clearly had to put a lot of work into getting everybody together. So well done. Jerry, do you want to make any comments before we give everybody else a chance to ask any questions or comment?
Thanks very much, Gavin. I hope you can hear me. I really can't add to what Paula has delivered very well. Paula's worked very hard together with the team to develop this model. But ultimately what we want to do is to have a model that is actually deliverable and potentially go beyond just mental health crisis. It's a platform for allowing not just the cognitive learning, but that behavioral emotional learning that we all get when we face that individual in crisis, and how we can best respond to them. I mean, forum theatre is not new, but actually I think the work that Paula is doing is really to refine and bring something that is really embodied, experiential, into hopefully a regular training session. And I think one of the big benefits of this training is that, the actors, you can control the destiny, so you can really imagine what you would do, but the big thing is actually you learn from each other. So that sort of, collective thinking and sharing about each other's roles is something that I thought was very useful. But I'm happy to step back here, Gavin, and happy to help Paula if there's any questions from your colleagues.
Any thoughts?
Can I ask something, please?
Great.
I just was thinking about this actually, and I think that's where a lot of our interface problems come from, is that people don't understand each other's roles, and it's a very heightened, anxiety-provoking time. You're very worried about the patient. You're doing a legal framework. You are depriving them if you're compulsory admitting them to hospital. So there's so much there for a practitioner, whatever their role is. So I just wondered, have you any evidence to see that enhanced interface, or is that too early yet?
Well, I suppose it's a good question. And really in the literature, in the focus group sessions I did, and even in the focus group sessions from this, everybody kept talking about each other's roles. Rhonda, it was quite fascinating. Even in the focus groups at the end of this, we had to keep bringing them back on topic about, what we were asking them, because they were all asking each other different questions about their roles. And if you did that, and if you did that, and I felt like a bit of a secretary for the week after, because people were asking me, could you pass me on such a person's email address, because I met them, and I was thinking about a project we could do. So we did ask them, about interdisciplinary training. Have you done this before? And, was there any benefit from it? And there was a clear, I suppose, in the actual data from the focus groups, people kept talking about how it helped them, I suppose, understand each other's roles. Because this was a feasibility study, we were focusing more in specifically and asking them, you know, about the learning approach and things. But if I were to go back to the data from the focus groups, it's in pretty much all 8 of the focus groups, people go off talking about what they learned about the other people's roles. And it was actually quite amazing because lots of the GP trainees as well, and myself included, I didn't know the difference between a social worker and approved social worker when I first started out this research about 4 years ago. And it was amazing, like all the GP trainees on the day and the police as well were saying, gosh, we didn't know the difference, you know, and that in itself is huge. So it was fascinating. But in terms of data about improving their knowledge, is that what you were asking?
No, I've just wondered that on practice level.
On a practice level.
Yes.
I think ideally that would be one of the questions if you were doing a follow-up study. Would be asking them, did it have an impact in your longer term work, you know, in terms of your understanding of respective roles?
Definitely.
No, definitely. Yeah. But I think, to be honest, if I had to put a bet on it, I'd say yes, because that was one of the things everyone talked about in all of the focus groups.
I can imagine, yeah. Thank you for that.
I just jump.
Oh, sorry, Jerry.
Please go ahead.
I think, is Joni saying something as well?
Yeah, Joni and Jerry, sorry, yeah, great.
Sorry, Jerry, if I jumped in. And just I suppose from my own perspective, at the time leading up to the event, we were having issues from Ananoma with misunderstandings that the GPs had as to police powers around liberty and things like that. And that is something that I really pressed whenever I was up at the event, and I spoke with a couple of the people from the GP trainees, and that was definitely fed back 100%, because we had no issues at all after that, and that really improved relationships between ourselves and GPs, because the GPs thought we just weren't doing our job, whereas in fact we just didn't have the powers, the same power across the water. So fact of that 100%, that helped us.
Yeah, and on that note, Joni, you've actually reminded me, I feel I have these focus groups embedded in my head a little bit because I've been listening to them the past few months. But there was one focus group session, I think it might have been one of yours, Gavin. The police service were actually talking about this protocol that they had in the Southeastern Trust, and about how people didn't seem to be using this protocol. But it was quite interesting because everybody else was going, what is the protocol? Like, we didn't know the protocol existed. Can you signpost us to what your protocol is? So that in itself showed that a lot of the times it's to do with just that baseline communication missing, but everybody kind of expects the other profession to know what they've developed. So yeah.
Can I jump in there?
Yeah, great, please do.
Sorry, I don't want to hog the space, but a really good question, Rhonda. And I think 2 things. Obviously, Paula's work was really to develop this model before potentially to skill it out. It's better to get it right at this stage before you skill out, so that will come down the line. But what I really value about your question is that, you know, that we have.
Sorry, my battery's about to die there.
It's okay. I'll keep going to. But it's whenever, you know, for example, as I'm a GP, and my learning from the mental health detention process was textbook, and then the first time was to do it live. And because it's so infrequent for us, we don't get that chance to maintain those skills. And the idea that cognitively we know what to do, but then to do the behaviors, emotional regulation, your own safety, so that it's that tacit knowledge, what people do in that moment. And we do believe that it's taking people to that sort of sense of what it's like and what would be. And the nice thing is we can pause and people can think and share their experience. And also, it's the first time I've ever done any training with PSNI and actually with approved social workers. And I learned so much as a GP from that one day. Even though I was part of the research, I've taken that back to my own practice.
That's brilliant.
Okay, we better leave it there. Darren, who organised the conference, is speaking next, so we better move on. But listen, thanks again, Paula and Joni and Jerry. I mean, it's brilliant to see that and to see it working well. And yeah, and it would be great to see it developing into a routine aspect of training. But listen, thanks again.
Thank you, and thank you for having me along to speak. Thank you.
So Darren's up next, along with Julie Haslett. So Darren, as you know, is a professional social work officer in the Office of Social Services, and as mentioned, organised the conference today. So thanks for getting us all together. And Julie, I mean, you also know as the social care lead in the strategic planning and performance group. So over to Julie and Darren. Thanks.
Thanks very much, Gavin. And we seem to have the hardest job after coming after all of those really enlightening and very, very helpful presentations beforehand. And I have to admit, from getting increasingly nervous as the day goes on in terms of delivery of this. Very conscious of time, so I'm not going to protract it any longer than it needs to be. But really just the purpose of this presentation is to give you a bit of an overview of some of the regional challenges and some of the potential solutions that we're looking at in terms of addressing those challenges. Myself and Darren are working very closely on this agenda, myself from the commissioning, service development and performance management perspective, and Darren from the very clear professional perspective, and he does a lot more than that. But we are, having both been practitioners, Darren's very lucky, he's been practitioner in Scotland and here, have a very keen understanding of some of the complexities of this role, and both feel extremely privileged to be working with ASWs and the ASW lead group. And just like before we get into the detail, just to echo the sentiments that Phil raised earlier on today, in terms of the thanks and praise for the workforce, because we are very aware of the increased complexity and the demands and the competing demands in the workforce, and have to say that the ASW workforce has stepped up without exception. So thank you. So I'm just going to give you a bit of an overview of some of the regional challenges, and then Darren will go into some of the detail on the potential solutions. So next slide, please. So all of these challenges, I'm sure you will be very familiar with, and these have been gleaned from the delegated statutory function process, of which I am part of within SPPG, but also what we are hearing from ASW leads and practitioners across the region. And I think Phil has quite aptly articulated in terms of the workforce demands where we're at just now around recruitment and retention. This is wider than ASW. This is a system-wide issue, and we are creaking at the seams in terms of our social work workforce, and that is completely reflected within the ASW workforce as well. We have got an interesting profile in terms of our workforce, females who have other caring responsibilities, and in terms of some of the competing challenges around protracted waits, we're finding a real challenge within the workforce. We have across our workforce sickness and long-term sickness, so that impacts on the service that we're trying to deliver. We have a huge issue around lack of inpatient beds at the moment. We have an unprecedented demand across the region, and you will all be familiar with the fact that we are approximately at 120+% capacity within each of our regional units across Northern Ireland. We are struggling in terms of trying to get beds admission, which is leading to a huge challenge around protracted waits, which has a knock-on effect with our ASW workforce. I was particularly interested, hence my question for Lisa earlier on, in terms of the upstreaming of how we tackle this issue. We could put in a huge amount of resource into creating more beds, but I don't think that's going to necessarily solve the issues that we have in terms of bed capacity. So there is something about how we upstream our services and look at community services in more detail, and I'll talk a wee bit about that later. Risk and safety is a huge issue, safety of workers, and it's great to hear Anya articulating the work that's being done around that area, but also who assesses the risk, who manages the risk. We are very familiar with SAIs that are coming through just now, and Phil again has been involved in that, and looking at what's the role of crisis services in terms of determining risk, and when do ASWs get called upon to make further assessments. So that's something that is becoming more of a regional challenge. We are looking at increased complexity. You'll all know that. You're dealing with it day and daily. And the additional complexity around substance use is also something that we're seeing more and more to the fore. The use of Form 4s in terms of that protracted conveyancing piece, once again, is becoming more increased and more of a challenge. And it's great to hear the work that Paula and Joni are doing in terms of linking with stakeholders and having those very interactive learning spaces, because we do see that there is variations across the region in terms of linkages with PSNI and NIAS in terms of understanding roles, and also an internal piece about how we link the regional out of our service with the rest of the day services across the region. We're very keen to look at the potential of this, and we're starting to talk in that language that this is a 24/7 ASW service, and how we join up better across the piece is something that we want to pay particular attention to. People will also be familiar with some of the challenges around GPs. GPs are extremely pressurized. Another part of the system which is pressurized. Getting GPs to respond in a timely fashion can be difficult due to their own pressures. GPs requesting that visits come out of hours when their surgery ends and the daytime rota ends is another big challenge for our ASW workforce. And all of these challenges in total are really creating a very beleaguered workforce who are struggling with some of these challenges. So it is no surprise that there has been discussion with NIPSA around some of the challenges that the workforce is facing. Next slide. Phil very articulately outlined the challenges. She's stolen our thunder, but in terms of the challenges and the competing demands and the impact that MCA is having on our ASW workforce, it's extremely challenging. And we need to consider how we prepare for the future rollout of MCA in terms of the workforce that we have at the moment. Next slide, please. So with all of this in mind, I'm creating the negative picture. However, there are lots of pockets of optimism amongst this. We need to see all of our services within the greater system. So we are taking a very clear whole system approach to how we identify solutions to the challenges that we face just now. ASW is part of the whole workforce, and we need to consider where the ASW service sits in relation to other services that we have at the moment. Next slide, please. So that really leads us to think again about the other services that impact upon the ASW role with a very clear person-centered focus. And it's so good that we are reminded of this throughout, we've been reminded of this throughout the day, hearing that care's contribution and perspective, but also being reminded of the human rights aspect of all of this through our colleagues in Scotland as well. It's really important that we keep that at our forefront. So with that in mind, we really need to look at how we link our crisis services with our ASW services as we move forward, looking at how we can link in further with our mental health acute inpatient, our learning disability acute inpatient, how we think about upstreaming services so that we have a really well-resourced community provision that prevents that intensive care part of the system being overrun. And looking at discharge with support. I mean, once again, in terms of accommodation, I mean, that's a common theme that comes out across all programs of care, but particularly around mental health, and that we see from our delegated statutory function reporting. Next slide, please. So with all of that in mind, myself and Darren and our ASW Lead Forum are working very closely to start to map the challenges. And we've had a couple of workshops very recently, just understanding in more detail what those challenges look like, how we start to sift through those challenges. So what's local, what's regional, what's within our gift to change, how we need to plug into other areas of activity. And I'm thinking particularly around the implementation of the mental health strategy and other strategies, and what the vision for the future will look like. And that's about connecting to the wider system. But what do we want to look like as an ASW workforce? Next slide, please. So we have been very busy as a group, and I have to say once again, the ideas and the solution focus and optimism that continues to astound both myself and Darren, that comes out of the ASW Leads group, and the resilience. We are focusing on honing in on what are the short-term solutions to some of those issues, particularly the protracted waits. What are the medium and longer term solutions? So how do we plug in with all the other service developments, particularly around crisis and prevention, and looking at what is local and regional, as I said before, with the idea that we will have a very clear strategic plan for the future over the next 1 to 2, 2 to 3, 3 to 5 years on what we want for our ASW workforce and the place that both the profession and the service sits within the wider system. So I'm going to just shut up now and hand over to Darren, who's going to give you a bit more of detail around some of the potential shorter term solutions.
Thank you, Julie. Alisa, next slide, please. So as Julie very clearly articulated the challenges, which we all know really well from a regional basis and from a local trust level, all the challenges, and I'm sure everybody on the call can identify with those. So as Julie rightly says, it was about sifting the challenges as a regional group and then breaking that down into what we see as that immediate and then medium and longer term solutions as we move forward. So, you know, we have been working away in the background, both from an OSS policy perspective and from an SPPG point of view as well. So most people on the call will be aware that the department has been trying as a means to relieve the pressure on ASWs arising from the protracted waits and the conveyance piece. And that's a huge piece at the minute across the region in terms of the workforce that we have and how we're able to kind of manage that and kind of undertake our statutory functions as we move forward. And that's usually on the fact that we're waiting on mental health admission beds. And whilst the issue in relation to acute mental health bed capacity needs addressed, as the root cause of some of the ASW pressures, we have been exploring the more immediate potential supports for ASW that we can kind of look at. I mean, you'll be aware that one of the trusts had sought legal advice about the responsibilities that ASWs had during protracted waiting periods, and they were advised really that the mental health order was silent on this issue completely. So following that, we kind of thought we could kind of build on that as a guidance that would allow someone other than the ASW to wait with the person, whether it was in their home or it was in the emergency department, once they had been assessed by using forms 2 and 3, and that it would also potentially allow someone to be moved to a temporary waiting place other than ED, because we know the difficulties associated with people waiting in ED. However, when we sought legal advice in relation to that, the department's legal advice said they didn't believe that was a lawful basis for such guidance. So we wanted to kind of look at, well, what other possibilities can we explore from a department point of view and something really practical that will support the ASWs in the discharge of their duties. And when I say that, I mean that's both day services and evening services, because both at the minute in terms of our day services and REIFs are experiencing significant pressure in relation to that. So when we started to look at this issue, we really thought that the best solution would be to make an amendment to the Code of Practice for the Mental Health Order of 1986, because the department under Article 111 has the power to amend this following consultation with stakeholders. And by stakeholders, I mean like RECWA and relevant others. However, the difficulty with this as an option right now is that the code of practice needs to be laid before an assembly, and I'm sure we all understand the political situation that we find ourselves in at the minute, but that's not to say that we shouldn't start that work. We prepare that work for an amendment to the code, and it would be ready should the political situation change. And we're very keen that that would give us more powers to do the things that we would want to do to relieve some of that pressure that I'm talking about right now. So that will be helpful moving forward. So what do the department have the power to do, and what can we do right now in the immediate or the short-term piece? So the department does have the ability to make a direction under the mental health order. And we mean by that, we mean who is eligible to be appointed as ASWs. And you may remember that the department done this a couple of years ago. They issued 2 directions under the Mental Capacity Act and the Mental Health Order, which expanded the scope of who could be appointed as an ASW as a temporary measure to address some of those really significant workforce pressures that we're currently seeing at the minute. And that was really key, is what could we do in this area by virtue of a direction. So we are currently exploring this option by making a similar direction as a temporary measure to address the pressures associated with these protracted waiting periods. So what would the proposal be? So the proposal at this stage would permit social workers who had certain level of post-qualifying experience and post-qualifying professional development to be appointed as an approved social worker. And we would only permit them to take on the conveyancing responsibilities, because what we didn't want to do is we fully appreciate that ASW has a significant role, and it's a very protected role, and rightly so it should be, but it's around how do we kind of manage the pressures around that protracted rates and conveyancing. We would provide this specific group of staff with training, and we would develop that training in relation to the conveyancing and how best to manage those waiting periods. It wouldn't provide all the options that we would want to, but it would help in terms of providing a larger pool of people who could swap with the ASW who made the assessment for admission when facing like protracted waits, which is happening across the region as it currently stands. So it really is that piece that we're really trying to focus on in the immediate period. We find it would be particularly useful in race as well, because protracted waits tend to be more of an issue out of hours. If we train some of the race staff, and we looked at our ASW candidates, and we looked at those with relevant training, we believe this could increase the significant pool of staff that could be identified by a direction as an ASW to kind of free up ASWs in other parts of the system when they need to do assessment. So at this stage at the minute, what's happening now? So Anya has gone out to the executive directors of social work at this point in time to ask if they would be willing for OSS to pursue this as a viable option for ASWs across the region. And what would that look like in terms of training needs then moving forward? I would then take up that along with Julie. I would then look meeting with the ASW leads across the region to look at what that would look like in terms of the training aspect of this role. What would that look like for people who need that training, and how would we take that in terms of implementing this as a viable direction? So, and we also then would need to take that back then to DSO to approve that final direction. So it's really important that we include all the leads across the region in relation to undertaking this direction. So that's one of the short-term pieces that's out there at the minute. It is currently sitting with the executive directors, and we're hoping to hear feedback in relation to whether or not trusts want the department to pursue this. Should they do that, I will then set up a regional leads group to kind of take this work forward and how we would issue this direction. Next slide, please, Rachel. So that's the short term. So some of the medium and longer term solutions would look like the increased workforce, so increased numbers in the ASW programme. And it was great to see this year the increased number of ASW candidates that we have. I think we have 38 at this point in time, which is significantly an increase in last year. Some of the stuff around funded places we're going to have a look at as well. Working with trusts to kind of look at, has all options be explored by health and social care trusts? I mean, this year I know some of the trusts across the region were able to look at their learning and development budgets in relation to getting an increased number of ASW candidates on the course, which has been extremely helpful and actually really solution focused by all the health and social care trusts, and we really, really welcome that. Some of the other ones is around alternative ASW models, some of the hub-based model in line with ASW quality standards, I mean, I've been out and I have spoken with and met with all the other trusts as well around their hub models and the nuances around their hub models, but clearly wanting that to be a standard moving forward in terms of how we deliver the ASW service across the region. And that would be really helpful, because then we can start looking at stuff like ASW support workers across the region. Would that be helpful as part of that hub model? And would that provide us with the benefit to the work that we're also doing as well alongside the direction? So commission, and I know Julie touched on this earlier on and very well, associated with the change in service delivery, that will always factor into the work moving forward that we're currently doing with all the leads moving forward. The revision of the codes of practice under Article 1, I've touched on that in my previous slide. I mean, that is a piece of work that we're looking to take forward. Obviously, it's going to take a wee bit longer in terms of doing what we want to do in relation to the codes of practice, but ultimately it would give us a wee bit more scope to kind of undertake that work. And the regional ASW Strategic Advisory Board, I mean, we agreed at the last couple of workshops that we would look at this as a kind of replacement to our Leads Forum, which we think will be really helpful, because it's going to allow the ASW leads and with their ASWs to kind of really look at feeding into that strategic planning for ASW service moving forward, and what they see are the issues, what are the challenges, and actually coming to grips with some of the real practical solutions that we feel is going to start to ease the system in relation to the pressures that we're currently facing. So that's going to be a feature of our next kind of workshop, is the Strategic Advisory Board. And what we felt would be really helpful, and it's kind of been touched on throughout this, is bringing the right people into that forum at the right time. So it's stuff like while it would be ASW, we would bring in our inpatient bed managers, we would bring in crisis when we need to, potentially we would bring in the PS. Now, at certain points of time, as we start to plan for what we want the future to look like and what stakeholders we need at that table at the right time in the right place to affect any type of change moving forward. So I suppose that's some of the short, medium and longer term solutions that we're currently working on at the minute. And I just felt it was really important that we were transparent and we're able to share this with you as a group of ASWs today, and with the candidates who are going to be impacted on this as we move forward as well too, or potentially impacted on. So it's great to see so many of them has attended today, and the turnout's been absolutely great, to have to say. So look, I mean, that's next slide, Rachel. I think that's me from my, so that's my bit from a solution focused point of view. Clearly, there is a significant amount of work to be done, but we're not going to shy away from it. And I know the ASWs will not shy away from this as we move forward, nor will the candidates as they enter into the new area of their career in terms of becoming ASWs, which is really, really important.